So, madam, I invite you to judge this session. Garima, madam, I invite you to judge the session with Dr. Smita Pandya and Dr. Shashwat Jani.
Okay.
Smita, Dr. Smita, madam. Jani can't hear. Welcome, Sunita, madam, our second judge for this session. Dr. Shashwat is also on the way, uh, SVP Hospital, so he is joining in 3 minutes. Madam, checking. Garima, madam, क्या क्या?
I'm here only, sir. I'm here.
Garima, madam.
Yes, sir. Yes, sir. I'm here with you.
Yes, and Sunita madam has also joined. Dr. Shashwat is on the way. He's at SVP Hospital, so he's having some little difficulty in reaching. So perhaps if everybody is ready, can we start, madam?
Yes, sir. Please.
Sunita madam, have you joined? Sunita madam? આપણે આપણે અનમ્યુટ થયા નથી મેડમ. મેડમ જોઈન તો થઈ ગયા છે. થેન્ક યુ. ના બસ બે જણા જોઈન થયા છે. શાશ્વત join. Garima madam.
Yes, sir.
Yes, madam. Sunita madam has also joined. So we can start session. Dr. Jani, Shashwat Jani will join in, soon. So
Sure.
I think so we invite our first presenter. So I'm welcoming you, Dr. Garima Gandhi madam and Dr. Sunita Yatrik Pandya madam. Welcome you, and we are honored that you are being our judges for the session.
Thank you, sir.
Yes. I'm inviting the first presenter, Ripple Jala. She is logging. Ripple, you can unmute yourself and you can start presenting, sharing the slides, your paper. Ripple. ચાલો એમની ચાલુ કર્યું ને એક ચાલ લઈને બેસી જાઓ ટેબલ લઈને બેસી જાઓ. Ripple, yeah, you can start your presentation. आप शेयर कर सकते हो. Yeah. Question of consciousness में भी तो unmute check रहा है. Hello, Ripple. Yes. You are unmute. Ripple, unmute yourself. Unmute, just unmute. हाँ. Ripple, you are not audible. Somehow, some issue is there. ऑडियो में जाके उसमें सिलेक्ट कर दो आपका जो भी है स्पीकर या फिर आपका जो ब्लूटूथ लगा है उसको.
Hello.
Yes. Now you are audible, but there are other devices connected.
Yes, sir.
Only one device should be connected. Or yeah. Welcome,
Hello.
Garima madam.
Yeah, thank you, sir.
अच्छा ठीक है हमने
Hello. May I be audible, sir? Hello.
Yes, you are audible.
Yes, sir.
Yeah,
Good
you can
morning,
start.
everyone. Good morning, everyone. Myself, Dr. Ripal Zala, a second year resident from OBGY department, Government Medical College, Bhavnagar. I am presenting the case of severe immune thrombocytopenia in pregnancy under guidance of Dr. Mayur Gandhi, sir, head of Department of OBGY in Government Medical College, Bhavnagar. Introduction. Immune thrombocytopenia is an autoimmune disorder characterized by isolated thrombocytopenia less than 1 lakh platelet counts. It complicates approximately 1
Just
to
one
2
second.
per
Just one
thousand
second. Hold,
pregnancies.
hold, hold, hold. Can we see the slides also?
You can share the slide from your laptop.
Because it is a
Uh,
poster presentation, so slides are important to be seen.
yes, yes, ma'am.
There is an option of share from below.
Yes.
Yes. Yes, it is visible. Just
Uh, okay.
yes.
Introduction. ITP is an autoimmune disorder characterized by isolated thrombocytopenia less than 1 lakh platelet counts. It complicates approximately 1 to 2 per thousand pregnancies. It increases the risk of maternal hemorrhage, need for blood product transfusion, and neonatal thrombocytopenia. Objectives. First, early recognition of maternal and fetal risk. Objectives. Early recognition of maternal and fetal risk. Second, optimize the platelet counts before delivery. Third, role of multidisciplinary management. Case summary. A 34-year-old female, third grade para 1 A1 L1 at 38 week 4 days gestation with previous LSCS and known case of chronic immune thrombocytopenia. First visit presented to our institute at date 16 April with 36-week 2 days pregnancy and altered lab reports shows platelets 25,000 with normal USG reports. She had a history of ITP in previous LSCS 14 years ago in view of NPOL and patients was on steroid resistance, then bone marrow biopsy done. Evans syndrome is there. Cyclosporin tablets started. Patient refractive to cyclosporin tablet, then open splenectomy done 6 years ago. As per hematologist opinion, platelet transfusions and IV methylprednisolone given and intensive maternal fetal monitoring is done. On second visits, patient present at 27th April with 38-week 4 days gestations with abnormal lab reports. Platelet shows 1000 and USG report shows IUGR and oligohydramnios. With clinical features shows ecchymosis at knee areas. In current pregnancies, platelet counts progressively declines to approximately 1000. So we did hematology consultations for further management. They advised for IV methylprednisolone, immunoglobulins, platelet transfusions, and intensive maternal and fetal monitoring. Plan. As USG reports were showing IUGR and oligohydramnios, we decided to terminate the pregnancy. Uh, we counsel the patients and their relatives for emergency LSCS. And so after optimizing the platelet counts by platelet transfusions, 10 PC and IV methylprednisolones, we did C-section and delivered healthy female infant weighing 2.5 kg with normal platelets counts. In postpartum, we give 1 SDP to the patient and continue steroids. We discharge the patients with 4 lakhs platelets counts with healthy mothers and baby. A role of multidisciplinary actions. As per obstetrics, timely obstetric intervention, surgical planning for emergency LSCS, and managing oligohydramnios and IUGR risk. As per hematology, platelet optimization, IV methylprednisolone administration, and managing chronic post-splenectomy ITP. As per anesthesiologist, managing extreme bleed risk during delivery, ensuring hemodynamically stability during surgery. As per neonatology, immediate neonatal evaluation post-delivery, managing risk of IUGR, and monitoring and management of neonatal thrombocytopenia. Maternal outcome. No major intraoperative or postoperative hemorrhage, Mother remains completely hemodynamically stable throughout the procedure. Discharged safely with scheduled hematology follow-up. Neonatal outcomes. Successful delivery of a live baby. Navigate IUGR and 33 weeks, 4 days, weeks prematurity safely. Discharge for ongoing and specialized neonatal evaluations. Clinical relevance. Severe ITP in pregnancy can be managed successfully with timely diagnosis and multidisciplinary care. Optimization of platelet counts before surgery is crucial. Early hematologist involvement and availability of blood components improve maternal and fetal outcomes. Conclusion. A coordinated multidisciplinary approach is a key to achieving favorable outcomes even in pregnancies complicated by profound thrombocytopenia. Hope is stronger than thrombocytopenia when multidisciplinary based care guides every steps. Thank you.
Good job, Ripple. Your slides were good. You presented confidently.
Thank you, ma'am.
We can proceed with some questions from the permission of the chair. So,
Yes, yes, ma'am.
so when do you think you want to give platelets in a patient of ITP when she's pregnant? What is the right time to give platelets?
When there is a when platelet counts goes into below 10,000, ma'am, then we can give a platelet transfusion. And there is a symptoms like bleeding, PV, and any other sides bleeding is there.
Okay. This patient was a case of previous LSAS, so you directly decided for LSAS. But suppose she was a primey who presents in labor and she wishes to have epidural analgesia. You check her platelet counts and it comes to be, say, 25 to 30,000. So, what will be your advice in such patients? Did you get my question?
Sorry, ma'am. Can you repeat,
I'll
ma'am?
repeat. I'll repeat.
Yes,
A
yes,
primary gravida with ITP presents to
yes,
you in labor, say at 38 weeks. You
yes,
check
ma'am.
her platelet counts, it is 25,000. She
Yes,
wants
ma'am.
epidural analgesia for her vaginal delivery. So,
Yes,
what
ma'am.
is your advice?
Uh, uh, First of all, we optimize the platelet counts, ma'am. 25,000 is a very low platelet counts for epidural anesthesia, ma'am. Uh,
Epidural analgesia. So, what platelet counts do you target
of above 50,000, ma'am.
for epidural analgesia?
Yes, ma'am. 40 to 50,000, ma'am.
You
What
sure
is the
about it?
cutoff value actually?
Hi, Dr. Shashwat.
Hello. Ripple, what is the cutoff value?
Uh,
If
for
you are planning for
epidural, yes.
epidural anesthesia, if you are planning for normal vaginal delivery without epidural anesthesia, and if you want to go for C-section for any
Yes.
emergency obstetric indication, so what are the cutoff value of platelet count in this type of cases?
Uh, in our case, sir, our anesthesia decide to more than 50,000
No, as
is
a
needed.
obstetrician, you have to also decide. Yes, you are right. Anesthesia has to decide, but oral bleeding you have to control. So, what is your plan of action? What is your cutoff value ideally?
Uh, for LSCS, sir, in spinal anesthesia, there is a 80,000 is there, sir.
Hmm. Okay.
And in epidural anesthesia, sir, there is a 60,000 is there.
Okay.
Yes, sir.
Okay.
You said your patient had splenectomy. So, a patient who already had a splenectomy, what are the risks for her, pregnant or not pregnant?
Uh, After splenectomy, there is a more chances of infections.
Okay, so what
Uh,
should you do before pregnancy? Suppose such patients comes to you in preconceptional period. Do you advise anything specific in this context to avoid infections during pregnancy?
uh,
અને બંધ કરે પોસ્ટ નથી કરો કાઢ નાખ.
Are we particularly concerned about any type of infections which screen could possibly avoid, and we can do something to avoid those infections for the mother because they can be very
uh,
serious things?
yes, sir. Ma'am, Haemophilus influenza, we can. capsulated organisms like Haemophilus influenza. Then risk is more in pregnancy.
So what can you do for encapsulated organisms and for Haemophilus
So we
influenza?
can vaccinate the patients before conceive and in
Which
first
vaccine?
visit.
Which vaccine?
Uh, Haemophilus influenza vaccines.
So you can give it during pregnancy?
Before pregnancy, ma'am. Before conceiving,
Flu vaccine
not
cannot be
during
given
pregnancy.
during pregnancy. We cannot give flu vaccine.
Yes, yes, ma'am. Can be given.
Yes. After how
Which
many weeks?
After how many weeks? In first trimester, there is
Can you give in first trimester or second or third?
in second trimester, sir. Because first trimester is most organogenesis is occurs in first trimester, so it's safer in second trimester.
Okay.
the
Yes.
vaccines for
Uh,
encapsulated organisms? When
May
do
I
you want to?
interrupt, Madam, Sir?
Yeah. Yes.
Yes,
Madam,
Viral.
actually, like we have 6 minutes for the presentation and two
Okay.
minutes
Sure.
for
Sure,
the
Viral.
questions
Okay,
answer.
Dr. Vidal. Dr. Vidal, thank you
So
for.
sorry for that, actually.
No, no,
And beyond that, this is 5 minutes. So just like I want to ask, like not for this case. So when you want me to like tell you about the timing, if you want.
I, I think as
Whatever
soon
you
as
have decided. Whatever you have decided. Viral.
Sir, we will do one thing like when they will present 6 minutes, then we will intimate you, and when there
Okay.
is a more
Sure.
than 2 minutes, we will just intimate you. Then you can decide on your own. That's all.
Okay. Sure. Sure. Sure.
Okay, sir. Thank you,
Thank
madam.
you. Thank you, Ripal.
Okay, thank you, sir.
Smith Patel. So now we are going to take Smith Patel as a co-host, and he is going to present. Am I right, Smith Patel? Are you ready? Just we will make him co-host. Yes. Give me a moment. Yes, Smith Patel, are you ready? Yes. So, respected judge, can we make him start by
Yes. Yes.
sharing?
Sure.
Yes. So, Smith Patel, share your the slides, and
Yes,
you can start your time.
yes. Can I start, sir?
Yes.
Good morning, everyone. Myself, Dr. Smith Patel, second year resident from Department of Obs and Gynae from Government Medical College, Bhavnagar, under guidance of Dr. Kanaklatan Nakum and Dr. Mayur Gandhi, sir. Want to present a case beyond the ovary, a true broad ligament angiolipoleomyoma masquerading as an ovarian neoplasm. Introduction. Leiomyomas are most common benign tumors of female genital tract. However, true broad ligament leiomyomas are rare. Extrauterine variants accounting for less than 1% of all leiomyomas. Because of their location adjacent to the ovaries and adnexal structure, these tumors often present a significant diagnostic challenge and may closely mimic a ovarian neoplasm. Degenerative changes within the tumor can further complicate radiological interpretation, leading to suspicion of malignancy. Angiolipoleomyomas are rare histological variants characterized by smooth muscle tissue admixed with mature adipose tissue and prominent blood vessels, which is exceptionally uncommon in broad ligament. We report a rare case of true broad ligament angiolipoleomyoma in a perimenopausal woman that masqueraded as an ovarian neoplasm, highlighting the importance of considering this entity as a differential diagnosis of complex adnexal masses. Case presentation. A 51-year-old para-3 live-3 woman with controlled hypertension presented with progressive lower abdominal pain and heavy menstrual bleeding for 2 to 3 months. Clinical examination revealed a firm, mobile, left adnexal mass distinct from the uterus, raising a strong suspicion of ovarian neoplasm. pelvic examination demonstrated a bulky uterus with firm mobile left adnexal mass exhibiting a distinct groove from the uterus, and the cervix was healthy on speculum examination. Serum tumor markers were within normal limits, although malignancy could not be excluded based on the clinical and radiological findings. The patient was hemodynamically stable and was therefore planned for surgery with a provisional diagnosis of benign or malignant ovarian mass, with the final diagnosis established on histopathological examination. The pre of MRI findings were lesion lobulated T2 hyperintense mass located in the left adnexa. Left ovary was not seen separately from the mass. Impression was highly suggestive of left ovarian epithelial neoplasm. Intraoperative findings and final impression. Exploratory laparotomy revealed a well-circumcised encapsulated 8 into 8 centimeter left broad ligament mass, distinct from the uterus and left ovary. The lesion was predominantly solid with well-defined cystic component, giving a solid cystic appearance, and was moderately avascular. The uterus and bilateral ovaries were grossly normal. No ascites, no omental deposits of pelvic or para-aortic lymphadenopathy were identified. Intra-frozen section was sent and reported negative for malignancy, and TAH plus BSO plus partial omentectomy was done. On histopathological finding, the excised mass showed a well-circumcised benign mesenchymal tumor with characteristic triphasic morphology of smooth muscle, adipose tissue, and thick-walled vascular channels without cytological atypia or mitotic activities. The findings were confirmatory of primary broad ligament angiomyolipoma. Discussion. Primary broad ligament angiomyolipoma is an extremely rare benign mesenchymal tumor that can closely mimic an ovarian neoplasm due to its adnexal location and solid cystic appearance. Despite negative tumor markers, preoperative differentiation from an ovarian malignancy remains challenged, and imaging is often inconclusive. Intraoperative finding of well-encapsulated mass separate from the ovary, along with histopathological demonstrating smooth muscle, adipose tissue, and vascular channels, establish the diagnosis. Complete surgical excision is both diagnostic and curative, with excellent diagnosis and very low risk of recurrence. This case underscores the importance of considering rare blood ligament tumors in the differential diagnosis of adnexal masses, even when clinical and radiological findings strongly suggest an ovarian tumor. Conclusion. This case highlights the diagnostic challenge posed by rare broad ligament tumors presenting as adnexal masses. A high index of suspicion, meticulous intraoperative assessment, and histopathological confirmation are essential for accurate diagnosis and appropriate management. And finally, the final diagnosis is sometimes made not by imaging, but by surgeons' vigilance and pathologists' confirmation. Thank you.
Very nice presentation. Nice case.
Completed well in time. So, Dr. Smith, if you were operating this patient who is having a broad ligament fibroid or some mass in broad ligament, we don't know the histopath yet. So, what are the precautions you will take during this surgery?
Sir, we will depend on the age of the patient. Yeah, we will plan if we send the intraoperative frozen section, and if it comes out to be positive, then we will go for a staging laparotomy.
I get it. But before you remove the tumor, you have just opened the abdomen, you have started doing this surgery. Is there any particular precaution during surgery you take to avoid some particular complications in case of a broad ligament mass? Yeah.
We will separate the retroperitoneum to keep the ureter away from the field of dissection.
So can you tell me the possible sites where ureter can get injured during surgery, this surgery?
Mainly, ma'am, it is near where there is a passage of ureter. It's the most common site of injury.
Where? Can you come again?
Near where there is a passage of uterine vessels above the ureter.
Okay. Have you heard of true broad ligament fibroid and false? Have you heard of true broad ligament fibroid and false broad ligament fibroid?
Yes, ma'am. True broad ligaments are the fibroids which originate from the subserosal surface of the uterus, and they will push the ureter laterally. and the pseudo broad ligament fibroids originate from the broad ligaments. So they usually push the ureter medially.
Is it the other way around?
Yes, ma'am. Sorry.
Okay, what are the other sites of ureteric injury during hysterectomy? What are the other possible sites of ureteric injuries during panhysterectomy especially? Sites of ureteric injury other than this.
Other than this, ma'am.
It's the
Any
most
patient.
common question asked in
Near the UV fold,
PG exam.
sir, near the UV fold, it can be
Your patient had a
injured.
panhysterectomy, right?
Yes, yes, ma'am.
So I'm giving you a clue to think of the sites of ureteric injuries.
So near the when we apply the first clamp near the corneal end, it can be injured. Then near the isthmus.
Can you describe the course of ureter in the pelvis?
Course of it usually is near the retroperitoneum. Then it comes with the uterine vessels near the isthmus where it is water under the bridge, ma'am. Then it comes under the ureteric vessels, and then it goes down towards the trigone
Okay,
of.
Dr. Shashwat sir, if you want to ask any question.
What are the any specific markers you want to do it pre-operatively in this patient?
Sir, in this patient, we did CA1, CA19-9, CA125, and CEA. But for the angiomyolipoma, we could have done, sir, Desmin, S100, CD34.
Is there any role of serum LDH pre-operatively when you don't know the diagnosis and you have this suspicious mark?
Yes, it can be done for.
Why?
Sir, ovarian tumors sometimes show LDH.
LDH is not for the ovarian tumor. Your diagnosis was not confirmed no? Pre-operatively.
Yes, sir.
That's why. Okay, how will you follow up this patient? If
Sir, after the histopathology, sir, it is benign, so we will not need any chemo or radio, sir. So we will just keep 6 monthly follow-up for this patient.
okay, okay, ma'am. If you want
Yes,
to
sir.
ask.
Yeah, we are done. We are done, sir. I think more than 2 minutes are over.
Yeah.
Dr. Viral, sir, we can proceed to the next student.
Yes, madam. Okay. Now the turn is Dr. Krunal Mothalia. I think he is there with Dr. Smith only. Yes, Dr. Krunal. Can you listen us?
Yes, yeah. Hello.
Yes. So, madam, can we move forward, right? And Dr. Krunal can present his slides, and we can start your time once you
Yes.
start your slides.
Timing फिर restart करो क्वेश्चन.
Dr. Krunal, is there any difficulty?
नहीं share
Hello.
करो.
Yeah. Yes. We are about to see your slides. Till now, there is no slides.
Okay. Good morning, everyone. Myself,
No, no.
Dr. Kunal.
Dr. Kunal, we
Yes.
cannot see your slides.
Uh,
You do the double click to enter the full screen mode. We cannot see your slides. Might be some network connection issue, I don't know, but
Should I present?
you can do that. You have to do that.
You have the slides.
is my slide visible?
No, till now not. We will try from our end. Just wait.
It's showing your screen sharing is paused.
Yeah, we have done from our end. I think we will share from our end. That's why actually it is done. Just our technician, like backend team, is trying for that. Just wait for 1 minute.
Okay.
Here we can also. No, still not visible. Madam, can you see slides or
No,
it's
no, we cannot. We cannot.
yes, yes. Can we do one thing? Just we will remove him, we will make him again, and then we can start again. Okay, okay. Just now we are doing. Now we are doing from our end. Yeah, now screen is visible. Make it large. So, Dr. Kunal, what we can do when you want to change the slide, just say next. From here, we
Okay.
will change. Okay.
Okay.
Okay. Fine. So you can start now.
Okay. Good morning, everyone. Myself, Dr. Kunal Muthalia, a second year resident from Department of Obstetrics and Gynecology, Sarti Hospital, Bhavnagar, Government Medical College, Bhavnagar. I am here to present my case, which is pulmonary embolism, tachycardia to obstetrician. Placental abruption complicated by IUFD is frequently associated with disseminated intravascular coagulation, a major contributor to maternal morbidity and mortality. Prompt recognition and excessive aggressive correction of the coagulation can reverse DIC. However, critically ill postpartum women remain at high risk for the thromboembolic complication. This case highlights successful correction of DIC but subsequent fatal pulmonosis in obstetric critical care. Next slide. Next slide.
Good morning, everyone. Myself, Dr. Abdul, second year resident doctor from
I am here to present a case of maternal mortality following pulmonary embolism complicated by placental abruption, DIC, and messy postpartum vulvovaginal hematoma, and to highlight the importance of early recognition, timely intervention, and multidisciplinary critical care in preventing adverse maternal outcome. Next.
They remain undiagnosed throughout the pregnancy. The serial antenatal ultrasonography to pregnancy.
Placental abruption complicated by disseminated intravascular coagulation is a life-threatening obstetric emergency requiring prompt resuscitation and massive transfusion. Following correction of hemorrhage and coagulopathy, postpartum patients remain vulnerable to thromboembolic complication because of the physiological hypercoagulable state. This case highlights the successful management of the DIC and vulvovaginal embolism, emphasizing the importance of continuous thromboembolic remains even after performing clinical examination. Next slide. 28 28 years old, 29 with 3 years gestation was with between 2 years and Medicine see occupation typically finished and critical conditions with option of this. Or medicine see people sitting with 2.5 to 2.8 to still 1. On every side, I'm going to put my own visiting word in, see him to the preliminary that I'm going to. I'm going to have massive below whether
Somehow I can't hear it. If Dr. Shashwat is able to hear, it's good. I'm not able to hear clearly. It's not clear. The network issues there, I think. And Dr. Shashwat, sir, can you hear him clearly? Because I can't. Dr. Viral, sir, I think there are some network issues. Voice is not clear at all.
Okay, madam, I think we can listen properly. Or
Someone
we
has
we can
unmuted me.
listen it properly, madam. Shashwat sir, can you listen it? Listen him
No,
properly?
no, no,
No.
no.
Okay. So slides and all thing is good, right? So Dr.
Yes.
Slide
Kunal,
is
can
good.
you come to the good network and start from where you left actually?
Okay, sir. You want to fold it on?
We'll pause this time.
I'm audible now?
Yeah, you are audible now.
Yes. 28 year, uh, 28 year old, Universal Central also after preparing with pregnancy. The session was referred with IUFD and suspected facility manager. The admission she had hypertension,
Sorry to interrupt, Dr. Krunal. Madam and sir, is he audible?
No, no,
It's
not
audible. It's
clearly.
very unclear. Very
Not clear.
Oh, here, like, can we do something? Okay. Dr. Kunal, can you speak loudly if possible? I don't know. Not audible.
I am audible now, sir.
Yes, now it's audible.
Yeah.
Okay. Okay.
So let our judge say, are you
Yes,
audible?
yes, audible, audible.
I'm
Okay,
okay,
then
sir.
go ahead.
Audible. Yes.
Okay. A 28-year-old gravida third para to lab 2 at 39 week 3-day gestation was referred with IUFD and suspected placental abruption. On admission, she had hypertension, tachycardia, icterus, and had a tonically contracted uterus with absent FHS. On admission, she was 2 centimeter dilated, and within 2.5 hours, she delivered vaginally a 2.8 kg stillborn baby. Her INR was 2.1, so episiotomy was avoided, but she had first degree perineal tear after delivery. In that, she developed a massive right-sided vulvovaginal hematoma requiring surgical evacuation. After that, she again developed hematoma at the same site after 6 hours of previous evacuation. So under GA, it was again evacuated and drain was kept at site. Patient was then intubated and kept on mechanical ventilation and was given total 7 RCC, 5 PC, 21 FFP. The patient was stable and improved.
I think he is muted. Dr.
Not
Kunal,
audible.
I think you are muted.
Yeah, not audible.
INR came back to 0.9112 post-op day. Her all blood investigation came back to normal limit by 13 POD. Jaundice resolved. Bilirubin was 2.5 milligram per deciliter. So she was planned to discharge at home on next day with oral medicine and follow-up to be advised after 7 days. Next, on her 14th POD, she complained of sudden breathlessness while walking at 11:40 p.m. So she was kept on NRBM 14 liters O2, but still not maintained O2 saturation. So urgent physician, anesthesia, and TB test department references were done. Anesthesia kept her on BiPAP and shifted to ICU on physician's advice. After 1 hour, she was again intubated and kept on ventilator. And inotropic supports were given, but her BP and pulse were not recordable. On next day morning, the pre-decided day to discharge her at home on 15th POD, she was declared dead at 9:55 a.m. Next slide, please. This case emphasizes that pulmonary embolism can be a terminal event in patient recovering from severe obstetric complication. Despite aggressive multidisciplinary management, the patient developed progressive respiratory failure with clinically suspected pulmonary embolism, leading to cardiogenic shock and maternal death. Early risk assessment, prophylaxis when appropriate, and prompt recognition of pulmonary embolism remain crucial for reducing maternal mortality.
So, did you confirm the diagnosis of pulmonary embolism in this patient, or was it a clinical diagnosis?
Ma'am, it was a clinical diagnosis. Patient's relative were not willing for postmortem.
Okay. If the patient is alive, what are the ways of confirming a diagnosis of pulmonary embolism?
Ma'am, clinically, a patient will be having tachycardia, complaints of tachypnea, breathlessness, and
What does ECG show in pulmonary
respiratory saturation.
embolism? ECG findings in pulmonary embolism. Do you know any radiological investigation which can confirm pulmonary embolism?
Radiological investigation, ma'am. CT can be done, ma'am.
Any CT, or is there any specific CT?
HRCT.
HRCT?
HRCT or any specific?
This specific.
Any particular CT scan which shows the pulmonary vessels having an embolism?
CT angiography, CT pulmonary angiography.
And
Okay.
how will you treat if confirmed? Is there any procedure?
Sir, thromboprophylaxis could be given, sir.
What is the meaning of thromboprophylaxis and what is the dose of the drug in that?
Sir, patient was started on injection enoxaparin and low molecular weight heparin can be started.
What is the prophylactic dose and what is the therapeutic dose?
So, LMWH 40 LMWH ma'am 40 milligram could be given.
In this patient?
Sorry, ma'am.
In this patient, that is the dose you'll recommend if she was alive?
Yes, this is starting dose, ma'am. We can give this dose once a day in OD.
Sunita ma'am, any questions you want to ask?
Yeah. What is the admission to delivery interval in your case?
Admission to delivery interval was 2.5 hours, ma'am.
And what product you have given before the delivery? Is there any
Before the
role of
delivery, ma'am,
yeah. See?
ma'am, according to massive protocol transfusion, PC, FFP, and RCC could be given in 1:1:1 protocol, ma'am.
At the time of admission, you know that the INR was 2.1. So, ma'am was asking that how many products you were given.
In how
At the
many
time of
times?
admission, two FFP and two PC were given to the patient.
Okay.
2 FFP and 2 PCV. INR of the patient
Yes,
is
ma'am.
2. So what blood product you will prefer to give first?
Ma'am, cryoprecipitate.
Good. How many?
Ma'am, in this patient, we have given total 2 cryoprecipitate.
Are you sure only 2 cryoprecipitate is given?
For delivery, ma'am,
Okay, no further questions.
Okay, Viral bhai, we can finish.
Okay. So thank you, Dr. Krunal. Thank you for your presentation. So we
Thank
will
you.
go ahead
Thank
and
you.
you
Thank
can
you, sir.
now discontinue if you want to. Otherwise, you can continue with us. And now we are inviting Dr. Hina Popat. And madam, are you available over here? Yes, Dr. Hina has just joined here. So, madam, am I audible to you? Dr. Hina.
Good morning.
Good morning, madam. Are we audible to you?
Yes, yes.
Okay, madam. So, can you share your slides and we can start? All are online.
I have already given my slides. Yes.
Okay, madam. So we will present. I thought like if you want to share, we can share. Okay, just give us the moment.
Yes.
Please share Dr. Hina's slide. So, madam, here like we will share the slide from our end. But when
Yes.
you want to change the slide, just say next. We will change the slides from here. Okay, madam. So
Yes.
give us the moment. Just within a 1 minute, our like backend
Definitely.
team will share.
Definitely. Definitely.
Dr. Hina madam, we'd like to see you also.
Yes.
Yeah,
You are
madam.
also
You have
there.
to yes.
Yes, I am starting my video.
Yes.
Morning.
Good morning, madam. Share karo. Share karo.
Good morning, Hina madam.
Good morning, sir.
Yes. Now we are online, madam. Can you see your slides?
Yes, yes,
Do some zoom, please. Yes.
yes,
Okay. So can we start, madam, and judge?
yes, yes. Yes.
Okay.
Uh,
So here
this,
your 6 minutes starts now. Please start, madam. Okay.
this is a case presentation of collodion baby. Me and my assistant, Dr. Rushabh Seshpal, has done this poster presentation. In introduction, I would like to tell you that collodion baby is a rare neonatal presentation characterized by shiny, tight parchment like membrane covering the entire body at the birth itself. The incidence is approximately 1 in 50,000 to 1 in lakh live births. The objective of presentation of this paper is to present a rare case of a collodion baby, to discuss and diagnose the neonatal management, to review the complication and prognosis. Case present starts the maternal history. She is at age 32 years. Second gravida, para 1, live 1. Previous obstetric history is normal delivery. She had one child, which was very normal, nothing delivered by me. Next, please. Yes. One full-term male delivery, consanguinity, non-consanguineous marriage. She is not consanguineous marriage in. Her antenatal history was, she had a regular antenatal visit every month by me. I show her every month. There was no history of any teratogenic drug exposure or X-ray exposure or any other material she has taken. No significant maternal infection during pregnancy. Anomaly scan were normal. Her birth history, delivery, obstetric history. At the age of gestational age 37 weeks, term size, she came with leaking PV and delivered within 6 to 7 hours by vacuum assisted vaginal delivery. There was no meconium, there was no apnea, nothing. She cried well, and birth weight was 3 kg. Neonatal finding at birth where the baby was covered with, next please, just scroll up. Yes. At birth, the baby was covered with a taut, shiny, yellowish membrane, suggestive of a collodion membrane. Clinical features were generalized parchment-like skin. Ectropion was present, flattened ears. Next, please. Restricted limb movements. Neonatologist examined this, and he had seen the previous one baby and of this fully collodion baby. So he's instantly diagnosed that this is a collodion baby. Differential diagnosis, though they put, was laminar ichthysosis, congenital ichthysosis, form of erythrodermia, Hurlin ichthysosis. Investigation were done. She was admitted in NICU, and skin specialist visited the NICU, and they went for CBC, CRP, routine sepsis screen, blood group, etc. Management was given in NICU care, continuous monitoring, strict aseptic protocols, maintenance of thermoregulation and hydration. Skin care was provided, frequent application of liquid paraffin, emollients, gentle handling of the skin. Supportive care were also given. Baby was admitted for 3 to 4 days there, and all the neonatal skin care and supportive care was combined with skin specialist and neonatal specialist. Special counseling were done to the parents and general family members about how to care this baby in future also. IV fluids were given, electrolyte monitoring and correction was given, nutritional support, psychological support were given. Next, please. This baby didn't had any complications. Baby went home after 3 to 4 days with good condition, but complication may arise of dehydration, sepsis, hypothermia, electrolyte imbalance. So discussion usually it is inherited as an autosomal recessive disorder, membrane typically shared over 2 to 4 weeks, may evolve into laminar ichthyosis or congenital ichthyosis form erythrodermia. Early neonatal intensive care significantly improve the outcomes. Prognosis depends on the underlying ichthyosis type, prevention and treatment and infection, early NICU support, and future. Always this baby has to be taken care by weather support. This baby should not go in sunlight. There should not be any infection. There should not be any outdoor games by this baby. There is a lot of consideration of future and psychological support and care has to be given. And baby were family and parents were counsel about this. Next, please. In conclusion, this is a rare but important neonatal dermatological emergency, requires multidisciplinary management involving neonatologist, dermatologist, pediatrician, and genetic counselors. Early supportive care can markedly reduce the morbidity and mortality. References are being taken from Nelson textbook of pediatrics, Every Disease of Newborn, Flipscart Dermatology, and Congenital Ichthyosis in Collodion Baby. Picture has been shown in this poster also. Now this baby is 1 month old and baby is doing fine. There is no problem. Parents have been counseled properly how to take care of this baby till it grows up. Thank you.
Very new case, ma'am.
Yes.
Very nice done, yeah.
That is why I thought of presenting it. I am seeing for the first time, but neonatologists and dermatologists had seen this type of baby twice in their career.
So you are lucky, ma'am.
Yes.
So, ma'am, what is the genetic basis of this disease? Like autosomal recessive, we get it, but
Recessive, yeah. So this is her second baby. So I think if they plan for third one, we will go for genetic counseling first.
any particular genes which are implicated in this?
No. We have to do genetic testing of parents first, which genes are involved first, then karyotyping of parents will be done, and then according to if they plan third baby, we'll go for after 13 weeks chorionic villus sampling, and that particular genetic autosomal recessive we can plan.
So, do we know which genes are involved in this this particular situation?
No, I don't know.
After delivery, madam, any specific genetic screening was done for the baby?
Yes, they did for differential diagnosis were there, whether it is fully collodion baby or it is, there are chances of 10% regression in future life, but it was fully collodion. There was no chance of regression in this baby.
Okay, Sunita ma'am, if you want. Okay, Viral bhai.
Okay, so thank you very much again, madam, for showing us the extraordinary case. So
Thank
now we
you. Thank
will.
you so much for giving this opportunity.
Thank you, madam. So we will move ahead now, and we would like to invite Dr. Harsh Talpada. Are you online, Dr. Harsh? Yes, we are making you a co-host now.
Sir.
Yes. Are we audible, Dr. Harsh?
Yes, sir.
Yes. And respected judge, is he audible?
Yes.
Yes, yes. So we can start. Dr. Harsh, please.
Good morning, everyone. I am Dr. Harshavardhan, second year OBGY resident from PDU Medical College, Rajkot. Under guidance of Dr. Kamal Goswami, head of department, and Dr. Shekhar Prajapati, associate professor. My case is placenta acquita spectrum disorder, cesarean hysterectomy in case of morbid adherent placenta. Normal presentation results from adherence of the blastocyst to the visualization of endometrium. Placenta acquita occurs secondary to abnormal adherence of placenta to myometrium instead of residue. This has important clinical implications in severe maternal and neonatal morbidity and mortality. After delivery, placenta and associated complications like DIC, multiple organ failure, and death. Correction of massive hemorrhage often requires massive transfusion, ICU admission, interventional radiological procedure, and hysterectomy. Fetal morbidity and mortality often associated with prematurity. Physiology and pathophysiology. In the Akreta syndrome, abnormal placental adherence to the myometrium stems in part from partial or total absence of the decidia basalis and imperfect development of fibrinoid or metabux layer. If the decidual spongy layer is lacking either partially or totally, then the physiological line of cleavage is absent and some or all cotyledons are densely anchored. Overall incidence is approximately 1 in 272 deliveries, and increasing incidence is mainly due to the rising rate of cesarean delivery. Previous 1 CS incidence rate is 11%, and previous 2 CS 40%, and previous 3 CS 61%. Next slide. Case detail: a 35-year-old female, third gravida para 2 live to 34 week. Previous 2 LSCS, both are FCL. Previous 1 CS in case of fetal distress. Patient diagnosed at 26 week today with USG suggestive of cephalic presentation with placenta accreta. For confirmation of diagnosis done with USG with Doppler, and MRI report also suggestive of placenta accreta. Elective termination of pregnancy done at 34 week gestation. Original diagnosis made on the basis of USG finding and also MRI finding suggesting the same. Investigations: CBC are normal limit 10.4 HB and total count platelet count normal. INR was 0.74 and RFCLF equivalent within normal limits. Suggested with bladder and also MRI picture is there. Next slide. Next slide. Management of the patient. Pre-operative evaluation with physician and anesthetist witness, and after availability of blood and blood products, plan for termination is done. Operative management: elective upper segment cesarean section done. Female baby delivered. Baby weight of baby is 2.4. Abdul for 8/10. Placenta left in situ. Obstetric hysterectomy performed. Then placental invasion into bladder, which bladder blast injury repaired with intraoperatively by neurosurgeon. Adequate hemostasis was achieved. Uterus was expelled out. Post-operative view of placenta percata picture shown. A post-operative outcome: successfully patient extubated, shifted to ICU for monitoring. Patient was hemodynamically stable and uneventful post-operative recovery was done. Histopathological confirmed placenta accreta spectrum. Next slide. Risk factor for placenta accreta. There are major 2 risk factors: previous CS and placenta previa are 2 most common risk factors. Other risk factors are myomectomy, endometrial curetan, there, and advanced maternal age. Learning points: placenta previa with previous cesarean delivery should be always raised suspicious for past. Early diagnosis using ultrasound plus MRI facilities, surgical planning. Multidisciplinary management significantly reduce maternal morbidity. Adequate blood components therapy is essential. Timely obstetric hysterectomy with bladder repair provide excellent maternal outcome in selected cases. Conclusion: placenta previa with placenta accreta spectrum and bladder invasion remains one of the most challenging obstetric emergencies. Careful antenatal diagnosis, planned elective surgeries, multidisciplinary teamwork from obstetric hysterectomy, bladder reconstruction, and appropriate blood component therapy result in a favorable maternal outcome in these patients. Thank you.
Good case, Dr. Harsh. Harsh, what are the indications of doing MRI in a patient with placenta accreta spectrum? Do we do in all cases or are there specific indications?
No, not done at all. If we are confusion or suspecting bladder invasion, with or not any confirmation from USG with Doppler for bladder invasion, then we go for the MRI, not doing all cases now.
What
More
are the USG
specifically-
finding? Sorry, yes, ma'am. Please continue.
No, just want to know. So, is it the bladder thing only, or there are some other important indications for doing MRI in placenta accreta? Bladder invasion still can be seen on USG with Doppler. You can clearly see the next question which sir is going to ask you. Those findings are most of the times quite clear. There are other indications for MRI in placenta accreta spectrum. Can you think of some?
Ma'am, in case of placenta perfecta 3C, in classification which pelvic organ any involvement or not, for that we are doing for MRI.
Okay, we can proceed to Dr. Shashwat sir's question. I'm not satisfied with your answer. We're proceeding with the next question. Read this question for your final exams, okay?
Okay, ma'am.
What are the specific USG criteria to diagnose or predict this placenta accreta spectrum?
So placenta accreta spectrum, first bridging vessel signs which inherit through bladder, then moth-eaten appearance of placenta, in which placental lacunae will form, and in USG, placental lacunae having increased vascularity, then loss of hypoechoic area behind the placenta, then loss of retroplacental myometrial junction, which is less than 1 mm from placental vessels, and between placental vessel and serosa, thickening was less than 1 mm. Then hyperechoic line discrepancy.
Okay, obstetric hysterectomy is the only treatment option, or we can preserve the uterus?
Yes, sir. In some cases, we can preserve uterus, in which patient wants to continue continue fertility, in which classical cesarean section was done. Placenta left in situ, and umbilical cord tied near the placenta, and uterus will close, and vigorously follow up with USG or MRI for placental dissolution. In some cases, placenta dissolved, but in future 20% of hysterectomy chances are there.
What is triple P procedure?
Yes, ma'am.
Triple P procedure.
Sorry?
Triple P procedure.
Yes, sir. Triple P procedure in which post perioperative placental location, then pelvic devascularization, and placental non-separation during myometrium excision.
Sunita ma'am, you want to ask anything, or should we proceed with the next student?
Okay, if you receive this patient in an emergency, patient is in labor and you just operate it and you just find that is the placenta accreta, you are not able to pull out the placenta, remove the placenta. What will be your next step? How will you prevent the? Okay, sure.
If you are in low source hospital, then we classical cesarean section was done, and baby delivered out without touching the placenta, umbilical cord tie, and
You receive this patient in an emergency. You don't know that is the placenta accreta or not. So you will proceed for the routine financial incision. You will put.
yeah. After financial incision, if we suspect a placenta accreta or any, then classical cesarean section done, then a baby delivered, followed by closure of incision without delivery of placenta or touching placenta to prevent bleeding, and send patient to higher center for obstetricectomy.
How will you know that is a placenta accreta or not intra-op?
Accreta we can diagnose, ma'am, but accreta will not diagnose.
Okay. No question.
Dr. Viral, we can proceed to the next student.
Okay, madam. So thank you, Dr. Harsh, for your presentation. So we are going to move ahead with Dr. Meet Kumar Khund. Are you online, Dr. Meet Kumar? I think no. So we are going to proceed with another speaker by Dr. Brijal Patel. Are you online, right? Yes, I think we are making her co-host. We have made her.
Yes, sir.
Yes, so you are audible to us also, and your slides we are going to share from our end. Just hold on. So here, when you want to do a next slide, just tell us next. We will change the slides. Okay, Dr.
Okay,
Brijal?
okay. Yeah, sure.
Okay. So you can
Good.
start from your end.
Okay. Yeah. Good morning to all the faculty members present. I am Dr. Brijal Patel, a second year postgraduate student from the Department of Obstetric and Gynecology, studying at Sri MP Shah Medical College, Jamnagar, under the guidance of Professor and Head of the Department, Dr. Nalini Anand. Today I am presenting my poster titled Feto-maternal Outcome in Severe Degree Anemia in Pregnancy, a tertiary care observational study conducted on 200 pregnant women with severe anemia. Now, severe anemia remains one of the leading preventable causes of maternal and neonatal outcomes and in developing countries, particularly in India. So this study evaluates its impacts on pregnancy outcomes and emphasizes the importance of early diagnosis and timely prevention. Next, please. So anemia is defined as hemoglobin less than 11 gram per deciliter. According to WHO classification, severe anemia is defined as hemoglobin less than anemia is defined as hemoglobin less than 11 gram per deciliter. Whereas according to WHO classification, severe anemia is defined as hemoglobin less than 7 gram per deciliters, and with other classifications are available as well. Now, ACOG and RCOG recommends intensive management if the hemoglobin falls less than 7 gram per deciliter. Now, our study included 200 pregnant women with hemoglobin less than 7 gram per deciliter presenting to a tertiary care hospital. So, these patients clinically presented with common clinical features such as pallor, tachycardia, dyspnea on exertion, fatigue, dizziness, and systolic flow murmurs. So, after confirming severe anemia, further clinical assessment and laboratory investigations were done, and management was based on WHO, ACOG, and RCOG guidelines. Two groups were formed. Group A with patients with gestational age more than 34 weeks and those who were in labor, and group B, patients who had gestational age less than 34 weeks. Now, the management was based on maternal conditions as well. Now, the patients with gestational age less than 34 weeks and whose hemoglobin fell between 5 to 7 gram per deciliter, in the parenteral iron was administered, and for those whose hemoglobin was less than 5 gram per deciliter, PEG cell, PEG red blood cell transfusion was made. Now, patients whose gestational age was more than 34 weeks and who were in labor, immediate blood transfusion was administered, and for labor, active management of third stage of labor was done to prevent postpartum hemorrhages. Next slide, please. The maternal and the neonatal outcomes were then recorded. As shown, among the maternal outcomes, 88% required blood transfusion, 42% had preterm labor, 18.5% developed postpartum hemorrhage, 6.5% required ICU admission, and 5% had puerperal sepsis. Now, coming to the neonatal outcomes, 61% of the babies had low birth weight, 38% were small for gestational age, 28% required new NICU admissions, and 4.5 had stillbirth. Now, coming to the etiological distribution, 84% of the cases were found to be iron deficiency anemia, which was the majority of the cases, followed by dimorphic anemia. Now coming to the preventive strategies, in preventive strategies, antenatal screening is must, followed by prophylactic iron and folic acid supplements. Dietary modifications can be done, in which vitamin C should be administered to enhance the absorption. Restricting tea and coffee while having the meals because it reduces the absorption. Deworming protocols should be followed, like single dose albendazole in second or third trimester should be administered given in endemic regions. Birth spacing should be done, where at least 2 years of interpregnancy intervals should be kept to replenish the iron stores, and early detection of the anemia should be made. Now, in conclusion, severe anemia in pregnancy is strongly associated with adverse fetal-maternal outcome, including increased need for blood transfusion, preterm births, postpartum hemorrhage, and low birth weight. Since iron deficiency accounted for majority of the cases, strengthening antenatal screening programs, ensuring compliance with iron supplements, and initiating timely treatment can significantly reduce maternal and neonatal complications. So early screening, prompt correction of anemia, and evidence-based obstetric management remains the cornerstone for improving pregnancy outcome. Thank you for your kind attention.
Hello.
Hello.
Yeah, why preterm labor rate is so high, 42% in your case study? Is there any
Yes,
reason?
because in severe degree anemia, there is uteroplacental insufficiency. So the oxygenation is reduced to the fetus as well, and nutrition are even reduced to the fetal as well. So that causes preterm labor.
Okay. All these patients were registered patient or emergency cases?
Some of so basically in severe degree anemia, if you take that particular case, then these are the patients which comes to the tertiary care at a very later stage. It is very difficult for to manage. So most of them would be emergency cases.
Okay. Ma'am?
What do you think is the mechanism of postpartum hemorrhage in these patients?
Ma'am, regarding postpartum hemorrhage in severe degree anemia, it reduces the uterine contractility. So it causes atony of uterus. So atonic postpartum hemorrhage is most common in these cases.
Okay. And in second stage of labor, any particular problem?
It can be prolonged second stage of labor in severe cases of anemia.
Why so?
Because proper contractions are not available, so the second stage also gets enhanced.
Okay. Any serious risk in second stage of labor and immediate postpartum in these patients?
Immediate postpartum, ma'am, if there is severe, then it can go to cardiac failure can also occur.
So what should you do? Suppose your patient has hemoglobin 5 gram%. She presented to you in late labor, 7 to 8 centimeter dilated. She's an unbooked patient. You still don't have PCV in hand, and she is delivering. She's pushing. Maybe she's fully dilated for 45 minutes or so.
Yeah.
Now,
Ma'am, first we need to stabilize the patient, make the patient hemodynamically stable. Then obviously we all need to do the labor management as well, as she's already fully dilated. Then we need to run the blood samples as soon as possible.
no, you said cardiac failure. So looking at that, what can you do to prevent that?
Oxygenation.
If you want to prevent cardiac failure because of the second stage issue in this very severely anemic patient, anything specific you can do?
Blood transfusion.
Will that prevent cardiac failure?
No, ma'am.
Okay, read about it for you.
Ma'am is asking what are the measures you will take to prevent cardiac failure at the time of near almost patient is delivering in second stage. So what are the position? How will you give oxygenation? What are the proper measurements you will take?
So we first we'll vitally stable the patient. We'll start
Do you think it
like
will occur?
oxygen support to the patient. Yes.
Do
Sorry.
you think it will occur? If you are going to stabilize the patient, making her vitals normal, is it possible immediately? No.
No, that is not.
Okay. Okay, continue.
Sorry.
So, Madam Sunita, Madam, want to ask, or can we move ahead?
What is
Yes.
in as you say, the patient is severe anemia. What
Yes,
other investigation you have to do to rule out what is the causes of anemia?
Ma'am, CBC with peripheral smear, HB electrophoresis to rule out sickle cell disease and other. Then looking at the peripheral smear, we can rule out other causes like iron deficiency anemia, megaloblastic anemia. Then iron profile serum ferritin could be done, so we can know that the iron stores are depletion of iron stores have occurred.
What is the Mancher index? Mancher index.
Ma'am, RB, it is MCV by RBC.
What it indicates?
Minor, to rule out between thalassemia major and minor.
What is the cutoff?
It is 13, ma'am.
Okay.
Yeah.
Are you know about the very high risk criteria governed by our government? And what is the cutoff value of hemoglobin?
Ma'am, India, specifically for India, India is a very high anemic prevalent country. So for basically anemia is less than 11 gram per deciliter, but it is very high for India. So it is less than 10.5 gram per deciliters for India specifically.
No, I am asking about the very high risk criteria. Have you heard about the very high risk criteria of Gujarat government running the Gujarat government very high risk criteria patients? There is a 12 and 13 patient, 12 and 13 criterias.
No, I'm sorry.
You have not heard about it? Very high risk patient, anemia, then thal patient, and previous 3 years. These are the very high risk. There is a government policy of very high risk criterias. There are 12 and 13 criterias. And the one of criteria is anemia. The anemia, that particular range, that anemia patient will cover very high risk, and government will provide them the fund that 15,000 something if they stay for the 7 days to the government hospitals. Have you not about the?
Yes, the criteria, ma'am, which came, like the very high risk pregnancy considered in.
Yeah.
Yeah.
Yeah. What is the hemoglobin range in this criteria?
Less than 7 gram per deciliter.
Okay. No, less than. There is a particular value. Okay. Thank you.
Okay, madam. Thank you. So now it's more time. Actually, we are waiting for the inauguration. So we will take one more person. So can we end, respected judge, this session with Dr. Brijal?
Yeah, sure.
Yes. So thank you, Dr. Brijal. Thank you for your presentation. So we are going to go forward, and we would like to invite Dr. Devanshi Mungra. So are you able to listen us, Dr. Devanshi?
Yes, sir.
Dr. Devanshi?
Hello. Yes, sir.
Your network is not that smooth actually.
Switch off the video at present.
Your sound is little break. So can you speak it again? Like,
Hello.
yes,
Hello.
yes. Do
Okay,
one
you can
thing.
start.
Hello. Yeah.
Good morning, everyone. Myself, Devanshi Mungra, a second-year resident from OBGY Department of PDU Medical College, Rajkot, under guidance of Dr. Kamal Goswami, sir, Head of Department of OBGY and PDU Medical College, Rajkot. I'm presenting today a poster on cesarean scar pregnancy, a rare ectopic entity. Introduction. Scar ectopic pregnancy is one of the rarest of all the ectopic pregnancies and is life-threatening form of abnormal implantation of embryo within the myometrium and fibrous tissue in a previous scar on the uterus, especially following C-section, which if not timely diagnosed may lead to serious complications like uterine rupture, hemorrhage, hypovolemic shock, and even mortality. Incidence varies from 1:1800 to 2,216 and pregnancies with rate of 0.15% in women with previous CS and 6% in all of the ectopic pregnancies. There are two types of hysterotomic scar ectopic pregnancies. Type 1 develops in the myometrium and grows towards the uterine cavity, whereas type 2 progresses exophytically toward the uterine serosa. Type 2 pregnancies have an ominous prognosis because they may result in spontaneous uterine rupture, hemorrhage, and maternal death. There is potential for loss of fertility if a massive hemorrhage necessitates a hysterectomy. Diagnosis with TVS in case of doubt MRI can be done. Case presentation. 36-year female was admitted with third gravida 3 live issue 2 with previous 2 LSCS having complaint of 1.5 months of amenorrhea. She came for routine ANC visit. On the USG, a cesarean scar ectopic pregnancy was suspected. So for confirmation of diagnosis, transvaginal ultrasound was done. Then patient was vitally stable and there was no complaint or symptoms. The plan of management was made of laparoscopic removal of the ectopic with concurrent permanent method of sterilization as the patient wanted a permanent method of sterilization. So the patient was managed, she was admitted and investigations were sent. Her routine investigations were normal and beta HCG was 600 and 126. So the plan was, the management was done via a laparoscopic removal of the ectopic with bilateral salpingectomy and the patient was stable during and after the procedure. As FCP was present in the USG, which suggested of 9 weeks, 3 days of gestation, methotrexate injection was also given, IM to the patient. Patient was followed till 6 months and with repeat beta HCG levels and no complications were found and no complaint. Intraoperative findings were in OT, the bilateral uterine artery were ligated, and then the incision was made over the lower CS scar, and the conceptus was excised out. Then endosuturing was done within itself, and after the procedure, bilateral salpingectomy was done with no complications, and patient was discharged on D3 of the procedure. Patient came for follow-up, and no other morbidities were found. Discussion. Various modalities of the treatment can be tried for such patient. Medical management with methotrexate can be tried. USG guided dilation and curettage excision can be done. Excision can be followed by uterine artery embolization. And surgical management is laparoscopy or laparotomy, which is the definitive and most patient rewarding. And that removes the whole gestation. And patient can be given the chance of fertility in future. So conclusion is that scar ectopic pregnancy, though, is rarest and capable of causing grave complications. So timely diagnosis and quick management and proper management of this patient gives the patient a good quality of life further. Thank you.
Nice presentation. What are the criteria for medical management?
For medical management, it should be early gestation, like less than 6 weeks around, less than 7 weeks around. Then beta HCG levels less than 5,000. Then the fetal cardiac pulsation should be absent. Patient should be hemodynamically stable, no rupture signs or any altered values should be present. And patient should be willing, first of all, for the medical management.
Okay.
How will you choose patient? Yeah. How will you choose a patient for dilatation and curettage? If you think that that is the answer in some particular case, what will be the criteria?
Okay, for dilatation and curettage, first it is USG guided. They have to do the procedure, and the same that fetal cardiac pulsation should be absent. There should be no more vascularity around the G-sac or placental vascularity, which may lead to hemorrhage during the procedure and ultimately leads to hemodynamically unstable patient. Then
Anything
patient
related
should
to your
be.
type type of scar pregnancy?
Sorry?
Anything related
Type of
to the
scar
type?
means a type 1 scar ectopic pregnancy where the gestational sac is growing towards the uterine cavity.
That is the main criteria. You cannot choose an exophytic scar pregnancy for this.
Yes, exactly. Yes,
Can you predict that which patient is more likely to have a scar ectopic pre-pregnancy? Suppose a patient is coming to your OPD
pre-pregnancy?
conventionally, and do you think you can look into something and possibly give an idea to the patient that you're more likely to land up in scar ectopic, so come early to us as soon as you get pregnant?
Yes, ma'am. So patients which have history of previous 2 CS section or previous 1 CS section, we can we can look for the myometrial thickness between the developing GSAC and the bladder to look for the scar thickness of the
Pre-pregnancy. I'm asking pre-pregnancy, preconceptionally, in between the pregnancy. Have you heard of isthmocele? You've heard of something called isthmocele? Devansha, are you with us? Have we lost him?
Hello? Hello?
Yeah, Devansha, did you hear my question? What is an isthmocele?
Isthmocele. Ma'am, near the cervical cervical ectopic, we can.
Cervical ectopic. Have you heard of niche, scar side niche, anything like that? No problem. Read it before your exams. Sunita, ma'am, any questions from your side?
No, ma'am. Thank you.
Thank you, Dr. Viral. We can go ahead.
Thank you, Dr. Devanshi, for your wonderful presentation. And here we will just end this session, and we will request all of you who has joined currently to go for the Hall A link, and we respect Dr. Garima Madam, Dr. Sunita Madam, Dr. Shashwat Sir to join Hall A link, and we are about to start the inauguration over there. So thank you all.
Thank you, Dr. Yeah, thank you. Thank you.
Okay, hello. So now we start our session post inauguration. Thank you everyone for joining. Hi, Jitesh Bhai. Hi.
Good afternoon, madam.
Good afternoon. And Dr. Bhavesh Bhai, you are also there now. Dr. Bhavesh Airao. આવી ગયા છે ને ડોક્ટર ભાવેશ?
Yes, ma'am.
Yes.
Good afternoon, madam.
Good afternoon. So let us start.
Yes,
Okay?
ma'am.
Yes. So I think we have all the reels in this session. The first one is Miss Darshana Pandya. Is she there? No, she is not there. Okay. Then Dr. Riddhi Shiv Godasara. Dr. Riddhi? Is she there? Has she joined? We'll have to. Dr. Riddhi ne phone karo. She has not joined.
Madam, one more.
મારી પાસે આવી ગઈ છે બોલી લઉં હા અને ડોક્ટર જીતેશ and Dr. Bhavesh, just to let you know that we have sent you they have sent you the link for Google form to give the markings.
Yes, ma'am.
You have that, na? So we'll directly submit it on Google. Okay.
Madam, one query.
Yes.
Google link માં 80 marks નું છે અને પેલું જે
100 જ છે. Okay.
links માં madam 80 marks નું જ આવે છે.
1 minute, let me tell you. હા.
એક તમે મેડમ એન્ટર કરી જુઓ ને મેડમ.
હા I'll just do that.
No, ma'am. I think I have received 100 marks.
Even I have received the same thing. Shall I send you that link? 1 minute.
Yes, madam. એવું કરો મેડમ. હા.
Easy point, sir. એના સિવાય કોઈ જોઈન થયેલું છે?
I think Dr. Azade is joined or Dr. Sujat Wali. Why nobody is? 1 minute, let me call him. He must be there. Dr. Azadi, I'll call her. સાંભળો ને તમે જીતેશભાઈને ફરી ગૂગલ ફોર્મ મોકલો છે તમારી પાસે ઓકે જીતેશભાઈને गूगल फॉर्म मोकलो ने तो वो कह रहे 80 मार्क्स का आया है 1 मिनट आई विल ओपन इट જીતેશભાઈ ના આવ્યો નંબર એને મોકલી દો ફરી આઝાદી આપણી આઝાદી
હેલો કેમ છો ડોક્ટર વિરલ બોલું ડોક્ટર વિરલ ગાયનેકોલોજીસ્ટ डॉक्टर आजाद बोलो
So Darshan Pandya is not there, okay? Then Dr. Riddhi Godasra is not joined, right? Shall I call Azadi? બરાબર તમને આપું આઝાદીનો નંબર
મારી પાસે કોલેજ ને આમાંથી આ લોકો
યસ મેડમ ગોટ આવી ગઈ છે મેડમ.
આવી ગયું જીતેશભાઈ?
યસ આવી ગઈ મેડમ.
હા ઓકે
સાહેબનો આ નંબર WhatsApp પર નથી એટલે પ્રોબ્લેમ થાય જીતેશભાઈનો.
અચ્છા જીતેશભાઈને આવી ગયું કે છે
આવી ગઈ. યસ રિસીવ મેડમ.
ઓકે સોરી
હવે આપણે આમાં છે કોણ આ સેશનના પેલા નથી સુજત વલીને ફોન કરો
મેડમ સુજતભાઈ નથી પ્રેઝન્ટ રહેવાના એમને ઓલરેડી હેતલ મેડમને વાત કરી દીધી
ઓકે
સુજતભાઈ
સુજત વાલીને કરો ને સુજત વાલીને કરો ને આમાં તમારા નામ
હિમાલીબેન રેડી છે તો હિમાલીબેનને બોલાવી લઈએ.
હા તમારે કંઈક
એ પ્રેઝન્ટ કરી દેશે
છે વૃંદા સુબા નામ નથી મારા this BIPS iPhone is for whose phone is that? Dr. Bipasha Lakhani? Is that your number? We have unmuted
Yes,
you.
ma'am.
We have unmuted you. So can you start your talk? So rest of the two judges, this is BIPS, Dr. Bipasha Lakhani who is going to present.
Yes,
okay? Bipasha
Yes,
Lakhani, right?
Yes, ma'am.
Yes, okay.
Next.
ચાર નંબર છે મારી પાસે 4 નંબર છે પણ એક હોસ્પિટલ હોય છે બાકી
Okay.
આ બંધ કરી દો ને ત્યાં જશે નહીં નહીં લાઈટ નહીં પંખો આ પોઈન્ટ છે
મગજને સજગ પ્રવૃત્તિઓ આથી સગર્ભામાં સ્ટ્રેસ અને બાળકોમાં ટેલોમિયરનો ઘસારો ઓછો થાય છે અને આ અમારી સંસ્થામાં થયેલ સ્ટડીઝમાં સાબિત છે
I think the volume was very low. Yes, did you get the connection properly, Dr. Jitesh? And
No, madam. No, I can't hear it.
Didn't hear it and didn't see it.
શું મળે છે મેડમ મેડમે મુશ્કેલ લાગે
Hello.
Hello.
Thank you. Good morning, everyone.
Good morning, Nitin bhai. Good morning.
so, Dr. Bipasha, basically your
Yes,
idea
ma'am.
was to give them the to know, I mean, the holistic approach, right? What was the exact
Yes,
idea?
ma'am. Yes, ma'am. So it is an approach where during the pregnancy only that we will try to reduce the overall stress of the mother, which helps in the social as well as
1 minute.
emotional and psychological.
Parul ma'am. Sonal ma'am.
Yes.
There are 2 reels from our college.
Okay.
So this is
Please
Dr.
give us the
Bipasha,
names of the participants.
Dr. Bipasha and Dr. Dhwani Solanki. So I will not comment on that.
Okay, so Dr. Bipasha, I just wanted to know that did you get any, like, those patients who were really stressed out, and then whether you asked them that whether they found any difference in their overall health or
Yes,
mental
ma'am.
health? Did you get those
Yes,
kind
ma'am.
of performers and get that?
Yes, ma'am.
How
So
did
there
you
are many
decide?
kind of patients who are right now admitted in our ward also. So overall approach is to make them stress free. So in IPD basis also we have an holistic care approach which are going on daily basis for high risk pregnancy as well as who are not high risk also. So we have compared the studies also, and they have showed that it has decreased the stress and overall improved the outcome of the mother as well as the baby.
Any questions from the other judges?
Madam, sound was not audible to us.
I know, even for us it was like that. Maybe we made it highest this thing, but basically the thing which is saying the same thing is there. Would you like to do it once more? Video માં તમારું વોલ્યુમ ઓછું આવે છે ડોક્ટર બિપાશા. Volume is low in the video.
Only
That
was
is the
audible,
problem.
madam. Only
It was not
music was
audible, but if you want, you can try again with increase. I mean, keeping your volume highest.
Madam, if possible, repeat it.
Yes,
If
that is what
possible,
I'm
madam.
saying, with highest volume on you from your side.
Or they can share the file directly, so you can play over there only.
Yes, that also we can do. Yeah. Okay. So because we shared it from our side and the volume was very low. So do you have it right now with you, which you can share immediately?
Yes, yes, ma'am.
Or by the end of the session you can do it. If right now you can do it, that's good, well and good. Otherwise,
Yes, ma'am, I have it with me.
yeah. એમનામાં જ છે ડોક્ટર.
Excuse me, ma'am. It's not letting me share the video as of now. Can I share it at the end of the meeting, ma'am?
Madam.
So now the next speaker is Dr. Dhwani Solanki, right?
Yes.
Next reel from Dr. Dhwani Solanki.
It's continuous. Yeah. Continuous on
We can't hurt, madam. I can't hurt.
We cannot see the reel also. Video is not visible.
आवाज नहीं आ रही है.
ઓપરેશન ના કરાવવું હોય તો બીજા બી ઘણા બધા ઓપ્શન વિચારી શકે. આવે છે ધાતુની આકડી હોય છે જે 5 વર્ષ માટે બી મુકાઈ શકે, 10 વર્ષ વાળી બી આવે છે. બીજું એક જે અંતરા કરીને ઇન્જેક્શન આવે છે જે દર 3 મહિને મુકાવવું પડે. બીજું છે ગોળીઓ હોય છે જે દરરોજ લેવાની ગોળીઓ હોય છે, એક અઠવાડિયે લેવાવાળી ગોળી હોય છે.
Okay.
I think again the volume is very low, right?
Yes, madam.
But at least we could listen to it. This was regarding contraception, right, Dr. Dhwani? So, please, questions from Dr. Jitesh bhai.
Madam, નથી સંભળાયું કશું, madam.
Oh, એવું છે?
હા, કશું.
I have to ask for reels all the participants to directly give it, because these people are sending it and the volume is low. So Dr. Dhwani will give you a few minutes. So by that time you start your this thing also, please. Right? So you can directly share your reel. That would be better. So both of you should do that. Dr. Dhwani is not there. Nitin bhai, Dr. Dhwani નથી તમારા સ્ટુડન્ટ?
હા, just madam message pass on કરું છું. Message pass on કરું.
So we'll ask both Dr. Dhwani and Dr. Bipasha to be prepared with their video. Directly they can share.
डायरेक्टली Zoom लिंक पर प्ले
Yes,
करवाना था
that would be better.
That,
Yes, yes, yes. Because I could listen to the second video, but it was not audible to the other people.
Madam, they had shared in chat box now. One video is shared in the chat box.
Okay.
So one can download and just.
Okay, we'll just do that. Chat box ની વિડિયો ડાઉનલોડ કરો ને એક જ આવે છે બીજી શોધો ચાર છે ને ચેટ હા ડોક્ટર બિપાશા 1 મિનિટ
ના પણ એમાં ઓડિયો નથી આવતો જે શેર કર્યું તેમાં ઓડિયો નથી આવતો.
Okay, till we sort out this glitch, I think we'll have to.
તમે ડાયરેક્ટલી સ્ક્રીન શેર કરીને
બેવમાં એવું આવે છે બિલકુલ લો આવે છે
સ્ક્રીન શેર કરીને વિડિયો પ્લે સ્ક્રીન શેર કરાવો તમારાથી. Can we allow them to screen share? Because if we give them right to screen share, they will be able to share their screen.
Yes,
Dr. Sujatwali is there.
Okay, we can
Dr. Vaishali Pandresh is there. Dr. Vaishali. नीचे मैंने post नहीं. Let us clarify this whether it is there problem is there with all the speakers or not. So Dr. Vaishali, are you there? We have unmuted you.
Good morning, sir.
Yes. Dr. Vaishali, yes.
Yes, ma'am.
On video.
Please show your video also. I mean, switch on the video from your side.
Sorry, ma'am. Just a second.
Yes. So now we'll run your reels, right? Reel. What is it on about?
Ma'am, I had made a reel on over-the-counter contraceptive pills, the hidden dangers.
Okay. हाँ હવે આપણે રીલ ચાલુ કરો. We'll try from our side. If it's not good, then we'll have to try something.
Yeah, come on.
વૈશાલી પાંદરે બસ આ હા
कॉन्ट्रासेप्शन नहीं लिया और प्रेगनेंसी रह गई अब क्या करें यही सोच रहे हैं ना सो हाय दिस इज
Video is not visible.
सो लेट्स डिस्कस आवर
Video is not visible.
not visible
Not visible. Video is
one
not
minute no
visible.
we can 1 minute just hold on ફરી કરો સ્ક્રીન શેરિંગ કરો અહીંથી આખું ફરીથી કરો
અને એમાં છે ને સ્ક્રીન શેરિંગ ના સેટિંગ માં allow video and audio to go there.
જસ્ટ કર્યું ફરી કરીએ અને હવે ફરી પહેલેથી ચાલુ કરો પહેલેથી કરો
Yes, now visible.
this is
कॉन्ट्रासेप्शन नहीं लिया और प्रेगनेंसी रह गई अब क्या करें यही सोच रहे हैं ना सो हाय दिस इज डॉक्टर वैशाली एंड OBGYN resident सो लेट्स डिस्कस आवर रेसिडेंसी रियलिटी विद मी क्या अबॉर्शन पिल लेना ओवर द काउंटर सही है नो तो लेने से पहले ये वीडियो जरूर देखें नॉर्मली जो आप प्रेगनेंसी टेस्ट करते हैं उससे सिर्फ ये पता चलता है कि आप प्रेग्नेंट हैं लेकिन उससे ये पता नहीं चलता है कि वो प्रेगनेंसी कहाँ है और ये जानने के लिए हम अल्ट्रासोनोग्राफी करते हैं नॉर्मल प्रेगनेंसी लोकेशन एंड प्रेगनेंसी आउटसाइड द यूट्रस सो द हाई रिस्क कॉन्सिक्वेंसेज एसोसिएटेड विद दिस कंडीशन आर डिस्क्राइब्ड ओवर Now, what to do when we encounter unwanted pregnancy? First of all, do not panic. Secondly, consult a gynecologist who are going to do the ultrasonography and follow procedure accordingly and follow safe abortion practices. That's all. Thank you.
was it audible
Yes,
Yes,
madam.
ma'am.
Yes, ma'am.
Audible and visible.
Yes, okay.
Yes,
So
audible,
I think
audible.
the problem is with those two videos. So they'll once they send it in chat box, we will run them again. Now there, Himali caller. We'll have to. Have you tried this thing? I mean, Doctor. Questions from Dr. Jitesh or Bhavesh if you want to know about something. Yeah.
Dr. Vaisali,
Yes, sir. Good morning, sir.
good morning. Can we make this reel visible to all public?
Yes,
Any,
sir. Sure.
any rules applicable to us?
No, sir.
Madam?
I think we should have given you 2 minutes to, show the complications related to this, the way the things are, scenario is worsening.
Yes, sir. Actually, ma'am, the timeline was 90 seconds. So, to explain a lot of things about that over-the-counter pills was a bit task for me. That's why the most important complication that was the ectopic pregnancy that the people are not knowing, the journal people. That's why I had more concentrated on that particular thing.
But I
So
think
that
for
is
a low resource setup, I think if we give more this thing to emergency contraceptive,
yes,
that would be
yes,
good.
yes, ma'am.
Yes,
Sure.
Because
agree.
that they can take it without over the counter, they can
Yes,
take it without a doctor's this
yes,
thing.
ma'am. Ji, ma'am.
I think we have to teach that more to the society when we,
Yes.
because whenever I take lectures for those working women, I
Ji, ma'am.
usually positively inform them about that 72 hours, this thing, so
Yes.
that would be
And
better.
it's recorded.
Yes.
Yes, uh, Dr. Bhavesh, you were saying something?
Hello, Dr. Vaishali.
Good morning, sir.
Hello. Good morning. How to explain the patient, illiterate patient? This reel, how explain the illiterate patient? How will you say?
Sir, first of all, it is very important to have a rapport with the patient and to explain the medications in their language. And unke samne, first of all, to explain the medications one by one in their language, and let them say also whether they had understood or not. Whether they had to take 24 hours, whether they had to take 48 hours, whether per vaginal or oral, to explain them in their language and to let them say in their words also whether they had explained or not. So that is very important, sir.
Dr. Vaisali,
Yes, sir.
what was your topic?
So the hidden dangers over-the-counter medical contraceptive pills.
So this is contraceptive pills?
About medical abortive pills, basically.
Okay. So what is the over-the-counter contraceptive pill available?
So mifepristone is there.
Which contraceptive pill is available over the counter in India?
What's about new about the IPIL? What's the new?
Mifepristone, bisoprostol is basically abortification, no? And it should not be given without prescription as per
Without
the.
prescription. So the generally people take their eye pill within 72 hours after having an unprotected intercourse. That is available in medical shops without a medical prescription also.
So this is over-the-counter contraceptive pills, na?
Yes, sir. Yes, sir.
I told you that in consultation we usually tell them about 72 hours pill, that I pill. That is
Yes,
the same
sir.
thing.
Yes, sir.
So
I pill,
actually your talk should have been on that, I
ma'am.
think. Contraceptive, if you are saying. Yes. Your drill name should be emergency termination pill and not contraceptive pill. Then that is what Dr. Jitesh wants to say.
Abortion pill.
Yes.
Yes, abortion pill.
Yes, ma'am.
Okay. So will Dr. Jitesh Bhai and Bhavesh Bhai, we are trying to run those 2 videos again, just to, because otherwise in chat box this kind of video is not going to be fully loaded and sent over here. So we'll try once more. Just try to listen to it with a close to
Yes,
your
ma'am.
body. Yeah, please.
Bipasha and Dhwani.
Yes, Bipasha and Dhwani, please.
Yes.
Vaishali will remove, right, madam?
Vaishali now, thank you, Dr. Vaishali. You can,
Thank
we
you
are
so much.
muting you. Yes, yeah, okay.
Thank you so much, ma'am. Thank you, ma'am. Thank you, sir. Thank you, ma'am.
Dr. Bipasha, we were starting first now. Dr. Bipasha. Bips 1 છે ને something. હા, Bips 1 એવું કંઈક એનું છે. That's not there.
I think they have gone to the system department.
Okay, then try this Dr. Dhwani Solanki.
Both are together. So we can take another Dr. Darshana Pandya or.
Thank you so much.
Now, okay, now Dhwani is there.
એમને ચાલુ કરી દો ને. આ છે ને ડોક્ટર ધની સોલંકી. ઓકે હા તો 4959 ની પાસે ગાડી ચાલુ છે એના સાઈડ તારી ગાડી લઈને જતો રહો ને એટલે મને બોલાતા બોલાવવાના બધાના રિઝ્યુમ ને એ બધું મારી જો પાછું ના નવું લેવું પડે.
હા પ્રજિતા કેમ છે? હાય કૃષિ. હા મારું જો પાછું બાળક છે તો હું બતાવવા આવી છું. કેવી રીતે અહીંયા? હું છે ને પ્રોપર્ટી કઢાવવા આવી હતી. તારે કેટલા બાળકો છે? મારે એક જ બાળક છે. બસ એક જ બાળક છે? હા. પ્રોપર્ટી એ શું હોય? પ્રોપર્ટી છે ને બાળકો ના થાય. મેડમ તને અંદર સમજી શકે. મારી ફ્રેન્ડને 5મી સ્વાવર છે તો એને કોન્ટ્રાસેપ્શન વિશે સમજવું. હા બેન, આપણી પાસે બહુ બધા ઓપ્શન અવેલેબલ છે. તમારે 5મી સુવાવડ છે તો સારું એ રહેશે કે તમે વસ્તીબંધનું ઓપરેશન કરાવી દો જે કાયમી રીતે વસ્તી નિયંત્રણ કરશે. બેન ઓપરેશન ના કરાવવું હોય તો સારું બેન, આપણે ઓપરેશન ના કરાવવું હોય તો બીજા બી ઘણા બધા ઓપ્શન વિચારી શકાય. આવે છે ધાતુની આકડી હોય છે જે 5 વર્ષ માટે બી મુકાઈ શકે, 10 વર્ષ વાળી બી આવે છે. બીજું એક જે અંતરા કરીને ઇન્જેક્શન આવે છે જે દર 3 મહિને મુકાવવું પડે. બીજું છે ગોળીઓ હોય છે જે દરરોજ લેવાની ગોળીઓ હોય છે, 1 અઠવાડિયે લેવાવાળી ગોળી હોય છે.
I think this time the reception was a little bit better.
Yes, madam.
Okay, so your questions, any, if any? I think everything is self-explained, but.
Dhwani?
Hello, Dhwani. Dr. Dhwani.
We have made her co-host. I don't know whether she is there or not.
Dr. Dhwani.
Then I think Bipasha Lakhani, is she there?
Dr. Himal.
This patient is postpartum or
Dr. Dhwani, I will have to call her.
देखो अनम्यूट का कुछ इश्यू था, अनम्यूट कर रहे हैं.
Dr. Dhwani, please unmute yourself.
I think वहाँ से अनम्यूट करा मैडम.
कर दिया है यहाँ से तो कर दिया. We did that. She is unmuted, no? She has to unmute now herself. We have already sent her this thing. Okay, so let us now go to the physical one who is already present over here, Dr. Himani. Okay.
Yeah.
Yeah, please, Dr. Himani.
Bipasa is there or not, madam? Bipasa is there.
But they are not listening. I don't know. I am calling Dr. Nitin now.
Okay, ma'am.
They are not responding.
Madam, they had responded in the chat box. Dhwani, are you there?
Yes.
Dhwani? You are not audible. Dhwani and Bipasa, you are not audible.
Not able, not allowed to connect to audio.
Dhwani, can you, Bipasa?
Hello. Hello.
Madam,
Sir,
now
me
audible
and
it seems.
Dhwani are together only. Yes, sir.
Okay. Jitesh?
Yes, Dhwani.
Now they are.
Dhwani,
Yes, sir. Good morning, sir.
good morning. Nice reel.
Thank you, sir.
Hello.
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 Hello. Yes, sir. Am I audible?
Yes. That approach in counseling in contraception is known as?
Sorry, sir.
The approach we follow in contraceptive counseling is known as which approach? Am I audible? Am I clear now?
Yes, you are clear. So, sir is asking about a different approach to counseling the patient, theoretically. When we...
Yes, sir. The cafeteria approach.
Yes, cafeteria approach.
Hello, Dhwani.
Yes, sir. Yes, sir.
This patient is a postpartum or a gynec patient.
Sir, postpartum patient.
So, which contraception do you suggest more?
Sir, we advise abdomen tubal ligation after 6 weeks, but if patient denied for operative option, so we advise depot medroxyprogesterone, Dampa in Antra.
Postpartum which day?
Sir, third day.
Third day. So, PPI IUCD, what's about the PPI IUCD? What is it?
Sorry, sir. Yes. Postpartum intrauterine device insertion, sir.
So, it is advisable this time?
No, sir. Ideally, it should be in within 48 hours.
Okay.
Which is the ideal time for counseling for the contraception during pregnancy or after delivery?
Sir, during pregnancy.
Okay. Madam?
Okay, madam.
Dr. Dhwani, right?
Yes.
Yes. Nice. Okay. Good. So now I think that another Dr. Bipasha is there for the question answers. Or
yes.
Yeah, you are there.
Yes.
So we'll run your reel again once more because you people have not heard that, no?
Yes,
No, madam.
Yeah.
We have
Okay.
to
So
run the reel again.
You are doing it, no? Or shall we do it?
Just
Okay.
ma'am, I'm doing it. Just a minute, ma'am.
Okay. Then Dr. Himani will ask. Madam, बस सही हो. એની સાંભળ્યું આ લોકોને નથી સંભળાયું એટલે એના રસ્તામાંથી એનું ના થાય તો આપણામાંથી કરી દેજો. If you cannot do it, then we'll do it from our side again, okay, with increased volume.
Okay, ma'am.
डॉक्टर हेक्सेल को नेक्स्ट सेशन पोस्ट करवानी मैडम આવે છે તમારી ડીસી એટલે બધી લિંક્સ આપણે જરૂર લોડેડ છે અમે પેલા મોબાઈલ
presentation confidence
Sir, can I share my video, please? Hello.
Hethelben, they are ready for screen sharing. Can they allow to screen share?
Yes, we will allow. So please start.
Audio is not.
No audio. हम यहाँ से कर देते हैं ध्वनि.
Okay.
Yeah.
Bipasa stop sharing.
Yes, sir.
ધ્વનિનો છે કે બિપાસાનો છે?
Bipasa.
યસ સર. ઓકે.
Johnny no bati gaya.
Pregnancy test positive છે. મેં તમારો ત્રીજો મહિનો
Hello,
છે
are you
અને
able to
પણ
see
વધારે
it?
આવે છે અને શુગરનો રિપોર્ટ અત્યારે હું
Audible.
A1C પણ વધારે છે 7 આવે છે. ઓછા મહિનાએ તમારી સુવાવડ આટલી જોખમી થઈ ગઈ છે તો અમારા હોસ્પિટલમાં એના માટે વિવિધ પ્રકારની પ્રવૃત્તિઓ થતી હોય છે તો એના મેડમ તમને આગળ સમજાવશે.
સાંભળો બેન, સગર્ભા દરમિયાન બાળક અને માતા એકબીજા જોડે ગાઢ એકમ રીતે જોડાયેલા છે. આના કારણે સ્ત્રીના માનસિક, શારીરિક અને ભાવનાત્મક સ્વાસ્થ્ય સારું બાળક અને માતા બંને માટે અત્યંત જરૂરી છે. આના ઘણા ઉદાહરણ આપણા પુરાણોમાં છે, જેમ કે અભિમન્યુ, પ્રહલાદ, શિવાજી. આવો તમને અમારા હોસ્પિટલના ક્લિક સેન્ટરની મુલાકાત કરાવો. ગર્ભ ધ્યાન અને ગર્ભ સંવાદ, સૂક્ષ્મ ક્રિયા અને યોગા, મગજને સજગ રાખતી પ્રવૃત્તિઓ. આથી સગર્ભામાં સ્ટ્રેસ અને બાળકોમાં ટીલોમીરનો ઘસારો ઓછો થાય છે અને આ અમારી સંસ્થામાં થયેલ સ્ટડીઝમાં સાબિત છે.
Yes, Jitesh bhai, Bhavesh bhai.
Hello, Bipasa?
Yes, sir.
By this reel, which type of message given to the patient?
Sir, for that, to decrease the overall stress and improve the pregnancy outcomes, even if it's high risk or even it's not an high risk, and to overall improve the quality of the mother care, the patient should have an environment in which the family as well as the social psychological support is provided to the mother for the better outcomes. Sir.
Okay, suppose patient is a hypertensive and high risk patient, then advise the yoga.
Yes, sir. We can advise yoga, but there should be an overall approach, like not just the yoga to reduce the stress also, and to have a psychological as well as the family support, as well as for that we should have in medications. Even so, if the HbA1c is 7, and so BP is also high, we should give an antihypertensive as well as oral hypoglycemic agents. Along with that, all this approach is very necessary to increase the outcome of the mother as well as the baby, sir.
Okay. Have you heard about the Garbha Sanskar? What is it? Is there any role in this patient? Garbha Sanskar.
Yes, sir.
What is it?
So it is basically Garbha Sanskar is whatever the baby, the fetus is inside, and whatever the baby listens, or for example, there are some examples like Abhimanyu and everyone in our past ancient history, which have already heard about the same thing and have given a great ancient examples for it. Like listening to the calm music, having a relaxation exercise, having a balanced diet, and doing an exercises, which helping the overall improvement of the mother as well as the outcomes. Sir.
Okay.
Bipasa,
Yes, sir.
nice reel.
Yes, thank you, sir.
Okay. Will you explain in group in antenatal OPD or one-to-one discussion is necessary?
Sir, we are explaining them in the group actually, but whenever the patients comes for the very first time with a positive pregnancy test or is a high risk patient, we explain to them that we have such kind of activities which are going in our institute. So we explain to them that the benefits of it, and even if the patient is indoor, like if the patient gets admitted, we have a different approach to that, sir. Also, so even if the patient is not getting admitted, we have an OPD based holistic care approach, which are specific timings for that, and we have a specialized person who helps them have these all activities, sir.
Okay. Do all patients agree? Do all patients agree when you counsel?
No, sir. Most of them agree to it. Majority of them agree to it. So, on the basis of the explanation and how we approach to the patient for the same is.
Okay. Thank you.
Thank you.
Okay. Hello?
Okay, we can go to the next.
Yes, next.
Yes, so we are presenting the next reel. Dr. Himani.
What if I told you your age and your fertility don't
Hello?
always follow
Excuse
the
me,
same timeline? The biological clock is real, but it doesn't mean you have to rush into motherhood. Every woman is born with all the eggs she's ever have. As the years pass, both the number and quality of these eggs naturally decline, especially after the age of 35. That's where egg freezing comes in. Egg freezing allows healthy eggs to be collected and preserved at a younger age, giving some women the option to try for pregnancy later. But remember, it's an option, not a guarantee. Whether you're focusing on your career, haven't found the right partner yet, or need medical treatment that may affect fertility, understanding your options today can make a difference tomorrow. The biological clock isn't meant to scare you. It's meant to inform you. The earlier you understand your fertility, the more choices you have. If you think egg freezing is an option for you, please connect with your fertility specialist to know more.
So we have Dr. Himali here itself at the Hall C. So please feel free to ask her the questions that you. Hello. Good afternoon.
Good afternoon.
Was it audible?
Yes, yes, nice and clear, real.
Thank you.
Madam, your name is?
I'm Dr. Himali Maniar.
આમાં ડોક્ટર આઝાદી પટેલ નામ લખેલું છે.
No, no.
અમને જે લિસ્ટ આપ્યું છે.
Is separate person or is separate person? Dr. Himali's
No,
name is
this
not
is a
there.
separate reel under the
The
entry
name
of
is
Dr.
not there
Himali.
here.
Your name is not there in the list.
It came in last night actually. I had
Okay,
sent last
okay.
night, so I
Okay,
think
we
the
can
list
add
was
on.
made just before that.
Ninth
Okay.
number. We can add on ninth number.
Doctor?
Himali Maniar.
Okay,
Maniar.
okay.
In Google form, you also not their name.
I have put it in Google form, but I filled it last night. It was a late entry, sir. So
Okay.
Okay, okay, no problem.
Nothing.
any questions?
Madam, any contraindication for egg freezing?
So basically, if there is already, if patient contraindication, I will say that if they have already undergone chemotherapy, then of course there is no point in doing egg freezing. But if there are patients who are going to opt for chemotherapy, this should be given an option earlier. Otherwise, any person can opt for egg freezing, whoever has plans of getting conception late. It could be because of career, it could be because of their personal choices, it could be because of not finding the right partner. Egg freezing is a wonderful new advanced age option which should be given to all couples.
Suppose 18-year girls comes to you that I am going to marry later on and due to my career option, will you freeze my eggs?
At the age of 18, I don't think I will, but I will definitely tell her to come between 25 to 30.
Okay.
Overall good explanation this part. And
We have to
all
do her
questions has been
AMH.
asked by Jitesh sir, so I'm not asking further question.
Just in case her mother has a history of premature menopause, we can do her AMH and see if she's falling in that category. Mostly at the age of 18, we will not see anything like that and we will not freeze it.
How much time you keep the egg preservation?
We
How
can
much
do it.
time?
We can do it for lifetime. 25 years,
Lifetime.
we have studies of 25 years.
So after 20, 40 years, when patient wants, then is there any problem in patient during pregnancy?
So egg retrieval is almost 90%, 85 to 90%. Then we have to do, of course, because it is egg retrieval, the person will have to undergo IVF. So fertilization rates go till 60%, and then the blastocyst rates may go till 50%. So that we have to explain the patient prior.
Okay.
Yes, sir. Thank you. Thank you so much.
Thank you.
So now we will be playing the reels of people who are not present for question answers, but they have sent us the reel. So we will just play their reel and judge them.
Madam, Azad Patel is also a egg preservation. So same reel both Himani and Azad.
હા એટલે એમની એન્ટ્રીમાં સેમ ટોપિક છે, so we will
Okay.
just play the reel and we can judge.
Sure.
આઝાદી પટેલ.
Egg freezing only for celebs?
No! God, please, no!
Egg freezing is for women. All those women who want to take charge of their fertility and who wants to plan their future on their terms. It is for unmarried women, for professionals, newlywed who want to delay pregnancy and childbirth.
short and simple.
So she is not present, she is busy. Actually આ બધા working consultants છે, private practitioners who have sent their entries, but they are busy with their profession, so they are not able.
So are there two different categories for consultant and students?
No, nothing, sir. Different categories. It is the same category for everybody.
Okay. Next we can do it.
નમસ્કાર, હું ડૉક્ટર દર્શના પંડ્યા રાજકોટ ખાતે છેલ્લા 3 દાયકાથી કન્સલ્ટન્ટ ગાયનેકોલોજીસ્ટ તરીકે કાર્યરત છું. આદરણીય વડાપ્રધાન શ્રી નરેન્દ્રભાઈ મોદી સાહેબે યુવિન કાર્યક્રમ હેઠળ અજમેરથી આપણી તમામ કિશોરીઓ માટે સર્વાઇકલ કેન્સર અટકાવવા માટેની વેક્સિન એટલે કે HPV વેક્સિનના રસીકરણનો કાર્યક્રમ શરૂ કર્યો. એના માટે મોદી સાહેબને વંદન સાથે અભિનંદન આપું છું. HPV વેક્સિન 14 વર્ષની તમામ દીકરીઓ જેમને માટે 2 ડોઝ હોય છે એ આપણે સૌએ અપનાવી જોઈએ, સૌને એના માટે જાગૃત કરવા જોઈએ. આપણે સૌ જાણીએ છીએ તેમ સર્વાઇકલ કેન્સર એ સ્ત્રીઓના શરીરમાં થતું ગર્ભાશયના મુખનું કેન્સર છે. એનો ઇન્સિડન્સ આપણા દેશમાં ખૂબ વધારે છે અને તેમના મૃત્યુનું પ્રમાણ પણ ઘણું આઘાતજનક છે. અને આ એક જ એવું કેન્સર છે કે જે વેક્સિનથી આપણે અટકાવી શકીએ છીએ. એટલે એનો આપણે સૌ લાભ લઈએ. આવતા 8 માર્ચના વિશ્વ મહિલા દિવસ નિમિત્તે અમે પણ એક કેમ્પનું આયોજન કર્યું છે, જેમાં તમામ દીકરીઓને રાહત દરે વેક્સિનનો ડોઝ આપવામાં આવશે. બહેનો, જે 14 વર્ષની દીકરીઓ છે એમને 2 ડોઝ જોઈએ, એક 0 અને એક 6 મહિના પછી. જે દીકરીઓની અને મહિલાઓની ઉંમર 14 વર્ષથી વધારે છે તેમને 3 ડોઝ જોઈશે, 0 પછી 2 મહિના પછી અને ત્રીજો ડોઝ છે એ 6 મહિના સુધીનો. તો આપણે સૌ આ તકનો લાભ ઉઠાવીએ, કેન્સરના વેક્સિનેશનના રસીકરણ માટે જાગૃત રહીએ. અમારી માતૃ સંસ્થા જેવી કે સોગો, ઓક્સી, એમ્સ વગેરે સંસ્થાઓ અને IMA હવે એને નેશનલ મુવમેન્ટ તરીકે લઈ રહ્યું છે. એ સૌના સંયુક્ત પ્રયાસોથી આ કાર્યક્રમ શક્ય બન્યો છે. તો સૌ સર્વાઇકલ કેન્સર એટલે કે ગર્ભાશયના મુખના કેન્સર અટકાવવા માટે સૌ સાથે મળીએ, વેક્સિનેશન કરાવીએ. સર્વાઇકલ કેન્સર સૌથી વહેલું શોધી શકાય એટલા માટે પેપ ટેસ્ટના કેમ્પો પણ કરવામાં આવે છે, જંગ જાગૃતિના કાર્યક્રમો પણ કરવામાં આવે છે. એવી રીતે આપણે સૌ સહિયારા પ્રયાસોથી સર્વાઇકલ કેન્સરને અટકાવીએ.
હેલો,
ડોક્ટર દર્શના મેડમ નો હતો ને?
દર્શના મેડમ. હવે બીજું
મેડમ આમાં ક્વેશ્ચન આન્સરમાં માર્કિંગ
નહીં થાય, 0 મળે ને એમાં.
ઓકે મેડમ.
મેડમ અમનો ટાઈમ લિમિટ વધારે હતો કદાચ.
હા, વધારે હતી એટલે એ તમારી રીતે જજ કરી લેજો સર.
અમે ટાઈમ નથી આવતો ટાઈમર.
અચ્છા, આમાં 2:30 હતી, 2.5 મિનિટની આ રીલ હતી અને હવેથી છે ને અમે 1 મિનિટ પછી બંધ જ કરી દેશું.
ઓકે મેડમ. ઓકે
90 સેકન્ડ આપી છે ને આપણે એ લોકોને 90 સેકન્ડ આપેલી છે.
90 સેકન્ડ.
Theoretically.
Next. सबमिट कराया एक बेर में પછી સબમિટ થઈ ગયું છે તો પાછું ખોલવા જાઉં તો પાછું પહેલાથી ચાલુ થાય છે એટલે છેલ્લે જ કરવાનું છે ઇવન વન ના કરતી જાવ ને થોડો થોડો ડાયરેક્ટ તો બે કાયા ને
Sujat Wali, senior gynecologist in practicing in Godhra, Panchmal district for more than 30 years. From my experience, I have realized that we are losing many patients due to peripartum cardiomyopathy. They remain undiagnosed because we gynecologists are not completely aware about this condition, and we also don't realize the seriousness about this condition. The symptoms are extreme fatigue, breathlessness on exertion, and cough. If after delivery any patient suffer from these symptoms, they should be consulted by cardiologist and echocardiography should be done. If cardiac function is less than 45%, they should be labeled as suffering from peripartum cardiomyopathy and should be treated appropriately by the cardiologist on time so that mortality can be prevented. If we are not aware, if we fail to diagnose on time, if we fail to diagnose and treat on time, then these conditions may claim many lives in our society. Thank you.
presentation started. Concept presentation confidence.
Type available નથી ને
Double condoms give double protection? Hi, I'm Dr. Riddhi Godasra, and here are such 7 contraceptive myths busted with clinical evidence. Myth number 1, withdrawal is as effective as condom. Fact number 1, even foolproof timing isn't perfect because pre-ejaculate contains sperm and it offers zero STI protection. Myth number 2, one emergency pill a month keeps pregnancy away. But fact number 2 is it delays or prevents ovulation, but it does not disrupt an implanted pregnancy or it does not cause abortion. Myth number 3, contraceptive pills come with lifetime infertility package and it increases weight. But fact number 3, fertility usually bounces back once you stop the pill. And my friend, calories do the game. Pill usually does. Myth number 4, breastfeeding gives me free pass from contraception until years. Fact number 4, only for first 6 months until exclusive breastfeeding and periods have not returned. Myth number 5, copper T can get lost in my body. Fact number 5, it prefers staying in uterus, which is its home. Myth number 6, tubectomy causes early menopause as it stops periods. But fact number 6, your fallopian tubes retire, but your hormones doesn't. Myth number 7, vasectomy takes away man's masculinity. But fact number 7, it blocks sperms, not testosterone. Family planning is considered a women's job, but in reality, it is a team sport. And every couple deserves an evidence-based advice and not just a WhatsApp advice.
90 seconds. Sorry.
So, Riddhi Godasra, are you available? Just raise your hand if you are available or in the chat. If you are not available, we will move ahead without doing the question and answer. Okay, Riddhi Godasra, we are not getting any response in the chat also and hand raise also. So here we are just going to end the reel session and we are going ahead for the poster presentation session, right?
Okay. So how to compile this?
Yes, sir.
Just for compilation, because I will not be going to give marks for 2 students, number 6 and 7. So in totaling, you have to take care of that.
I didn't get 677. Which names?
Bipasha and Dhwani. I am not giving marks because they are students from our college.
Okay, that will be like.
Sir, it is okay. We understand you'll always be impartial. So you please go ahead with the marking, sir. No problem.
Because totaling just instead on behalf of me, somebody else can also mark that. So
No,
Ethel
sir. It
madam
is
or
okay.
can mark.
No, sir. It is okay. It is okay. Please go ahead with the marking, sir. No worries.
Okay. So, sir, please give your marking, no problem from our end, and we will going ahead. We will move forward for the poster presentation session. And the first presentation is in this the judge panel is Dr. Jitesh sir and Dr. Hital Patolia madam, right? And
I
we
am not in
will
there as a poster.
1 minute. I am not able to.
પોસ્ટરમાં જજમાં મારું નામ નથી.
1 minute, sir.
Sir, we'll continue.
Yeah, we will continue, sir. Sorry, I forgot.
Sir, if you can and if you have time, it will be an honor to have you, sir. So please, if you can continue.
No, madam, not possible now.
Okay, sir. No worries.
Jitesh sir.
મેડમ મારે ઓટીમાં જવાનું છે.
કશો વાંધો નહીં, sir. Thank you so much.
ઓકે, થેન્ક યુ મેડમ.
So who will be? So, Nitin sir, are you available over here? Nitin sir. Yes, Nitin sir is already here, no? Jitesh sir, thank you.
So it's a 11:45 session started now?
Yes, 11:45 session is about to start now. Bhavesh sir.
Hello.
Okay.
Yes,
you share?
Bhavesh, sir. Can you continue with us, or you're busy?
No, madam, I am not continuing with. I am a one OT is there and emergency is too.
No worries. Thank you so much for being with us, sir. Thank you.
Thank you, madam, to give the opportunity for that. Thank you.
We are honored, sir. We are honored.
Thank you.
So I welcome Nitin sir as a judge, and we have Hital Patolia madam as a judge over here in this session, and we are going to start with Dr. Utsav Kumar Vasani. Are you available, Dr. Utsav? Yes, we are making you a co-host.
1 minute, madam. Dr. Himani's mark is how to display in Google form or not appear in Google form.
Yes, that will be a problem. In a marking.
I don't have Google Forms. I am sending a photograph of the mark sheet.
Okay, send the photograph on the WhatsApp number.
No, sir, we can do one thing. Just whatever marking pattern is there, just put it in the message to Hital madam and this thing like Parul madam. Sorry, Sonal madam. So like internal discussion, you can do it later on and you can just give us the final marking. Because Google form is made yesterday and in that we cannot add the name at the last moment. So that's
I
why
have not received the Google form. I am only having that hard copy.
timer hटाओ.
I have only PDF only.
Jitesh sir, who is speaking this? Bhavesh sir, you didn't get, okay, you have only hard copy then. Oh, so sir, if possible, I can share you the Google link also.
Best. You can share with the Google form again.
Sir, I'll do. Our coordinator will share you the link. No problem, sir.
Okay, thank you.
Okay. Bhavesh, real session link.
Nitin, I'm Nitin. Nitin also.
Okay. Sorry. Nitin sir, I'll share you the this session link I'll share you. Poster presentation link I'll share you.
The poster presentation I have. Poster presentation link I have received the Google form. For the real one, I have only hard copy.
Real also I will share you. No problem, sir. So we are going to start now. So Dr. Utsav, your time is 6 minutes
Hello,
and 2 minute question answer will be there. Okay.
am I audible, sir?
Yeah, audible.
Okay. Good morning, respected judges. I am a second year resident of Sumar Medical College, Surat. I am doing a poster presentation on a rare case of second trimester unscarred uterus rupture under guidance of Dr. Ashwin Sir Vachan and Dr. Archit Sir Desai. Rupture of the sir, can you share our screen? Hello, hello.
You need to share your screen.
Okay, sir. Wait a minute. Is it visible, sir? Hello.
Yes, you are visible.
Yes, visible. You can start.
Okay, okay. Good morning, respected judges. I am a Dr. Utso Vasani, second year resident of Sumar Medical College, Surat. I am doing poster presentation on a rare case of second trimester unscarred uterus rupture under guidance of Dr. Ashwin Sir Vachani and Dr. Archit Sir Desai. Rupture of unscarred uterus is a rare and potential catastrophic event associated with severe maternal and neonatal morbidity and mortality. It is defined as a full thickness separation of the uterine wall and overlying serosa. According to ACOG, uterus rupture occurs in 1.5 per 10,000 births in patient without prior cesarean section. Case presentation. A 22-year-old Gravida 2, Para 1, Live 1, patient in 5-month amenorrhea, came to Stemmer Hospital with chief complaint of acute abdominal pain since 10 hours. The patient had no previous antenatal sonography with her. On examination, the patient temperature was 37.6 Celsius. Blood pressure was 19 by 60, heart rate 160 beat per minute. There was a sign of acute abdomen with diffuse tenderness and guarding. On speculum examination, the cervical was closed and there was no per vaginal bleeding. The patient was stabilized and fluid resuscitation immediately commenced. Urgent blood investigation sent off showed a full blood count with hemoglobin of 4.7 gram per deciliter. USC finding shows 4.9 by 1.3 centimeter size defect in the fundic region of the uterus with adjacent hemoperitoneum and intrauterine fetal death. Under general anesthesia, emergency laparotomy was performed. 2-liter hemoperitoneum drain along with 90-gram blood clots. On table finding, 7 by 4 centimeter size transverse rupture present over the fundus reaching left cornea with red margin up to myometrium and cavity open. Around 20 week size fetus ancet present in the abdominal cavity and placental base attached to uterine cavity. Both were removed. The rent was sutured with Vicryl-20 in double layer. Total of 4 units of fake red blood cell and 4 units of fresh frozen plasma was transfused. After monitoring the patient in the intensive care unit for 72 hours, she was shifted to general ward and was discharged home well on 7th post-operative day. Uh, as you can appreciate in first image, it is sonography image, which is showing uterine rupture, which indicated with arrow marks. Second picture, if you can show fetus with intact amniotic sac. Third picture, you can appreciate fundic region, uterine rupture scar, and in the last image, you can see is taken a double layer suture with Vicryl-20. Discussion. Spontaneous uterine rupture in second trimester of pregnancy without prior uterine surgery is extremely rare. Reported cases in the literature suggest underlying etiologies of abnormal placenta, implantation, and congenital uterine anomalies, such as a bicornuate uterus and uterine septum. In this case, no previous ultrasound was available for the placental localization. Injurious use of prostaglandin, multiple DNA, multiple pregnancy, or some other important preceding factor for uterine rupture. Occasionally, no underlying cause is found. Conclusion, as in this case, in cases of presentation with acute abdomen, uterus rupture as a differential diagnosis should be kept in mind. Clinical examination and early ultrasonographic evaluation helps in early and promote diagnosis. The patient was advised to uh, delays subsequent pregnancy. In this case of another pregnancy, vigilant monitoring in tertiary care center is advised from early gestation followed by elective cesarean section. Thank you.
Very nice presentation and a unique case.
Thank you, sir.
One
Thank you, sir.
question: was it preventable?
No, sir. In second pregnancy, you can prevent by delaying pregnancy and giving early care in tertiary care. But in first pregnancy, it is idiopathic in our case mostly, sir, because there is no available sonography or there is no available histopathology, so we can't decide is there any placental etiology or any uterine abnormality. So in our case, is mostly sir idiopathic, sir.
But monitoring of labor, use of partograph would have helped.
Yes, sir. In our case, is the second trimester, sir. So in
Okay.
second trimester, we can do the thing in third trimester, or in second trimester, it is very difficult to diagnosis if there is no available any ultrasound or any
But
previous history of
taking good
surgery.
history of previous surgery or something like
Yes, sir.
MTP or something.
Sir, there is no history of any MTP kill or any minor or major surgery. Patient is gravid to para 1 live and it was full term normal delivery, sir.
So, what
No,
did
he
you feel was the probable cause for this, Dr. Utsav?
Sir, ma'am, it is very difficult to comment on this case, but if we did early ultrasonography for uterine anomaly, or if we did any histopathological examination for placental etiology, so we can comment better on past or any uterine anomaly like septate uterus or biconate uterus, ma'am.
And where
In
was
this
the
case,
rupture?
ma'am, it was on fundus of uterus, ma'am.
Okay. So, probable cause also you could not find out retrospectively.
No, ma'am. It was in our case. It is very mostly, sir, ma'am, idiopathic. We can't comment on any diagnosis. So, ma'am,
Okay.
it is become a rare case of second trimester unscanned uterine rupture, ma'am.
Okay. Thank you.
Thank you, ma'am.
So thank you, Dr. Utsav. So we are ending your session now and we are going ahead with the another speaker. So thank you, Dr. Utsav again. And we will welcome Dr. Riddhi Unatkat. I think you are available, right? And we are making you a co-host. Just wait.
आता स्मित पटेल આવી
એક હું કહું તાનું
ન્યુઝીલેન્ડમાં તો
બે મિનિટ હું કહું તમને સો ડૉક્ટર રિદ્ધિ Dr. Riddhi, just unmute yourself and show your video. Yes. So can you share your slides from your end?
Yes.
Hello, Dr. Riddhi, am I audible?
Yes. Yes. Yes.
Okay, fine. So you can share your slides and you can start your presentation.
next करूँ ना
Hello, am I audible?
Yes, you are audible. Please share. Yes, you can start.
Sir, is my screen visible?
Yes, ma'am.
Visible.
Good afternoon, respected judges. I am Dr. Riddhi Unarkat from second year resident of obstetrics and gynecology department from Government Medical College and Sarti Hospital, Bhavnagar. Here I am presenting a case of DIC, prompt management can turn a nightmare into smiles. As you can see in the picture, after following abruptio placenta, patient went into PPH, AKI, and DIC. And now we will see how we turn the patient from chaos to the recovery by managing PPH, DIC, and AKI. Incidence of DIC and maternal mortality is very high following abruptio placenta. DIC and hypovolemic shock give rise to acute kidney injury in almost all patients of abruptio placenta. Dialysis requirements are up to 40% of the obstetric patients who develop AKI from severe placental abruptio, they require dialysis. And those who survive the danger eventually develops chronic kidney failure. So the mortality rate for obstetric patients who require dialysis due to severe AKI and associated coagulopathies hovers around 30%. Prompt multidisciplinary management is crucial to improve the survival in the critically ill patient. We'll see now how abruptio placenta adverse outcome will go into AKI. Early separation of the placenta and implantation releases thromboplastin, which leads to consumption coagulopathy and DIC, and uncontrolled bleeding, which further leading to hemorrhagic shock and hypoperfusion, leading to microvascular injury and AKI. Let me take you through the case summary of my patient. A 26-year aged third gravida para 2 live 1 woman with 31 weeks of gestation had undergone emergency LSCS in view of abruptio placenta with IUFD at a peripheral center. Intraoperatively, bilateral uterine artery ligation, V-Lynch sutures, and infundibulopelvic hemostatic sutures were taken there to treat the PPH, and 2-point RCC were given. The patient referred to Sarti Hospital, Bhavnagar, 3 hours after surgery with severe hemoperitoneum, profound hemorrhagic shock, severe DIC, and AKI. On admission, the temperature was cold and calming on touch. Pulse was not even recordable. Blood pressure was systolic was 60 mm of Hg in right brachial artery, and diastolic BP was not even recordable. Respiratory rate was 28 per minute. SpO2 was only 66% on room air. Urine output was just 10 ml since post-op, and drain output was 15 ml, which is blood stain from post-op. On per abdomen examination, abdomen was largely distended, drain was in situ, and uterus was well contracted and retracted, and dressing was dry and clean. On per speculum examination, 2 blood-soaked peg present in the vagina, bleeding was present and leaking from the pegs. Per vaginally, uterus was postpartum size and anteverted. Both the fornices were clear. On investigation, hemoglobin was just 4.6 gram percent. Total leukocyte count was 13,300. Platelet count was just 62,000. Serum create was high to 2.8 milligram per deciliter, and D dimer was more than 10,000. Fibrinogen degradation product was 11.6 microgram per ml only. Fibrinogen was 48.02 milligram per deciliter, and PTINR raised to 108 second and INR to 7.18. Let's see the sequential laboratory and clinical course during the hospital stay of the patient. On day 1, hemoglobin was 4.6. On sequential days, from day 1 to day 11, hemoglobin tend to go to 10.4. We have transfused 5 pints of RCCs to the patient. Platelet count was 62,000 on first day of admission. On day 11, patient platelet count were 1,45,000. Serum create was 2.8. Eventually, it went up rise to day 3 to 3.2, but eventually it go down to 0.9. PTINR was 108 by 7.18 on day 1 of admission, and it eventually goes down to 18 and 1.23. But not lab investigations are only important. We have to see the clinical course of the patient. So the abdominal girth was baseline on admission with 15 ml of blood stain drain output and 10 ml of urine output. After 12 hours of admission, baseline was raised to 3 centimeter. and with only the same drain output of 15 ml, and urine output was came to 85 ml. But after 28 hours of admission, it has rise up to 5 ml, 5 centimeter. On USG abdominal pelvis, it's suggestive of moderate hyperechoic fluid in the peritoneal cavity, which is suggestive of hemoperitoneum. After we have mobilize the drain, and when the drain is fully functional, on 28 hours of admission, 700 ml was drained from the hemoperitoneum, which was blood stain, with urine output of 1650 ml. After this mobilization and fluid in the drain come out, patients start to recover slowly and steadily. On 48 hours after admission, abdominal girth goes backline to baseline, and drain output was 300 ml, but now this is serous and not bloody discharge. And urine output was 2300 ml per 24 hours. On 72 hours of admission, abdominal girth was baseline, 25 ml of drain output, and urine output was 2800 ml for 24 hours. Thus, urine output was less than 50 ml for more than 24 hours. We have removed the drain on 4th day of admission. Let's see how we manage this patient. In critical phase of day 1 and 2, we had started noradrenaline support for as vasopressor, as patient's blood pressure was not recordable. We have approached the multidisciplinary approach and transfused the multiple transfusion. 3-pint RCC and 4-pint FFP was given on day 1 only. With vitamin K, broad spectrum antibiotics, and hydrocortisone, we managed the critical phase. Now shift to the recovery phase, which is from day 3 to day 10. Noradrenaline support was weaned off on day 3, as the patient's BP was came to 120 by 70/80. Additionally, 2 RCCs were transfused on day 3 and 4, as we need to go for hemoglobin of 7 to 8 minimum, and we have monitored the patient in HDU. And let's see the outcome. On day 11, we had seen the recovery fully. Hemoglobin was 10.2, platelet count were 1.45 lakh, PTINR was 23 second, and INR was 1.32. Serum create goes down to 0.9, and we discharge this
You
patient.
have 10 seconds to sum up.
Yes, sir. I'll conclude my slide with abruptio placenta may trigger a cascade of DIC, hemorrhagic shock, PPH, and AKI within 2 hours, but it does not have to define the outcome. This case demonstrates that timely recognition, rapid resuscitation, massive transfusion, and multidisciplinary collaboration and persistent critical care can transform a seemingly irreversible catastrophe into a complete maternal recovery. In obstetrics, victory is not achieved by one person or one surgery or by it is achieved by coordinated team efforts and multiple interventions. Take home messages: every minute matters, every decision matters, and every mother matters. We did not just save a uterus, we saved a life who had 2 little souls dependent on her.
So,
Thus, I conclude.
Yeah, respected judge, we have only 1 minute to question answer because she has taken the 1 minute extra.
Yes.
Dear sir, Nitin sir. Nitin sir, you are not audible and not visible also. Nitin sir.
Sir, are you with us? हाँ सर, अनम्यूट करो सबको.
Ask to unmute. We can ask.
Hello. Okay, good presentation. It was a very good presentation. What are the major patients you see for preventable approach in your practice now? Based on your study, as a carry-home message?
Sir, we get almost In a year, we get almost 100 to 150 patients with abruption placenta. Among them, 30 to 40% patients are coming up with severe abruption placenta, and they may go into the severe DIC and AKI. And when patients serum create goes more than 2.5 milligram per deciliter, it eventually goes higher up, and we need to shift patient to the physician side, and patient eventually went into CKD. But even after 2.8 create, and that may go rise to 3.2 create, we had successfully, without need for
What my
renal
question
replacement
is,
therapy.
for future, what will be the prevention stage to reduce AKI incident in abruption placenta?
To prevent the AKI in incidence of abruption placenta, we need to promptly and early detect the abruption placenta and timely resuscitate and timely manage the patient to may go patient into acute kidney injury in a severe form.
So do you have any data that after initial interim analysis, you find that these are the AKIs happening very large? So some of your intervention could have prevented the AKI, that comparable.
Sorry, sir.
After 100 patient of placenta, abruption placenta, how many turned to the AKI? How many you could prevent the AKI?
During my course of residency, sir, I have seen 50 to 75 patients go into abruption placenta. Among them, 10 to 20% patient went into AKI, and we have prevented among 10% of the patients from severe AKI.
Okay. So thank you, ma'am.
Yes, can we end the session now? Okay, so we will go ahead with the next presentation.
Thank you, ma'am. Thank you, sir.
Yes, so it's a very good presentation by Dr. Riddhi, and I would like to invite Dr. Palak Rajpal. Yes, I'll make you this thing. Dr. Palak, just wait. I'll make you co-host.
Who got this machine?
So, Dr. Palak. Dr. Palak, will you please unmute? And if possible, we want to see you also. And then you start presentation.
Yes, Palak, please introduce yourself. We can start. Your time is running out, beta. Hello, Palak, are you there?
You are unmute, but if you are speaking, we are not able to listen you. You are good. We are not able to listen you at all.
Not audible.
Hello.
Not audible.
Yes, yes. Sure. Yes. Dr. Palak, I think we are unable to listen you. So I think we will
We'll go with the
further.
next candidate. We'll come back to you, Palak, again if you are able to hear me. We'll again
Okay.
try your session. But just to save time, since we are running late, we are taking the next candidate.
Okay, so I would like to invite Yashvi Shah. Okay, Yashvi, wait. Are you able to speak now, Yashvi?
Hello.
Yes, is that Yashvi?
Yes, ma'am. Good
Yes,
afternoon, ma'am. Am I
please.
audible?
Yes, you are. Yes.
Make your video visible.
Yes, sir. Am I visible now?
Yes, yes.
Start now.
Please start.
Good afternoon, everyone. Myself, Dr. Yashvi Shah, first year OBGYN resident at GMERS Medical College and Hospital, Gandhinagar. I am presenting my poster on hydatiform mole under guidance of Dr. Runu Ghosh, ma'am, professor and head of unit at GMERS, Gandhinagar. Introduction. Hydatiform mole is a rare type of gestational trophoblastic disease, or abnormal pregnancy, where placental tissue grows abnormally instead of developing in normal fetus. Incidence of molar pregnancy is less than 1 in 1 to 600 to 1 in 1,000 pregnancies. So there are two types of moles, complete mole. An empty egg is fertilized, so there's no maternal DNA there, usually by one sperm that duplicates its own DNA, giving 46XX or rarely 46XY karyotype that's entirely paternal in origin. No fetal tissue forms, just abnormal swollen chronic villi. Partial mole. A normal egg is fertilized by two sperms, karyotype, or one sperm that duplicates, giving triploid 69 chromosome karyotype. Some fetal tissue may be present, but it is not viable. It's not visible. And here, maternal chromosome is present. Clinical features, vaginal bleeding in early pregnancies, uterus larger than expected for gestational age, markedly elevated beta-HCG levels, hyperemesis gravidum, early onset preeclampsia, thecal uterine cyst on the ovaries, and absence of heart tones. Diagnosis, ultrasonography, classical vascular or snowstorm pattern, serum beta-HCG disproportionately high, histopathological confirmations after evacuation. The main concern in progress to persistent or invasive mole is carcinoma or malignant form is one of the biggest complication. This is why beta-HCG level is critical even after apparently complete evacuation. Complete mole carries higher malignant potential than the partial mole. So there's around 15 to 20% higher risk in complete mole. So my case, a 22-year-old female primary gravida came with complaint of lower abdominal pain for past 2 to 3 days, which gradually increased in nature. Last menstrual periods were on 2nd of April 2026. Her past menstrual history was normal of 4 to 6 days and regularly for regular cycle of 25 to 28 days. Obstetric history, primary gravida with 9 weeks of gestation. Past history, the patient is a known case of pulmonary coach disease left side. Treatment completed in November 2025. For abdominal examination, on inspection, abdomen was normal, no scar marks, no dilated veins seen. On palpation, soft, non-tender. On post speculum examination, the cervix and vagina were healthy. On genital PV examination, os closed, uterus anteverted, uterus approximately 8 weeks in size, right side furnaces mild bulky, and left side furnaces were clear. So on lab investigations, her hemogram reports were normal with her hemoglobin 11.1, her total counts were 4,400, and platelets were 281,000, and RBS was normal of 112. So the patient was, for the beta-HCG level on baseline were 3,13,580 on 4th of June. The patient was planned for dilatation and evacuation on 5th of June, and post-surgery on day 4 post-surgery, that is 7th of April, 7th of June, the beta-HCG level had fallen significantly to 43,778. And then a week later, again, the beta-HCG levels had come down to 1,284. The patient was negative on serological examinations, and the USG on admission showed 56 into 42 sized mixed ecogenic areas within the internal tiny cystic areas noted in endometrium suggestive of H mole. So the surgical options were the surgery done was dilatation and evacuation. Intraoperative finding was multiple irregular grape-like brown and soft tissues material removed on dilatation and evacuation, membranes were removed, no fetal parts or fetal tissues were received. On histopathological examination, gross examination received multiple irregular brownish and soft tissue structures measuring 5 into 5 into 1.5 centimeters. Microscopic examination showed sections taken from received tissue widths, shows abnormal shaped, cystic dilated chronic chorionic villi, lined in proliferating trophoblastic cells also seen. At places, decidual cells were also seen. And above histopathological findings are consistent with clinical diagnosis of complete mole impression, complete hydatidform mole. So this was the USG done on admission at our LR, and this were the histopathological slides of the same patient. So the discussion, the molar pregnancy may seem to be a regular pregnancy at first, but most molar pregnancies cause symptoms that include dark brown, bright red bleeding from vagina during the first 3 months, severe nausea, vomiting, and sometimes grape-like cysts that pass from the vagina, and pelvic pressure or pain may be seen. Factors that can contribute in molar pregnancy includes early molar pregnancy. If one has had one molar pregnancy, the person is more likely to have another one. A repeat molar pregnancy happens on an average in 1 out of every 100 people. Age of mother, a molar pregnancy is more common in older age groups or young of 43 or more, and in younger age groups of 15 to or below. Pathophysiology, trophoblastic tissue proliferates excessively, and the villi swell with fluid, producing a classic cluster of grapes or snowstorm appearance on ultrasound. After
You are crossing your time limit, beta. Question answer session has to begin.
Okay. Yes, ma'am.
See, we have kept 6+2 for the posters.
Okay, ma'am.
So you had only one case, this one of molar
Yes, sir.
pregnancy.
Yes, sir, one case.
So total in your clinical exposure, how many GTD you had come across, and out of that, how many this one is a
Sir,
plastic
in my
disorder?
last 6 months of residency, sir, I have seen 3 cases of complete hydatidform mole. And all of them have turned out uneventful at the end. Patients have recovered, and there was no GPN that was noted in progression.
Okay. And this one has gone toward the malignancy.
No, sir, there was no malignancy in this patient. The patient has had a settled beta HCG levels now.
Okay. What is PSTT?
So per speculum examination and per vaginal examination.
PSTT is a placental-side trophoblastic tumor.
Sorry, sir.
Placental-side trophoblastic tumor. What is the difference from the molar pregnancy?
Hello.
Placental-side trophoblastic tumor is another variant of GTN.
Yes, sir.
So how will you differentiate from the complete mole?
So the USD findings are significantly different. So the snowstorm appearance or the grape-like structures which appear on the USG are more significantly showing towards the complete mole.
Okay. So next.
Hello.
Yes, Yashvi, thank you so much. Your time is up. Thank you.
Thank you so much, ma'am.
Palak, we are again retrying to get you. So, are you able to hear us? Unmute. Okay, we have unmuted you. Yes, now we are able to see you and hear you. Can you share, please? So, Nitin sir, this is Palak, the previous candidate.
Okay, ma'am. Okay, ma'am.
Yes. આમાં પાછું previous ના જાય ને
Ma'am,
Okay,
hello.
you can start. You can start. Share your screen and start.
Ma'am, I can't just share my screen because I'm.
Okay, technical team can share the screen.
Okay, we'll do that.
Thank you.
Okay, you can say next once you according to your part.
Okay. Good afternoon, ma'am. I'm a second year resident. I'm presenting a case of broad ligament hematoma, and I'm from Government Hospital, Bhavnagar. And the case was broad ligament hematoma following a normal vaginal delivery. Early recognition and emergency obstetric hysterectomy was done. Introduction. The postpartum hemorrhage remains one of the leading cause of maternal morbidity and mortality worldwide. The broad ligament hematoma is a rare but potentially life-threatening cause of concealed type of postpartum hemorrhage. It usually results from the trauma to the uterine or vaginal vessels during the childbirth and may rapidly progress to the hypovolemic shock if the diagnosis is delayed. Early recognition and prompt surgical interventions are essential to prevent the maternal mortality. Can you please change this slide? The aim was to present a rare case of broad ligament hematoma following the normal vaginal delivery and to highlight the importance of the early diagnosis of concealed type of postpartum hemorrhage and to emphasize timely surgical management, including of cystectomy in this last life-threatening condition like postpartum hemorrhage. So the patient was delivered outside the hospital and came with the bleeding PV, and per abdomen, the patient was abdomen was soft and tender on touch. Per vaginally, the bleeding was present, and the trauma to the uterine or cervical vessels during the labor was happened, and concealed type of broad ligament hematoma was there. Concealed postpartum hemorrhage and severe patient came with severe abdominal pain and continuous mild vaginal bleeding as soon as the pack was removed. And the ultrasonography was suggestive of hematoma, hypovolemia, and hemodynamic unstable patient was explored. The laparotomy was done, and crystalloid and the blood products was given. Massive transfusion in 1:1:1 ratio was given, and then surgical intervention was required. Then hemostatic sutures were taken, but the definitive surgery was done as an obstetric hysterectomy, and the patient was improved after that. These are intraoperative findings of pictures from the surgery. This is the broad ligament hematoma, which around 500 gram clots were evacuated, and then hemostatic sutures were taken. But eventually, we had to do obstetric hysterectomy in this patient. So my case summary is a 20-year-old female, para 6, live 6, was referred from the peripheral hospital after normal vaginal delivery, and her baby was 3.1 kg, male child, and with the complaint of lower abdominal pain and postpartum hemorrhage with the packs in situ. There were 2 packs. On arrival, the patient was hypovolemic shock and with pallor, tachycardia, and hypotension. The examination suggested concealed postpartum hemorrhage. After aggressive resuscitation with the intravenous fluids and blood products, emergency laparotomy was performed after diagnosis the broad ligament hematoma. Intraoperatively, the large left broad ligament hematoma extending up to the cervix. Because of ongoing bleeding and expanding hematoma, a subtotal obstetric hysterectomy was performed to achieve the definitive hemostasis, and the patient received the blood transfusion. The blood products were 9 RCC and 4 FFP and 4 platelet count were given, and 3 human albumin were given.
and the intensive post-operative care was given. The patient was shifted to HDU after operation, and she was recovered well and discharged in stable condition.
Okay.
The conclusion is the broad ligament hematoma is an uncommon life-threatening cause of concealed postpartum hemorrhage, persistent abdominal pain, shock, which is disproportionate to visible blood loss, and the falling hemoglobin after vaginal delivery should raise the suspicion, and the early referral and rapid resuscitation and timely exploratory laparotomy and obstetric hysterectomy when fertility preserving procedures fail are life-saving, and prompt multidisciplinary management significantly improve the maternal outcome.
Okay, good poster, yes, Palak.
Thank you.
But what could be the cause of hematoma here in your case?
Sir, there was a hematoma intraoperatively, and the
What could be the
bleeder
cause? Etiology.
etiology was the injury to the uterine or interiliac artery.
Why that injury could have occurred?
Sir, the patient was referred from outside. It was
But from the history,
and it could be the traumatic during delivery.
but as a treating team, what do you think? Was it a preventable thing or non-preventable thing?
So was the labor prolonged? Did they use forceps? Was it instrumental delivery? Did they do the kalla? You know, they in periphery they do those pushing and abdominal pushing and all. So did the patient undergo all those things?
No, ma'am. No, ma'am. No, there was no
Or
instrumental.
precipitate labor? Precipitate labor?
No, ma'am.
In short duration, from
No,
the
ma'am.
onset of labor pain to delivery of the baby in short times. So that can also lead to sudden change and can lead to injury, right?
Yes.
So if proper assessment of the pelvis, proper monitoring of the partograph, and mode of delivery, if we do, it can be preventable.
Yes, sir.
Okay, thank you.
Thank you.
Thank you.
મહેન્દ્ર ચૌધરી કામ કરેगा नहीं तो मीटिंग में जाएगा નથી ઓકે મહેન્દ્ર ચૌધરી
છે
એટલે આમાં નથી ને હરેશ ચૌધરી છે હરેશ ચૌધરી હશે
યશવી થઈ મહેન્દ્ર ને મેં જોયો હતો પણ જો ના આવ્યો હોય તો No, Dr. Mahindra is not there, right? So we will move ahead with Dr. Dara. Yeah, Dara is there. So Dr. Dara, are you available? Yes, can you unmute yourself?
Muted. Unmute करो.
Unmuted? Yes.
Okay.
Yes, Tara, we can see you, we can hear you. Now you can start.
Okay. Okay. Good afternoon, everyone. My name is Dr. Nora Rakesh Patel. I am second year resident of Obstetric and Gynecology Department at Narendra Modi Medical College. Today, I am going to present a poster on a case of Mullerian duct anomaly under guidance of my PG teacher, Dr. Rakshita B. Patel, my associate professor, Dr. M.J. Bizar, and my assistant professor, Dr. Roshni. So, present a rare Mullerian duct anomaly, transverse vaginal septum, septate uterus, cervical agenesis, and unilateral renal agenesis associated with congenital cervicovaginal fistula. As we all congenital malformation and upper data normally associated complications.
Dr. Dara, your voice is breaking actually.
Network is You can stop your video so that it will bandwidth will be okay.
Yeah, do one thing. Stop your video and just continue with your speaking.
Continue speaking. Hello.
Dr. Zara.
She has left.
No, she has come, sir, again.
Again,
She
okay.
left and she came again. I think we will give her a moment actually.
Okay, we can wait 1 minute.
Dr. Dara, if you can speak.
Yes, sir.
Yes, start.
Okay, sir, I am presenting a rare multiple duct anomaly, transfunctional septum, septate uterus, cervical agenesis, and urinator agenesis. As we all know, mullerian duct anomalies are congenital malformations result from abnormal development of the mullerian ducts affecting the uterus, cervix, fallopian tube, and upper vagina. They are commonly associated with primary amenorrhea, infertility, recurrent pregnancy loss, and obstetric complications, even the endometriosis. As we all know, the lower part of the vagina and the organs of the urinary tract is formed from the urogenital sinus. Embryologically, urogenital sinus and mullerian duct formation occur simultaneously. So, with mullerian duct anomaly, making the comprehensive evaluation essential. Now, presenting a case of a 28-year-old married into gravid woman with the main complaint of 9 to 10 months of amenorrhea. The urinary pregnancy test was negative and difficulty during sexual intercourse. She initially gave the history of achieving menarche at the age of 14 years, followed by irregular menstrual cycles for several years. Now, gender and its examination was unremarkable. Sexual characteristics were normal. Or vagina blind and taking approximately 1.5 to 2 centimeters.
We lost the voice. We lost the voice.
Sorry.
Okay. Continue. Change the slide.
Continue. Okay. Okay. So I'm hearing. So on per vaginal examination, we found the transfer vaginal history given by the patient that she achieved at the age of 14 years, followed by the irregular menstrual cycles. Now that was not fitting with that. So unfortunately, we came to know that she was taking the
We are not able to listen you clearly. Okay, we are able to read your slide, so don't worry. We are just looking through that.
Sorry, sir. Sorry.
Yes, continue.
We advised her for UST, and UST came with the bilateral ovaries normal. There was a septate uterus and endometrial thickness of about 8 mm. We found about 4 to 3 centimeter hypoechoic collection behind the transverse vaginal septum and suggestive of the hematoculpus. There was absent right kidney, suggestive of renal agenesis or ectopic or the atrophic kidney. Now, to confirm our UST findings, we advised her MRI, and MRI came with the septate uterus with hematoculpus, and there was actually absent right kidney. So it actually confirmed our UST finding. So with the provisional diagnosis, we concluded with this was a case of a mullerian duct anomaly. And for the symptomatic management, like a complaint of the patient of about difficulty in the sexual intercourse, we planned a vaginoplasty for her. So after completing all
Change the
necessary
slide.
fitness,
Slide change.
sir, actually continue each side.
Oh.
After completing all the pre-op fitness and pre-op findings, we took the patient for laparoscopic guided vaginoplasty under general anesthesia. Now, on laparoscopy, we found both ovaries adherent to the posterior uterine wall. Now, without doing anything with that, we put a stab incision at the center of the transverse vaginal septum, followed by a careful dissection between the bladder and the rectum to create a neovaginal space. Now, during dissection, approximately accidentally, we found 20 to 30 ml of clear fluid, and that raising the suspicion of iatrogenic bladder injury. So immediately surgical call was done. Retrograde methylene blue dye test was done. Surprisingly, there was no intraperitoneal spillage of the dye. So, but on close examination, we came to know that there was a delayed spillage of the dye in the vagina, the part of the vagina which was above the transverse vaginal septum. So, to confirm, the surgical team did the cystoscopy and they confirmed a vesicovaginal fistula with the tract extending from the posterior bladder wall approximately 3 centimeters below the left urinary orifice to the vagina. Now, on close examination, we came to know that it was not the acute tract, and we concluded with the diagnosis of congenital vesicovaginal fistula. Now, surgical team decided to do the left ureteric digest stenting, and they repaired the bladder opening of the fistula through a vertical cystotomy with a layered closure. Now, for the hematoculpus, we did with a 1 to 1.5 centimeter lower vertical incision, uterine incision, to drain the hematoculpus, which revealed cervical agenesis. Now, on doing so, we found that there was cervical agenesis. The uterine incision was closed in layers. The vaginal opening of the fistula was reconstructed and closed appropriately. Now, to prevent the risk of the fistula recurrences, a surgical team decided to put a vascularized omental interposition flap between the bladder and the vagina.
We can give
Sorry,
1 minute because technical issue.
Thank you, sir. Anterior and the posterior pelvic drain were placed. A silicone poly catheter was inserted for the continuous bladder drainage. And finally, for our neovagina, we put a vaginal mold made up of condom and the sponge was inserted.
Can you show the next slide? For want of time, just show the next slide.
Now, for the whole post-operative period, the patient remained hemodynamically and vitally stable. We put the patient on IV antibiotics for about 7 days. Poly's catheter was continued. Trains were removed after 10 days, and surgical team removed the left DJ stent after 1 month. Weekly vaginal bolt changes were done. Vaginoplasty healed approximately after 3 months, with hopefully improve her sexual function and menstrual outlook. Now, this case represents a rare combination of the septate uterus, cervical agenesis, congenital vesicovaginal fistula, and unilateral renal agenesis, highlighting the close logical relationship between the.
Because the time is up, ma'am.
Okay, Dhara, time is up.
So we had read your slides. Don't worry. We have read your slides. Go to your investigation slide. Can you show the investigation slide? Ultrasound. I want to see the sonography.
1 second.
Second one.
Okay, sir.
Okay. Right. So here endometrial thickness is given.
Yes, sir.
And you said it is a hematocolpus. So what is the
yes.
And on in your operative finding, you are mentioning you are opening the uterus vertically.
Yes, sir.
So that hematocolpus versus hematometra is not matching.
Sir, actually, that hematocolpus part is above the transverse septum, so it was not actually inside the uterus. It was
hematometra only. You said cervix is absent. There was no outflow tract. There was no outflow tract was there.
Yes, sir.
So it is a totally hematometra, na?
Yes, sir.
Okay, no problem.
Thank you.
Yes, we can. Thank you.
Thank you.
So the last participant of this session.
Yes, Dr. Mahib Agrawal. Course. Yes, Dr. Mahib Agrawal, are you there? Will you make yourself unmute? And turn on your video and share your slide. So are you ready? So yeah, you are audible. You can start now. Okay.
Good afternoon, everyone. I am Dr. Mahip Agrawal, second year resident of OBGY from Zydus Hospital, Dahod. I am here to present a case series poster on a feto-maternal outcome and the peripartum hemolytic trajectory of sickle cell disease complicating pregnancy tribal center. Sickle cell disease is especially relevant to us because Dahod is surrounded by the sickle belt, which is a burden, and it further complicated by pregnancy. Pregnancy amplifies the risk. It's hypercoagulable state, oxygen demand, venous stasis, provoke occlusive crisis, acute chest syndrome, and thromboembolies. While sickling in uteroplacental bed contributes to preeclampsia, fetal growth restriction, and stillbirth. Our aim is to be mainly measured here maternal and perinatal outcome, transfusion requirement, and importantly, the serial changes in hemoglobin, bilirubin, and LDH from admission to post-delivery day 3. Method we used was prospective observational study. We have study of 22
Change
patients.
your slide, please.
And yes.
Scroll up. Scroll up. Okay. Go ahead. Go ahead.
We studied 22 consecutive pregnancy with confirmed sickle cell disease. The mean age of the patient was 24 years. HBS was average 75%. We recorded the clinical outcomes, laboratory parameters at admission and again on post-delivery day 3. Since we paired both the observation, admission versus 3-day values, compare using Wilson-Koch sign rank test and p-values. The analysis statistic analysis were descriptive studies, median, paired admission versus day 3 comparison by Wills signed rank test, side effects of Hogman lens median, changes with 95% confidence interval, analysis and figures. Out of 22 pregnancies, 45% were primary gravida, 59% was LSCS rate, 82% was live birth, 14% was stillbirth. Mean weight of the baby was 2.2 kgs and 100% required blood transfusion. Mode of delivery was mainly LSCS and fetal outcome were abortion was 14% and live birth was 80%. Morbidity spectrum. Maximum seen was transfusion requirement and organomegaly. Peripartum hemolytic trajectory is shown at the day of admission and on the postpartum day 3. The mean change in the hemoglobin was 7.48 on admission to 8.92 on partum and post-operative day 3. Whereas in bilirubin on admission, it was near 3.46 to 2.28 and it decreases to 2.58 to 2.09. LDH was around 1324 to 400 and it decreased to 1000 to 300. WBC counts were increased on the time of admission from 35,000 to 51,000, but it came down on postpartum day 3 to 24,000 to 13,000. Platelet range was between normal in mainly all the cases.
WBC 35,000.
Yes, sir.
It's an average.
Yes, sir. Almost all patients which were admitted to us were having WBC's count more than 20,000 at the time of admission.
What is the normal range of WBC count?
Sir, in postpart, normal range is 5,000 to 11,000.
So if your average is 35, So there must
Yes,
be
sir.
highest and lowest very high.
Yes, sir. Uh, Discussion. A real danger is sickle cell disease sharply raises maternal perinatal risk, about 6 for higher maternal mortality in larger meta-analysis. R59 cesarean 14 stillbirth rates reproduce this in a Western Indian tribal belt. Severe from the outset, everyone needed transfusion, and every Arab Asian hemoglobin S haplotype thought to be a milder cause of acute chest syndrome, eclampsia, and crisis. None of them assume low risk. A recovery signal is by day 3 rose with 3 hemoglobin rose while bilirubin and LDH fell. Objective low cause evidence that hemolysis status once the transfusion and supportive cares are given. The danger is largely modifiable despite intensive care level. Illness, not one mother died. So early referral and structured multidisciplinary care can make the condition survivable. Mainly the conclusion is sickle cell disease turns pregnancy into high risk condition. In this tribal belt, every woman needed blood transfusion. Maternal complications were common, but 1 in 7 pregnancy ended with stillbirth. Yet the timely transfusion, supportive care, hemolysis settled, hemoglobin rose by day 3, and not single mother died, showing that grave risks are
Dr.
treatable.
Mahip, your
Serial
time is
bilirubin and
over.
LDH give a simple load.
Dr.
Yes, sir.
Mahip, your time is over. Now we will, if you want to sum up, you have 10 seconds and then we'll go ahead with the question answers.
Yes, sir. My mainly sum up is early recognition, early refer, ensure blood transfusion, and closely monitoring of this patient can save the mortality of this patient.
Okay. So what is the cesarean section rate in a non-sickle cell patient in your hospital?
Sir, 30%.
And in sickle cell patient, it is up to 60, 59%. You say.
Yes,
What
sir.
is the reason high section rate in sickle cell patients?
So mainly we have seen that many times when patient comes to us, there is at the time of delivery there is by default crisis. If patient is mainly having a complaint of pain, bone pains, limb pains, or there is increased bilirubin, or sometimes even there is fever and septicemia. So when if patient is in this condition, we have seen that many times it is by default MSL. If patient is not having any labor pain and we take it to cesarean, we have seen that patient are having MSL, means fetal is getting in distress. So if when it is 37 or 38 weeks, we suggest to the patient that if patient is not in labor, then and in crisis, so for patient may have say, stillbirth. So sometimes we go for elective CS in
But
such
it's
patients.
almost double.
Yes, sir. And many are previous CS and IUFDs, and mainly
Other
there
obstetric
are
indication. It's
obstetric
not because of
conditions.
sickle
Yes.
cell. It will be other
No, sir.
obstetric indication.
Yes, sir.
Okay. Thank you. Mahib Dharmendra Agarwal, right?
Yes, sir.
Okay. Thank you.
Thank you, sir.
Audible.
So thank you. That was a lovely presentation, and we complete this session. Thank you, Nitin sir, for being there with
Thank you,
us.
ma'am.
Can you continue in the next session also, sir?
Okay.
Great, great, sir. Thank
Just
you.
I need such 5 minutes, one or two phone calls by the
That
time.
is okay, sir. That is okay.
No problem, sir. And we will share you the link for the next session also with you so that you can just put the judge sheet, like you can mark in that
Okay.
sheet
Then,
actually.
yeah.
So I welcome Dr. Naisha also. Naisha Goel, madam. Madam.
Yes, am I audible, sir?
Yes, madam. Good afternoon, madam.
Okay, good afternoon.
Yes. So we welcome Dr. Naisha Goel, madam, as a judge. We have Dr. Hital Patolia and Dr. Nitin as a judge for this session. And we are going ahead with this poster presentation session. And we have first person, Dr. Rajvi Patel. I think she is there. Yes, I'll make you co-host, Dr. Rajvi. Just wait. I think you can unmute yourself now. Dr. Rajvi? Yes. Lovely. So now you can share your slide, share your screen, and start your presentation after sharing your screen. So if you want, we will share your slides from here, Rajvi. So when you want to
Okay.
change the slide, just say next. We will change from here.
Okay, sir.
Okay, start.
Am I audible?
Yes, audible.
Okay. Good afternoon, everyone. Myself, Dr. Rajvi Patel from SMEEM Medical College, Surat, here to present a poster on the topic Pregnancy Finding Hidden Cavity, Pregnancy in the Non-Communicating Horn of Robot Uterus, a rare clinical entity. Under guidance of Dr. Jitesh Shah, Professor, and Dr. Ashwin Vashani, Professor and Head of the Department. Introduction. Robot is a congenital Mullerian and characterized by asymmetric septus in which one cavity communicates with the cervix, while the opposite blind hemicavity does not. Pregnancy occurring in the non-communicating cavity is extremely uncommon and possesses significant risks, including uterine rupture, miscarriage, abnormal placentation, and maternal mortality. History, clinical examination, and investigations. A 32-year-old Gravida 9, Para 1, Live 1, Ocean 7 female was referred from private hospital with USG suggestive of missed abortion at 17 weeks. On examination, the patient was vitally stable. On per abdominal examination, uterus 16 to 18 week size, and on per vaginal examination, Paris Fox. Decision was taken for second trimester abortion in view of missed abortion. Induction of labor was done with mechanical dilatation and cervical injury. The abortus could not be delivered even up to 48 hours. Hence, decision was taken for hysterectomy. On laparotomy examination fine. So next slide. Next slide. Next, sir, can you change the slide? On laparotomy examination findings, prominent right horn was seen, bilateral ovaries and fallopian tubes normal. Incision was on the right upper segment of the uterus and abortus with the placenta was exposed. No communication was felt between the right horn of uterus and cervix. On pervaginal examination intra-op, communication was felt between the left horn and the cervix, hence suggestive of pregnancy in the non-communicating horn of overt uterus. Patient and relatives were explained about the anomaly and the risk associated with further pregnancies. Patient and relative didn't wanted further conception, hence bilateral tubal ligation was done. Discussion. In robot uterus, a asymmetric uterine septum that divides the uterus into two unequal hemicavities. One blind non-communicating hemicavity that with the functional endometrium but does not connect to the cervix. One communicating hemicavity that connects normally with the cervix and vagina. Normal external uterine counter that differentiates it from further uterine anomalies. Normal single cervix and vagina. Pregnancy in the blind cavity is exceptionally rare. Fertilization is thought to occur through transperitoneal transmigration of the sperm or the fertilized ovum. Diagnosis is usually made with resonating magnetic resonance imaging and 3D ultrasonography. Complications include hematometra, dysmenorrhea, endometriosis, and reproductive complications include infertility, recurrent pregnancy loss, miscarriage, preterm birth, fetal growth restrictions, malpresentation, uterine rupture, retained placenta, product of conception, and postpartum hemorrhage. The treatment is typically hysteroscopic septum resection, that is metroplasty, to unify the cavities and relieve the obstruction, or excision of the non-communicating horn. Conclusion. Robot uterus is rare because normally this anomaly often presents with obstruction and dysmenorrhea before conception. Pregnancy in the non-communicating horn of robot uterus is rare and potentially life-threatening condition. A high index of suspicion, appropriate imaging, and timely further surgical interventions are essential to reduce the maternal morbidity and preserve the reproductive potential.
Can you last slide? Can you show? Last slide we cannot see. Okay. So what is it in your day-to-day practice? What will you do with all dysmenorrhea patient?
Sir, depending upon the age of the patient, if she's nulli gravida or she's married, the management depends upon the age. We'll go with the age. Sir, we'll first do the investigations, ultrasonography and all. Sir, if it is managed medically, we can go with medical
So in
management.
imaging, so imaging is what, as you rightly mentioned in your conclusion. So would the imaging help you to understand the different types of the uterus anomaly?
Yes, sir. Usually 3D ultrasonography is useful in diagnosing various uterine anomalies because it will show the outer contour as well as the answer, including hysteroscopy, will helpful in visualizing the internal cavity of the uterus. And depending upon the diagnosis, we can manage further.
So it's even in the 2D grayscale imaging also appropriately tracing the endometrial cavity from the end to end, coronal section, sagittal section, and transverse section appropriately will raise a suspicion, and based on suspicion, you can go for the 3D and for then MRI accordingly.
Yes, sir.
If it is indicated.
Yes,
Nisha ma'am, any question? You have to unmute ma'am. Please unmute ma'am. Whole C team, can you
Yes,
unmute
yes.
Nisha ma'am? Okay.
Am I audible now?
Yes, ma'am. Yes, ma'am.
Yes. Okay, okay.
Yes, ma'am.
With the imaging modality, how can you differentiate that it is the Robert's uterus or this is the unicornuate and there is any rudimentary horn? Is there any differentiation?
Ma'am, first, the outer contour on the, if we go for 3D ultrasonography or invasive investigation like laparoscopy, the outer contour. In robot uterus, the outer contour of the uterus is normal. Ma'am, whereas if it is unicornuate uterus or bicornuate uterus usually will have indentation and there'll be a cleft in the cleft on the fundus. Then on hysteroscopic examination, if we'll go, ma'am, if it is unicornuate uterus, only single corona will be visualized. This will be same with the robot uterus, but the on 3D USG, there'll be a separate cavity will be visualized, ma'am.
Okay.
And mostly, ma'am, this patient present with hematometra. So the clinical and investigation findings will be seen accordingly,
Okay.
which may not be seen with unicornuate uterus.
Okay. Is there time left to ask?
Yes, we have 30 seconds more.
Okay. So after the definitive surgery, you told like after the accident of the rudimentary horn, yeah, accessory horn, how will you counsel the patient for the future fertility?
Ma'am, will counsel, ma'am, in my patient, the patient didn't wanted further conception, so we did tubal ligation. Same accordingly, if the patient doesn't want further conception, it is better to do the same. But if the patient wants further conception, ma'am, will ask her to avoid pregnancy, avoid pregnancy for at least 2 to 3 weeks post surgery, so that the complete solution and proper endometrial lining is formed, so that the further pregnancy implantation is better and the chance of abortion is less.
Okay. Okay. So thank you, Dr. Rajvi Patel, and we will end your session now.
Thank you, ma'am.
Okay, I'll just make you okay. So the thing is like just for the other participant, I'll just want to clarify that we have a timer of 6 minutes. In that you can present. If you want, if you can finish early, we will have more time to have a question answers. After 6, there is a time buzzer, and after that we will have 2 more minutes for the question answer. So after that we will stop your presentation. Okay, so hope you all have listened it. So now we are going further, and we have the next participant, Dr. Tanvi Patel, I think. Yes. So I'll make you 1 minute. Wait, Dr. Tanvi, I'll make you co-host. Yes, and now you can unmute yourself. And we will share your
Yes,
slides
sir.
from here.
Yes, sir.
Yes, right. So if you whenever you want a next, just say next. Okay. So all the best. Start.
Okay. Good afternoon, respected faculties, chairperson, and dear colleagues. I am Dr. Tanvi Patel, second year resident from Smimer Hospital, under guidance of Dr. Jitesh Shah, Professor, and Dr. Ashwin Vasani, Professor and Head of Smimer Medical College, Surat. I am presenting a case titled as When Benign Mimics Malignancy, a giant mucinous ovarian cyst adenoma presenting as a suspected ovarian carcinoma. Introduction. Giant ovarian masses measuring more than 10 centimeters are now uncommon owing to widespread use of ultrasonography. Adnation masses in the postmenopausal woman warrant careful evaluation because of the increased risk of malignancy. Large complex ovarian mass with elevated tumor marker and suspicious radiological feature may closely mimic ovarian carcinoma, posing a significant diagnostic challenge. This case highlights the importance of intraoperative frozen section in guiding appropriate surgical management and avoiding unnecessary radical surgery. Our patient was 60-year-old postmenopausal multiparous woman with known case of hypertension and type 2 diabetes mellitus. She was presented with progressively enlarging abdominal mass for 2 years associated with lower abdominal pain for 7 to 8 days. General examination, she was vitally stable. On per abdo examination, a large about 28-week predominantly cystic non-tender mass occupying the lower abdomen and extending above the umbilicus. Per vaginally cervix plus to vagina. Her serum Ca-125 was 82 unit per ml and serum CEA was 16 nanogram per ml, which both were elevated. Imaging revealed ultrasonography 25 by 17 centimeter complex cystic lesion with a 16 by 20 12 centimeter solid component. CCT abdopelvis revealed a 27 by 21 by 30 centimeter abdominopelvic mass with septation and heterogeneous enhancement, suggestive of epithelial ovarian malignancy. There were no para-aortic lymph node involvement or pelvic lymph node involvement was there. Next slide, please. Based on the CT findings and high RMI index, exploratory staging laparotomy was planned. Midline vertical incision was made. Peritoneal fluid sample was sent for cytology. As shown in the image 1 and 2, there was a 30 by 30 by 15 centimeter left ovarian mass with intact capsules about weighting of 8.5 kg was found. In spite of high RMI index and CT findings, intraoperative frozen section revealed a benign epithelial ovarian tumor. After this finding, surgical plans was completely changed. There was total abdominal hysterectomy with bilateral salpingo-oophorectomy was performed instead of cytoreduction and further staging. Final histopathology confirmed benign mucinous cyst adenoma of the left ovary with incidental findings included CIN1 and senile cystic endometrial atrophy. Change, please. Her RMI index was 738, which was more than cutoff value, that is 200, suggestive of the high risk of malignancy. Other index was also suggestive of high risk of malignancy. Giant benign mucinous cyst adenoma may closely mimic ovarian malignancy clinically, biochemically, radiologically. Although her CA-125 level and CA level was elevated, they were not diagnostic, and frozen section remains invaluable in determining the appropriate extent of surgery while preventing unnecessary oncological overtreatment. Conclusion: correlation of clinical finding, imaging, tumor markers, frozen section, and definitive histopathology is essential for accurate diagnosis. Frozen section optimizes surgical management, avoid overtreatment, and ensure favorable patient's outcome. References are mentioned below. Thank you.
Okay, then compared to the normal abdominal hysterectomy, any other complication you find in this case?
No, ma'am.
No, any other complication or any difficulty you found?
No, ma'am.
Okay.
Which are the other hormonal markers can be there for epithelial tumor apart from CA125?
Yes, CA125. There can be elevated CEA level, CA19/9. In this case, that can be elevated.
Any marker which is linked to RMI scoring or Roma scoring? Something is known as Roma.
Yes. Risk of ovarian malignancy algorithm. That includes CA125 and HE4 tumor marker and menopausal status.
Okay. Thank you.
Any other condition when the CA125 is elevated?
CA125 can be elevated in malignant cases like serous carcinoma, mucinous carcinoma, and other germ cell tumor and all. Even that can be elevated in benign conditions like pregnancy, menstruation, endometriosis, even fibroid adenomyosis, and other conditions too, which can which can be inflammatory, which can irritate peritoneal lining, and that can produce even in liver cirrhosis and else.
Okay, so Dr. Tanvi, I have one question. Suppose if the frozen section might have told you it is a cancer, not a mucinous cyst adenoma. So how will you proceed? How your team might have proceeded if it is a cancer?
We can do total abdominal hysterectomy with bilateral salpingectomy. After that, we can staging the whole uh, whole organs and all. We can palpate lymph nodes. We can measure the. We can palpate and evaluate the lymph node, that is para-aortic lymph node, pelvic lymph node. We can palpate liver, spleen, their structures and all, and
I
do
just
the
want to ask
cytoreductive
simply,
surgery.
have you taken the cytology before starting the surgery or no?
Yes, cytology sample was taken after opening of the peritoneum.
Okay. So staging surgery, you know the component. If you want, you can say very fast and then we can add. Staging
Staging,
surgery
that
for
is
the ovarian tumor. What is the component
one,
for that?
1, 2, 3. Okay. Stage 1, which
No, no,
include
no,
only.
no, no, no. I'm asking what will you do for the staging surgery for the ovarian tumor?
No, no, sir, I can't
Like
get it.
hysterectomy, you can do, just I'll let you know, bilateral lymph node dissection, para-aortic node dissection, and total omentectomy. That is the component of
Oh,
the
sir.
staging surgery, right? Okay, so it's a nice discussion and nice presentation. Thank you for that. So we will move ahead. May I, Dr. Naisha and Nitin, sir?
Okay.
Madam?
Okay, sir. Yes,
Can we
please.
move ahead? Yes. So thank you, Dr. Tanvi. I'm going for the next presenter is Dr. Haresh. I'm making you a co-host now. Wait. You can unmute yourself. And we will start your slide from here. Wait, give us the moment. Yes. So please start.
Good afternoon, respected judge, faculty, and everyone. I am Dr. Harish Chaudhary, a second year postgraduate resident from Department of OBGY, PDU Medical College, Rajkot. Today, I am presenting a maternal near miss case titled a near miss maternal near miss case of severe preeclampsia with cardiorespiratory collapse. Timely resuscitation and multidisciplinary management saves 2 lives. Maternal near miss refer to a woman who nearly died but survived a life-threatening complication during pregnancy, childbirth, or within 42 days after termination of pregnancy. Case summary: our patient, 31-year-old, third gravida, para 1, abortion 1, live 1, with 28 weeks of gestational age, referred to our hospital with chief complaint of breathing difficulty for 10 to 50 days and vomiting 2 episodes for 1 day. on admission, BP was 200 by 110 mmHg, pulse rate is 104 per minute, respiratory rate is 36 per minute, SpO2 95%, uterus is 28 week, cephalic, floating, FHS plus R, abdominal wall edema plus, PV os closed, non-FS, and urine albumin is +4. With high risk concern, emergency LSCS to be done. And on OT table, patient suddenly collapsed on OT table while shifting. BP non-recordable, pulse rate 29 per minute, SpO2 70% on room air, FHS plus R. Immediately, 3 cycle of CPR given with combined management by physician, anesthesia, and obstetrician and pediatrician. High-risk consent taken and explained regarding morbidity and mortality. And patient revived. Post-revival BP 180 by 110 mmHg, pulse rate 130 per minute. Thereafter, intubation done, SpO2 100% on FiO2 100%. Emergency preterm LSCS done under general anesthesia. Baby was live FCS 1.5 kg. Post-operative care, patient was shifted to ICU, higher antibiotics given, acidosis corrected, and IV nitroglycerin started. Combined physician, anesthetist, and obstetrician management done. Close monitoring for hypertension and management done accordingly. Routine investigation sent and treatment given accordingly. Patient discharged with healthy baby after suture removal. What we found the clinical challenge in this patient is severe preeclampsia with hypertensive emergency. Second one is pulmonary edema with orthopnea and oliguria. Third one is sudden cardiorespiratory collapse before induction of anesthesia. Fourth one is high risk to both mother and fetus. And other one is a need for rapid resuscitation and emergency delivery. What is our management approach in this patient is multidisciplinary, in which stabilization and assessment, then 3 cycle of CPR, then airway secured and intubation done, then emergency LSCS under general anesthesia, and then ICU care and critical monitoring, and multidisciplinary team involved, in which physician, anesthetist, obstetrician, and pediatrician involved. Outcome, mother successful resuscitation done, intubation stabilized and extubated on post-operative day 2, blood pressure controlled, no major morbidity, hemodynamically stable, discharged in stable condition on post-operative day 8 after suture removal, baby live female baby 1.5 kg, NICU care provided, and discharged healthy with mother. Why this case matters? Because cardiorespiratory collapse before giving anesthesia, rare event and critical. Successful CPR following emergency cesarean delivery, survival of both mother and preterm baby, excellent outcome through coordinated multidisciplinary approach. Discussion: this case highlights the classical example of severe preeclampsia with impending eclampsia and pulmonary compromise leading to immediate cardiorespiratory collapse, rapid deterioration during pre-operative period, the unpredictability and need for early identification of high-risk cases, timely decision for delivery preparedness and obstetric emergency and multidisciplinary resuscitation and teamwork were vital. Maternal near miss underscored the importance of system-based intrapartum care and critical care support in saving 2 lives. Thank you. Thank you.
Okay, a good case. So how many similar cases you had observed during your residency?
Sir, in my 1.5 year residency, I have 3 cases I have seen, in which 2 survived and 1 is expired. Okay.
What is the prevention?
Prevention is in high-risk patient, immediate multidisciplinary approach is the mainstay. Just like in this case, severe preeclampsia, and in OT table collapse, then we have to manage accordingly, not only by obstetrician, but by physician, anesthetist, pediatrician, and all departments. So this one is the high significant reduction in the mortality of patient.
First thing is identification. Which are the patient of high risk and what should be the mode of anesthesia? In your patient, what was the anesthesia mode? On table?
First, on table was planned for a spinal anesthesia, but after collapse, there was a plan for
So
general.
in case of severe preeclampsia, can we think of epidural or general anesthesia in advance?
Yes, sir. We can plan, sir.
Because chances of sudden hypotension with spinal anesthesia can make it very difficult to manage.
Yes,
so instead, if you take the epidural or GA, will be better, easy to manage.
Yes, sir.
Nisha, ma'am?
Did you prefer the prophylactic vaccine dose in this patient?
Yes, sir. Yes, ma'am. We are giving prophylactic next dose in this patient.
Okay, and sir, ask about how you prevent. So from the very antenatal, first trimester, how will you prevent such cases to severe preeclampsia?
Yes, sir. In first one, we have to identify iris factor. If in first trimester, if with iris factor along with the preeclampsia is there, we can start aspirin at in first trimester between 12 to 16 weeks, and we can continue till 30 to 34 weeks aspirin. Then we can continuous monitoring in every visit, BP monitoring, then urine albumin sugar monitoring we can done, so we can prevent the preeclampsia. And we can start antihypertensive at early when we found sign and symptoms of preeclampsia or any pre-monitoring sign we can found, then we can start early antihypertensive.
Okay, so just we will sum up now. So thank you, Dr. Harish, and we will go forward now. I would like to invite Dr. Vimla Chaudhary. Are you available over here?
Good afternoon, ma'am. This is a student from our college, so will not mark for her.
That's okay, sir. We don't mind.
Fine. Okay.
Actually, because you are you like nothing like that. No problem, sir. Okay, so I think, sir, Dr. Vimla is not there in our list. Uh, Actually, if Dr. Vimla, if you are there, just raise your hand. Okay, allow from the Priya Mistry screen. Okay, I'll do that. So, Dr. Vimla, are you there now?
Hello. Yes, sir.
So, Dr. Harish, you can now remove your video and you can continue like this thing with our presentation and all. So, Dr. Vimla, on the screen of Dr. Priya, right?
Yes, sir.
Okay, perfect. So, we will go ahead and we will share your slide. Hold a moment. Dr. Vimla, we have not. Okay, you can share your slide. Okay, start.
Hello. Yes, sir. Can you see the screen?
Yes, we can see. You can start.
Yeah.
Do the full screen and start.
Good afternoon, everyone. Myself, Vimla Chaudhary, presenting a case on ovarian tumor.
Do the full screen and
The top.
start. Dr. Vimla, sorry to interrupt you. Do the full screen and start.
Okay, sir.
Below, just beside 85 percentage, or wherever you are comfortable.
Sir, actually, it is not working.
Do one thing.
Yes, sir.
You can see the right corner 85 percentage. Just make it 100 percentage if possible. Or there is one more show on the top. There is a show.
Sir, I can't see the cursor only.
Okay, because you have not given us the access, we cannot do anything in your thing.
Full screen करिए कुछ.
Okay, anyhow, it's visible. You can continue. No problem. Leave it. Leave it. You can
Yes.
continue. No problem.
The title is The Frozen Verdict Guiding Definitive Surgery in Borderline Ovarian Tumors. The case description is a 47-year-old para 3 living 3 with a history of obstetric hysterectomy 22 years back. Presented with acute lower abdominal pain and vomiting since last 2 days. Patient was vitally stable on admission, and on examination, there was a smooth, mobile, solid cystic consistency mass measuring about 10 into 10 centimeter, felt in right iliac fossa, and no tenderness was noted. In per vaginal examination also, there was a mass felt of solid cystic consistency. Then USG was done that revealed a bulky right ovarian cyst measuring about 12 into 16 centimeter size, and vascularity was preserved on ultrasonography. After that, MRI was also done, and it confirms that it is a that is suggestive of serous borderline ovarian tumor. We have decided for exploratory laparotomy. Then right salpingo-oophorectomy with left salpingo-oophorectomy and bilateral pelvic lymph node sampling was done. Intracolic omentectomy was sent, and bilateral paracolic peritoneal biopsies was done. Then a frozen was sent with suggestive of serous borderline ovarian tumors. CA 125 was 7.2, and according to that, RMI was 64. That is suggestive of intermediate risk for malignancy. The gross findings were it is a 17 centimeter size and approximately 1.5 kg weight of cyst, and appearance was a large spherical unilocular cyst. Surface appears smooth and shiny. Final histopath reports were 17 into 14.5 into 1.8 centimeter, serous borderline ovarian tumor with micropapillary architecture, and psammomatous calcification was seen. There was no stromal microinvasion, capsule breach, ovarian surface involvement, or fallopian tube involvement, or any peritoneal implants, or no lymph node metastasis. Omental and peritoneal biopsies were negative for tumor, and the tumor was staged as FIGO stage 1A. The post-operative course was uneventful, and the patient was discharged in stable condition. The conclusion is borderline ovarian tumors remain a diagnostic challenge, and frozen section accurately guided the extent of surgery. Comprehensive surgical staging was completed during the same operation, avoiding re-exploration. Multidisciplinary decision making ensured adherence to oncologic principles. Early stages borderline tumors have an excellent prognosis following appropriate staging. Hello.
Yes.
Hello. Yes, ma'am.
Okay. It's complete.
Yes, ma'am.
Okay. So how will you differentiate from it's a borderline tumor or it's a malignant tumor?
Ma'am, in that all the features mainly suggestive of benign, and some features of malignancy are seen.
Like
ORAD's 4 or 5 stages, it is if it is not there in USG, then we suspect is a case of borderline tumor.
Okay. So in frozen section is coming like it's a borderline tumor, so no further oncological procedure you did.
Yes, ma'am. In this case, we have to do 3-month follow-up.
Okay. So in follow-up, what you examine the patient there, what investigation you did in the patient?
Ma'am, examination, we will do only per abdominal examination, and we have to do USG to see any mass at the site of ovaries, and we can also do CA 125 to see the regression.
Okay.
Okay.
So can we move ahead, sir?
Yeah.
Okay. So thank you, Dr. Vimla. Now I think there is Dr. Priya Mistry, right? So you are Priya
Yes, sir.
Mistry?
Yes,
Okay, fine. So we will share your screen, or do you share your screen?
I will share my screen.
Yeah, please share that.
Yes, sir. Yeah, poster. Yeah. My slide is visible or no?
Yes, visible. You're audible. You can start. No problem. That's fine. Perfect.
Yes. Good afternoon, everyone. I am Dr. Priya Misri, third year resident from OBGY, Paramswamy Medical College. I am presenting a case of high-risk surgical journey, managing giant multiple fiber in a morbidly obese woman with rheumatic heart disease. In our case, female was 35-year-old, para one living one, came to us with a complaint of heavy menstrual bleeding since 2 months, associated with passage of clot and regularly 3 to 4 pads per day. Her anthropometry was, her weight was 92.9 kg, height is 150 centimeter, and BMI was 141.3 kg per meter square. She was known case of rheumatic heart disease since 2022 and on medication. Her preoperative hemoglobin was 11.7 gram per deciliter, and she brought her USG at multiple uterine leiomyomas with largest size of 9.2 into 6.3 into 8.3 centimeter. We evaluated her and posted her for the abdominal myomectomy. Her preoperative optimization was multidisciplinary team. Our gynecology team, anesthesia, cardiac, and medicine. Optimization for risk of heart failure and anemia during intraoperative and postoperative period. Antibiotic prophylaxis was selected, and thromboembolic prophylaxis was given. Counseling regarding risk and possible need of hysterectomy was also done. Her intraoperative decision making. We attempted abdominal myomectomy. After opening, as you can see our intraop picture, we found multiple fibroid with distorted uterine anatomy. By anticipating excessive blood loss and underlying valvular heart disease and surgical difficulty, we decide to convert a total abdominal hysterectomy with frozen section intraoperative. Our outcome is patient is hemodynamically stable throughout intra-op and post-operative period. Post-operative recovery was uneventful, and our hemoglobin post-operative is 9.8 gram per deciliter. All evaluation for her cardiac condition was also done, and thromboembolic prophylaxis was given. Histopathology shows the during frozen leiomyoma with secondary changes, and later on histopath report came with a myxoid and fatty changes. Discussion coexistence of giant multiple fibroid, RHD, and morbid obesity significantly increase the operative complexity and perioperative risk. And intraoperative flexibility and timely decision to convert the myomectomy to hysterectomy can be life-saving. And multidisciplinary coordination is key to success the outcome in high-risk gynecological surgery. And my conclusion is individualized surgical planning through the optimization and prompt intraoperative decision making can safely achieve the favorable outcome in high risk patient with symptomatic uterine fibroid. And our take home message is in high risk patient safety and appropriate intraoperative judgment are more important than the initial surgical plan. Thank you.
Okay. Okay. So in myomectomy, can I ask now?
Yeah.
Okay. In myomectomy, what precautions you will take in pre-op and during intra-op to decrease the blood loss?
In preoperative, first she has a hemoglobin of 11. If she has hemoglobin low, then we will first optimize her with increased hemoglobin. And if she is on aspirin or any anticoagulant, we will stop that anticoagulant and optimize her according to cardiac and medicine advice.
Okay. Then
And
intraoperative, what you take?
intraoperative, we can use vasopressin to reduce the blood and for the hydrodissection.
Okay. Any other thing?
Other
to decrease the pelvic reduce the pelvic blood flow, we can also do prophylactic internal iliac artery dilation.
Okay. So during this patient's abdominal hysterectomy, do you find any difficulty than the normal hysterectomy patient?
Patient was morbidly obese, so that was one challenge. And for this much big scar, there is not proper visualization during intraoperative picture.
Okay.
Anatomy was distorted, so clamping was also difficult.
Okay. If anatomy was distorted, so which organ that is the most chances of the injury?
Injury to ureter is most common during anatomy.
Okay. So what are the sites where we can predict that is the chances of the ureter injury during abdominal hysterectomy?
Uh, During when a ureter crosses the uterine artery 2 centimeter lateral to the stomach, cervix, internal os, and during the clamping, if we are going for BSO during infundibulopelvic ligament, there is a chances of ureteric injury, and during the closure of vault, there is also chance the ureter can also involved in vault closure.
Okay, good.
So, madam, whenever you say, if question answer is over, we can go
Okay,
ahead.
now it's over from my side.
Okay. So thank you, Dr. Priya, and we will go further now. And I would like to invite Dr. Rutu Rajkumar Gupta. Are you there? You can unmute yourself now.
Hello.
Yes. Wait.
Hello.
Just, we will remove this slide actually. 1 minute. Priya. Priya, can you remove your slide? Can you remove this slide actually? Dr. Priya. Yes, now it is gone. So now, Dr. Rutu, uh, do we have his slide? So wait, we will just share your slide from here.
Okay. Okay.
Yes, here it is. Just make it zoom.
Yeah.
Zoom kar do. Okay. Is it
Am I
okay now?
audible?
Yes, you are audible. You can start now.
Good afternoon, everyone. Today, myself, Dr. Ritu Gupta. I am from Swimmer Medical College, Surat, and I am second year resident. I am presenting a poster on a topic of the intrauterine device. Introduction. Intrauterine device is one of the widely used reversible method of female contraception. There is a two varieties of intrauterine device used presently, copper releasing and leave-in orchestral. The rate of uterine perforation was found to be less than 1 per 1,000 users. Cause of immediate perforation can be faulty insertion or delayed maybe due to the device migration caused by uterine contraction. Perforation is either complete with device being totally within the peritoneal cavity or partial when some part of the device still lies within the uterine wall. WHO recommended that all the migrated intrauterine device following the uterine perforation should be surgically removed as early as possible. Sir, next slide. Case report. A 20-year-old female, Para2 Live 2, was presented to our institute with a complaint of lower abdominal pain since 2 months. She had undergone a copper incision 4 months earlier, immediately in postpartum period. On examination, patient was vitally stable. On per abdominal examination, there was abdominal tenderness and rebound tenderness was elicited in hypogastric region. On local examination, there is no active bleeding per vagina was seen. Past history on his history of full-term normal vaginal delivery along with copper injection 4 months earlier. We had done investigation. On investigation, UPT was negative and ultrasonography was done. On ultrasonography finding, uterus was antiverted, normal in size and ecotexture. There is no any focal lesion noted. Endometrial thickness was 7 mm. Endometrial cavity was empty. An approximately 2.6 centimeter linear echogenic structure noted outside the uterine cavity in left side, adjacent to the ileum. Possibility of migrated cooperative. Next slide. So the further management was done, and we have chosen for operated laparoscopically. On laparoscopically, uterus was normal in size and shape. Bilateral ovaries appears normal. Bilateral fallopian tube appears normal. There was found omentum was adherent to the anterior abdominal wall, and through which we can see the copperty was seen embedded within the omentum. Further management done after the dissecting the omentum. Cut end of thread was visible. Thread was grasped with atraumatic grasper and gentle traction applied, and copperty multilode 375 was successfully retrieved. Patient post-operative recovery was uneventful, and patient discharged on third post-operative day. Here are the two figures, and first one is a intraoperative procedure video version. Kindly, sir, play it. Hello. Sir, first figure is of intraoperative procedure is a video. Previous slide, sir. Previous slide, sir. From the figure 1, intraoperative procedure, there is a video we can forward the intra from the end to the momentum, and through the end figure we can demonstrate that the cooperative multirode 375 was seen. Next slide, sir. Discussion. The treatment of migrated intrauterine device is based on its location, presenting complaints, and organ involved. The most common organ reported to be involved following the uterine perforation is rectum, and many times it may see omentum, small intestine, sigmoid colon, or urinary bladder. The copper-releasing intrauterine device cause abdominal pain, omental adhesions, bowel perforation. It may be associated with the fever and intermittent diarrhea. The removal of the migrated intrauterine device can be carried out by minimally invasive technique. Thank you.
So what are the risk factors that leads to this condition?
First of all, we can there are the minimal patient can with abdominal pain can be there. There is a if a localized inflammation, if there the patient may be irritate the bowel and may cause the diarrhea, and patient may have sudden discomfort also felt. If and the copper releasing IUD may cause the localized inflammation in the abdomen, and further may cause the any different adhesions between the visceral organs may be there.
Okay. No, I'm asking you what are the risk factors when you are putting the copperty into the patient, and what are the risk factors that lead to this condition of the perforation, uterine perforation and migration of the copperty?
Ma'am, due to the faulty insertion may be done, or after the postpartum period, there is a uterine contraction may lead to the perforation during the perforation through the uterus.
Okay. And what is the difference between the misplaced copperty and displaced copperty?
Sorry, ma'am. Pardon.
What is the difference between the misplaced copperty and displaced copperty? Misplaced and displaced. What are the different terminology? Do you know about
Misplaced
that?
copperty. Misplaced property means it may be lie within the uterine cavity or partially within the uterine wall. A displaced property means it may be perforate and outer the uterine cavity and may outer the in abdominal cavity.
Okay. So, can we move on, madam?
Yes. Yeah.
Yes.
So, thank you, Dr. Ritu Kumar Gupta,
Thank you, sir.
lovely presentation from your end. So, now we will invite Dr. Brinda Subha. Are you there? Yes, you are there. Let me make you co-host. Okay, you are already co-host. Just make yourself audible. Yes, you are audible now. Yes, you are audible. Can you share the slide? Yes. Just yes. Here it is. Your slide. Can we start now?
Yes, sir. Good afternoon, everyone. I am presenting the poster on the Beyond the Scar, Uterine Istomosil and Under-Recognized Cause of the Abnormal Uterine Bleeding. I am Dr. Brinda Subha, second year resident of this Women Medical College. I am presenting this poster under the guidance of Dr. Jitesh Shah, sir, Dr. Anamika Majumdar, ma'am, and Dr. Meghna Shah, ma'am. Introduction. Uterine istomosil, also known as cesarean scar defect or a niche, in a late complication of a cesarean delivery, characterized by the myometrial defect at the previous uterine incision site. It may present abnormal uterine bleeding, a chronic pelvic pain, and secondary infertility or remain asymptomatic. Appropriate diagnosis and management are essential to improve the reproductive outcomes. A case report. A 37-year-old para-3 live-3 woman with the history of the previous three lower segment cesarean sections with the last cesarean section 3 years ago presented with the heavy menstrual bleeding, intermenstrual spotting, and dysmenorrhea. On examination, patient was vitally stable. On there is a soft non-tender previous cesarean scar was present, which was non-tender. On per speculum examination, cervix and vagina was normal. On per vaginal examination, uterus was anteverted 10 to 12 week size with the restricted mobility and bilateral phonesis free. For which the investigations were done, the transvaginal sonography suggestive of uterus was bulky with the globular about 446 by 56 by 100 mm square, suggestive of changes of the severe adenomyosis, and approximately 20 by 22 mm square blood-filled istomosil, a triangular unequal defect at the anterior lower uterine segment, for which the MRI pelvis was done as a confirmatory diagnosis, which suggestive of the bulky uterus of approximately 5.2 by 6.3 by 10.3 centimeter square sized, and also a defect of the 1.1 centimeter in the lower uterine segment at the region of the uterine scar, suggestive of the uterine istomosil. The below image USG suggestive of the uterine istomosil, and the same suggested in the MRI pelvis. For this, the management was done after an adequate trial of the medical management for 1 year. Her complaint of the dysmenorrhea and the heavy menstrual bleeding was relieved, but intermenstrual spotting persisted, disturbing her social and the personal life. The patient was informed about all surgical options, including the istomosil repair, but as she completed her family and had persistent symptoms, she refused for the further medical management and strongly desired for the definitive management. In spite of the repeated counseling, the patient underwent a total abdominal hysterectomy with the bilateral salpingectomy. Intraoperatively, while applying the clamp over the left side for the uterine artery ligation, during the dissection, istomosil opened up and the old dark clotted blood of around 20 to 30 cc drained. Post-operatively, uterus specimen was bisected in the sagittal plane, and defect was seen below previous caesarean scar on the left side.
Change the next slide. Slide.
Yes, change the slide. Sorry.
Oh, go ahead. Go ahead.
The Can we change to next slide, sir? Yes,
This
the
okay?
image both, yes, sir. Both the image showing the cross section of the uterus post-operatively, which is showing the uterine scar towards the left side. Uh, can you change it to the next slide, sir? So the discussion, isthmocele is increasingly recognized with the rising cesarean section rates. The diagnosis is primarily made by the transvaginal sonography, saline infusion sonography, hysteroscopy, or MRI. And the treatment depends on the symptoms, residual myometrial thickness, future fertility plan. Hysteroscopic or laparoscopic repair is effective in the women with the adequate residual myometrial thickness, while the laparoscopic or vaginal repair is preferred in the larger defect, whereas the hysterectomy offers a definitive treatment. For these cases, the references are mentioned below. Thank you.
Okay, good case. How you can reduce chances of isthmocele?
Sir, there is you can reduce by doing it is a non-interlocking sutures by uterine closure. Then if the uterus, if we have made the lower uterine cesarean scar more towards the cervix, it can hamper the healing. And if we have taken the cesarean section when the cervical dilatation is more than 5 centimeter or more when the lower uterine segment is much more thinned out, and if there is a previous adhesions were there in the previous Caesar scar, that can also cause the uterine scar to more do the outpouching. And also the double, if we have taken the proper single double layer uterine closure during the cesarean section.
Okay.
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 Yes, madam.
Okay. Why intermenstrual bleeding is occurring in an isthmosal patient?
Ma'am, due to there is a outpouching, there is a during the after the menstrual cycle of the female completes, there is a collection of the blood in the outpouching that will cause the intermenstrual spotting. If that collected blood will cause the intermenstrual spotting.
Okay. And if the patient don't want to do the hysterectomy and his family is not completed, then how will you proceed with that patient?
With the residual myometrial thickness, if we see if it is more than, according to the references, if it is more than 3 mm, we can do the hysteroscopic resection of the lower of the isthmocele. That will that will cause a less outpouching and that will cause a less collection of the blood. Or if the defect is much more and the residual myometrial thickness is very less, we can do the laparoscopic defect repair.
Okay. Then what will you advise her for the future fertility if you do the laparoscopy repair of that isthmosal?
Sorry, ma'am?
What will you give advice to that patient if you do the laparoscopic repair of the isthmosal for the future fertility?
We can advise that patient for the for the next pregnancy, if the patient wants the next pregnancy, we should take a regular checkup. And if she has complained, she can conceive, but we can plan the surgery according to we can terminate early if there is a risk of that previous scar rupture or opening.
Okay.
So thank you, Dr. Vrinda. Are you about to present one more session poster?
No, sir. No, sir. No, sir. I'm having only one case.
Okay, thank you. So thank you all for patience listening and
Thank you, sir.
I also want to a big thank you to Nitin sir and Naisha madam.
Thank you.
Thank you. Thank you so much.
Thank you.
So here we end our session and
Thank you.
have a nice day to all of you.
Thank you.
Thank you, sir.
અને કાઢી નાખીએ. એક મિનિટ આ બૃંદા સુબાને ફ્રી ઓફ કોર્સ કરો. શું કરતા તમે ઓડિયો ઓન જ છે ને? બંધ કરી દઈએ બસ. હવે આઈ થિંક મેડમને ને સરને બી જવા દઈએ ને પછી તમે જોઈ લો. બરાબર હા ને? ચાલો સાઈન કરવાનું.
એક મિનિટ ના બેગ
Video. Good afternoon, everyone. Myself, Dr. Hardik Chauhan. Welcome, Dr. Nalini Madam, and welcome, Dr. Neeta Madam. We are going ahead and waiting for Dr. Mayur sir. Our first presenter is Dr. Drashti Desai. Yeah, just unmute yourself. Yeah, go ahead.
Good afternoon, sir. My topic is extensive bilateral pulmonary embolism following total abdominal hysterectomy. It is a case report. Introduction: pulmonary embolism is a life-threatening complication resulting from obstruction of pulmonary arterial circulation by thromboemboli, most commonly originating from deep vein thrombosis of lower limbs. Major pelvic surgery, prolonged immobilization, and post-operative hypercoagulability are well-recognized risk factors. Early diagnosis and prompt anticoagulation are crucial to reduce morbidity and mortality. This case describes an extensive bilateral pulmonary embolism that developed following total abdominal hysterectomy with bilateral salpingo-hysterectomy. My case presentation: a 50-year-old female, para-4-LIFO, underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy on 12th July 2016 for heavy menstrual bleeding of 8-year duration. On second post-operative day, she developed sudden breathlessness and chest pain. She suffered cardiopulmonary collapse requiring 1 cycle of CPR at referring hospital and was intubated before transfer to ICU of Sir Takht Singh Hospital on 17th July 2016. On arrival, she was intubated and mechanically ventilated with respiratory distress. Her pulse rate was 140 beats per minute, blood pressure 90 by 60 mmHg, respiratory rate at 32 per minute, and oxygen saturation of 49%. She also had altered sensorium with poor peripheral perfusion. Now, about the laboratory investigation, initial investigations revealed hemoglobin of 10 gram per deciliter, serum creatinine 1.5 mg per dl, markedly elevated troponin I, D-dimer, and SGPT. Arterial blood gas analysis demonstrated severe hypoxemia with mixed respiratory and metabolic acidosis. During ICU stay, renal function improved while serial blood counts and biochemical parameters were monitored. Imaging findings that were found were CT pulmonary angiography confirmed extensive bilateral pulmonary embolism with hypodense filling defects at the bifurcation of both pulmonary arteries extending into segmental branches. There was no overt right ventricular strain on CT. ECG demonstrated sinus tachycardia with STT changes in leads V1 to V6. USG showed a prominent inferior vena cava and hepatic veins with minimal right pleural effusion. Risk factors and pathophysiology. Patient's pulmonary embolism can be explained by Virchow's triad. Venous stasis due to post-operative immobilization following major pelvic surgery. Hypercoagulability associated with surgery and acute inflammatory response. Endothelial injury resulting from hysterectomy with bilateral salpingo-oophorectomy. Additional risk factors which were specific to this patient include age of 50 years, recent major pelvic surgery, prolonged immobilization, chronic heavy menstrual bleeding, and anemia. Now about the management. Patient received IV unfractionated heparin infusion according to the weight-based protocol with a plan for transition to oral anticoagulants. She remained on mechanical ventilation with gradual weaning using CPAP as her respiratory status improved. Supportive ICU care includes IV fluids, all the antibiotics like ceftriaxone, metronidazole, pantoprazole, ornithine, strict fluid monitoring, catheter care, and pressure sore prevention. Continuous monitoring of vital, serial, arterial blood gases, ECGs, and echocardiography was advised. Clinical outcome: following anticoagulation and intensive supportive care, the patient oxygenation improved significantly, renal function returned to normal, hemoglobin stabilized, and there was no evidence of post-operative bleeding from hysterectomy site. She remained hemodynamically stable with progressive clinical improvement while continuing ICU monitoring. Final diagnosis, extensive bilateral pulmonary embolism involving the pulmonary artery bifurcation and segmental branches following total abdominal hysterectomy with bilateral salpingo-oophorectomy associated with acute kidney injury which was resolved. Conclusion of my case is this case highlights pulmonary embolism as a serious postoperative complication following major gynecological surgery. Early recognition of symptoms, prompt imaging with CT pulmonary angiography, rapid initiation of anticoagulation and intensive supportive management contributed to a favorable clinical outcome in this patient. Thank you, sir.
Can you repeat the high risk factors that you enumerated?
Yes, ma'am. The risk factors which were seen in my case were, ma'am, the age of the patient, that is
What was
50
the
years
age? You said, if
recent.
I'm not wrong, you said 50 years.
Yes, ma'am.
So is it a
Recent
high risk
major.
factor, 50 years?
Yes, ma'am.
Okay. What age is safe?
Safe age, ma'am, less than 45 years, I would say.
Okay, so if in that case, you imply that any patient who undergoes hysterectomy is high risk?
Yes, ma'am.
What other high risk factors you said?
Recent, ma'am, it is a major pelvic surgery. So it itself is a risk factor. Immobilization after this procedure.
How much immobilization was told to her?
6 to 12 hours.
So that is a risk factor, 6 to 12 hours of immobilization. How much immobilization should we advise to a patient post-operatively?
Within 6 hours, we should immobilize the patient.
Okay. So you are doing C-section, right?
Yes,
So you
ma'am.
immobilize the patient in 6 hours.
After 6 hours, ma'am. मतलब
6 hours means એટલે બેટા અત્યારે બપોરે 12 વાગે સિઝેરિયન થયું તો તારું પેશન્ટ કેટલા વાગે ઇમોબિલાઇઝ થશે?
6 વાગે, ma'am. 6
વોકિંગ
વાગ્યા
એડવાઇસ
પછી.
કરો છો તમે?
Sorry, ma'am.
કરો છો તમે ઇમોબિલાઇઝેશન 6 કલાકમાં?
Yes, ma'am. 6 કલાક પછી position change, मतलब they can change the
હું એ જ
position.
કહું છું કે મને એ લાગ્યું કે you are not understanding what does immobilization understand.
Yes,
તું
ma'am.
પોઝિશન ગુજરાતીમાં આન્સર કરી શકીશ બેટા. તું પોઝિશન
ma'am.
ચેન્જ કરવાની વાત કરે છે કે તું વોકિંગ એડવાઇસ કરવાની વાત કરે છે?
Position change, ma'am.
તો એમ કે you are saying immobilization અને પછી તું વાત કરે છે પોઝિશન ચેન્જ કરવાની. So there are two type of exercises post-operatively. One is
Yes,
active,
ma'am.
one is passive. What do you mean by passive exercises? How do they affect the prevention of these type of risk factors? What was the BMI is also one question I want to ask about this patient. You have not mentioned about in the risk factors. As she was 50 years and you are saying high risk, I can say that 50 years can be a high risk in few circumstances. You might be right.
Yes,
I
ma'am.
just want to know the BMI.
26, ma'am.
26 means what was the weight?
Wait, ma'am. 84 around.
84 around. And height?
Height, ma'am.
So you mean to say she was moderately obese with abdominal
Yes.
obesity,
Yes,
laxity
ma'am.
as well? Okay, so these were two high risk factors.
Yes, ma'am.
So, okay, that's fine. So it is only one case you have presented.
Yes, ma'am.
So, Dr. Neeta, you want to ask anything? Hello.
Hello, Dr. Mayur Gandhi has also joined. So, Dr. Mayur, would you like to ask any questions? I think there is no response, but are we audible? Madam Nalini Ben, I think it's done.
Yeah, we can do good presentation, Dr. Drishti. And it was nice case that you have said, and
Thank you, ma'am.
good attempt.
Thank you, ma'am.
What is the name?
Bansuri. Dr. Bansuri Gajjar is there? Dr. Bansuri, Dr. Dhwani.
Yes, sir. Good morning. Good afternoon.
Yeah. Dr. Dhwani Solanki. Please unmute. Dr. Dhwani Solanki.
Good afternoon, sir. Yes.
Yes, go ahead.
Please unmute yourself and start your video.
Dhwani Solanki.
Yes.
And for all our respected judges, now the next talk is by Dr. Dhwani Solanki. So please mark accordingly.
Yes, ma'am.
Good afternoon. Myself Dhwani Solanki from APJ from Pramukh Swami Medical College. I am presenting case of clinical outcome in antenatal patient of patient ductal arteriosis with Eisenmenger syndrome. Eisenmenger syndrome, wherein patient with long-standing congenital left to right cardiac shunt develop a reversal of blood flow or bidirectional flow, which belongs to class 4 of modified.
Dr. Dhwani, can you switch on your video, beta?
Yes, ma'am.
Make it full screen. Dhwani.
Yes, ma'am.
Yeah.
She left to do it.
Yeah. Good. Go ahead.
Continue, bacha.
Yes, ma'am. My slide is visible.
Yes, it is visible, beta.
Yes, go ahead.
Proceed.
Yes, sir. मैंने क्या नहीं देखा थी दीदी स्लाइड नहीं थी सारी देखा है चलो बनावा नहीं देखा थी
Hello. Is there any problem?
Yes, sir.
Go ahead.
Presenting case of patent ductus arteriosis with Eisenmenger syndrome in antenatal period. Eisenmenger syndrome, wherein patient with longitudinal congenital heart disease with bidirectional blood flow, which belongs to class 4 class 4 class 4 cardiovascular risk sorry.
Is there any technical problem?
Yes, sir. I am not. Yes, sir.
Do you have a physical copy?
Yes, sir. Yes, sir.
Go ahead with that.
Yes, sir. Eisenmenger syndrome introduction, wherein patient with a congenital heart disease with right to left cardiac shunt, which chronically is perceived leads to reversal of blood flow, which is called Eisenmenger syndrome. This falls in WHO class 4 category, which lead risk of maternal mortality risk of 30 to 35%. I can't. Next. Sir, I am not able to change my slides.
You have to change it from your side. Here,
તમે જે સ્ક્રીન શેર કરી છે ને એમાં જુઓ ને પેલું જે પીપીટી ફૂલ સ્ક્રીન કરી છે એને સિલેક્ટ કરો.
કઈ વાંધો નહીં બેટા, તું ચાલુ રાખ તને જેમ ફાવે. તું ભલે પ્રેઝન્ટ નથી થતી, તું બોલી લે, નો પ્રોબ્લેમ્સ બેટા. રાઈટ મેમ, સોનલ મેમ.
તમારી પાસે ફિઝિકલ કોપી હોય એની સાથે કન્ટિન્યુ કરો એ જોઈને. સ્લાઇડ
That's okay. Don't worry. You can start it that way.
Don't take stress અને હાથમાં લઈને જેમ રીતે તને ફાવે બેટા બોલી જાનો, કઈ વાંધો નહીં.
Yes, ma'am.
स्टार्ट कर जल्दी.
A 20-year Nali Gravida, fourth Gravida, 33 abortion, attended our emergency department, 8 months of amenorrhea, with chief complaint of hemoptysis, hematuria, and dyspnea on moderate exertion, which associated with chest pain since 1 day. She was diagnosed polycythemic in early pregnancy since this pregnancy, and had a history of anorexia and weight loss since 2 months. Her vitals on admission were a pulse rate of 100 beats per minute, palpated on radial artery, respiratory rate of 28 per minute, BP was 130 systolic, and diastolic was 86 mmHg. SpO2 saturation was 70% on room air, on right foot, right thumb, and the on inhale oxygen 86% on an NRBA mask at 15 liters. On examination, differential bilateral clubbing and pedal edema grade 1 present. She was diagnosed with a 31 weeks 2 days breech pregnancy with severe hypoxemia. Screening to the echo suggestive of sinus venous atrial septal defect and severe suprasystemic pulmonary arterial hypertension. Then CECT were suggestive of pulmonary alveolar CECT findings suggestive of pulmonary alveolar hemorrhage or an infective etiology likely. Thus, broad spectrum antibiotics, cefosalvectam, initiated. She also received tranexamic acid, low dose aspirin, and the proton pump inhibitors, and the course of antenatal steroid. Diuretics, and besides round the clock monitoring and supervision at ICU admit. The repeat bubble contrast, repeat 2D echo bubble contrast suggestive of large patent ductal arteriosis with Eisenmenger syndrome, with suprasystemic pulmonary hypertension. And she was initiated after this diltiazem 30 mg, and then she underwent emergency LSCS under general anesthesia for Eisenmenger syndrome with breech in preterm labor. She delivered 1.03 kg female baby. She was on continuous, and then postpartumly she was on continuous mechanical ventilation and ICU admitted, and exhibited a gradual decline from third post-operative day, and she developed the tachycardia, and the digoxin therapy started, and went into bradyarrest and demise on 7th postpartum day. Her infant is in stable condition on room air. The conclusion discussion, the congenital in Eisenmenger syndrome is placed under category of according to adult congenital heart disease anatomic and physiological classification into category D, and the incidence of Eisenmenger syndrome is 1 per 2000
So
births.
it is placed in category D. What do you understand by that?
Category D means is Ma'am, it is a physiological stage according to ACHD staging according to congenital heart disease anatomy wise physiological staging Eisenmenger syndrome with suprasystemic hypertension and the Eisenmenger syndrome in stage D.
What do you understand by stage D is what I want to ask you. What do you interpret out of saying it is in stage D? Leave it. No need to read further. Anyways, time is up. So let us ask few questions.
Yes, ma'am.
What do you understand by stage D? Actually, pregnancy is contraindicated in Eisenmenger syndrome. Do you know why? What is the other syndrome other than Eisenmenger amongst the cardiac anomalies in which it is contraindicated?
Ma'am,
One is Eisenmenger. What is the other one?
Other is ma'am aorta aortic disease, Ehlers-Danlos syndrome, mitral severe mitral stenosis.
No. My question is better, very specific. Pregnancy is contraindicated in one other thing. Okay, tell me. I have told you that it is contraindicated, right? In Eisenmengers. Now this patient had previous 3 abortions.
Yes, ma'am. Recurrent.
Was she an undiagnosed case of Eisenmengers?
Yes, ma'am.
Until when was she diagnosed?
She diagnosed after admission in Sri Krishna Hospital after 3 days. Ma'am, first screening echo at Sri Krishna Hospital even suggestive of AS atrial septal defect, likely sinus venosum.
Okay,
Then
and no
two
history. All her life, no history suggestive of any cardiac abnormality. So
No,
big
no,
and
ma'am.
Eisenmengers, no abnormality. Okay, thank you. Any other judges, please? I'm done from my side.
Should we go ahead, madam? Any other questions?
From my side, it is done, sir.
What is the
Dr. Gandhi,
hemodynamic
sir?
change? What are the hemodynamic changes in patients with Eisenmenger syndrome?
Yes, sir. Right ventricular failure. It's right ventricular failure, tachycardia. Sir, tachycardia leads to arrhythmia and a sudden increase in preload of due to the sudden decompression of aorta due to the postpartum में right ventricular failure पे preload वधी जाए. Leads to tachycardia and then
What do you mean by peripartum cardiomyopathy?
yes, sir. Decrease ejection fraction.
Okay.
Nalini Ben, were you talking about Marfan syndrome? I just for my knowledge.
Yeah, ma'am.
Yeah,
There are 2
okay, na?
conditions. Yeah,
Because
ma'am.
I had one patient with Marfan and we had
Yes, ma'am.
positively.
Absolutely
This
right.
is just for
Actually,
their information, the students'
no, ma'am.
information.
It's actually
Okay.
contraindicated in books. It is written that 2 syndromes, one is Eisenmenger and second
That
is
is right.
Marfan's. Pregnancy is absolutely contraindicated, and if at all we come to know, they hardly actually reach. Earlier, it used to be that they hardly reach to the age of 18, 19 years
Yes.
and get married. But that's what was my concern. As she was pregnant for the first 3 times. Somebody could have told her not to conceive and go for adoption or something, and maybe just that.
Just I wanted to confirm my knowledge. That
No.
is
Yes,
it
ma'am.
perfect?
You
Okay,
are
thank
absolutely
you.
right, ma'am. Absolutely right, ma'am.
Thank you.
Yes. Should we go ahead with the next speaker, next
Yes,
presenter?
sure.
The next presenter is Dr. Dhruvi Bojani. Dr. Dhruvi,
Sir.
yes, please unmute and
Okay, sir.
okay, go ahead.
Sir, it's my slide visible?
Yes,
Hello?
you are visible and audible. Please go ahead.
Hello?
હા બેટા સંભળાય છે અને તારા સ્લાઇડ દેખાય છે.
Hello, sir.
હેલો, you are audible બેટા, you can start.
Good afternoon, sir and ma'am. And my
Is there any technical problem? Dhruvi, please
hello,
start.
sir.
Please start.
Am I visible?
Yes, yes, चालू करो फटाफट.
Myself, Myself, Dr. Dhruvi Bhojani, first year resident in GMC Bhavnagar, under guidance of Dr. Rajni ma'am and Dr. Kanak Lata ma'am. Introduction. What is complex cyst? Complex ovarian cyst is an abnormal sac on or within an ovary that contains a mix of emergency gynecology. 60% is right-sided due to stabilizing effect of the sigmoid colon on the left side and longer right uterovarian ligament. Physiology of ovarian torsion. Cyst measuring between 5 to 10 centimeter pose the absolute highest risk of torsion. Mechanical overload. Once a cystic mass grows to 5 centimeters or larger, its physical weight overrides the natural stabilizing tension of this ligament. Uterovarian ligament pedicle rotation cause venous and lymphatic congestion, progressive tissue edema, cause arterial compromise, and cause ovarian necrosis.
એવું લાગે છે ત્યાંથી present. Nalini madam, are you audible?
Just it is very much. I mean, I just was changing my net. I thought that it's problem on my side, but the voice was not continuous from Dr. Dhruvi, whereas when you spoke, I could hear it.
Yes, the same problem is here. We cannot listen to her. I mean, not
So
very
I
clearly.
actually was changing net. I thought, okay, is it because of my problem from my side or is it from that side?
So
I
Dr.
think let me call someone at Bhavnagar and see if what the problem is.
No, we called her only, Dr. Dhruvi, and she is saying that she is presenting, but maybe it is not transmitted over here.
Yeah. So let us connect to some. Let me connect to some consultant there and then tell us the scenario. I just spoke to Dr. Mayur Gandhi, sir, and he is connecting to other residents somewhere, someone there, and just looking into it, what the issue is.
Save time, I think we'll take our next speaker.
Yes,
And
ma'am, can do that.
yes, that would be better. So
Yes,
may we
ma'am.
request Miss Bansri Gajjar? Is she there, Dr. Bansri Gajjar?
Yes, ma'am.
Yes.
So you can start your talk. We'll take Dr. Dhruvi's later on.
Okay, ma'am.
Share your screen and start.
You are also from Bhavnagar, Bansri?
No, ma'am, from Karam, sir.
No problem, no problem. I just thought you are very clearly visible. Maybe we can tell you she can come with you later. No problems, Bacha. All the best. Start.
Thank you, ma'am. Is my screen visible?
Yes.
Good afternoon, everyone. I am Dr. Bansri, presenting from Sri Krishna Hospital, Karam, sir, under guidance of Dr. Nitin, sir. I am presenting a case of a 26-year-old fourth gravida, previous to normal deliveries with 1.5 months of amenorrhea. She underwent a suction and evacuation for a presumed failed intrauterine pregnancy. And on post-op day 8, she presented with severe lower abdominal pain, nausea, vomiting, and abdominal tenderness. The patient on examination was conscious and hemodynamically stable with localized abdominal pain and tenderness. Lab investigation revealed persistently elevated beta HCG and severe anemia. USG findings were suggestive of heterogeneous loculated pelvic collection, which was likely to be a hemoperitoneum. So decision was made for emergency laparotomy, and intraoperatively 150 ml of hemoperitoneum was drained. Left side ampullary tubal rupture was suspect seen, and left salpingectomy was done. So during both suction evacuation and laparotomy, the tissue was sent for the histopathological examination, and that was consistent with the findings of the product of conception. Post-operatively, patient was shifted to ICU for brief intensive care monitoring, and blood products were transfused as per requirement. And post-operatively, beta HCG was done, which was found to be serially decreasing in trend. And my conclusion over here is that heterotopic pregnancy should be a differential diagnosis if a woman is presenting with severe abdominal pain post suction and evacuation, even in case of spontaneous conception. And the current incidence is increasing, 1 in 30,000 pregnancies. It is an uncommon but a potentially life-threatening obstetrical emergency, and careful evaluation of adnexa during the early pregnancy USGs can be helpful for the early diagnosis, and it reduces the maternal morbidity. And the below picture shows the intraoperative picture of the ampullary tubal rupture and the clots that were retrieved during the laparotomy. Thank you.
So, Bansri, I have a question for you. That when you said in a case of presumed intrauterine pregnancy,
Yes,
so
ma'am.
was it confirmed intrauterine pregnancy by ultrasonography?
Yes, ma'am. The USG confirmed, and there was no any other GSAC which was seen in the adnexa. Adnexa was normal in the USG, and only intrauterine pregnancy was seen at that moment.
Okay, one more question that I just want to know Okay, as per the weeks of gestation,
Yes,
was
ma'am.
the heterotropic pregnancy corresponding? I mean, the intrauterine as well as the extrauterine pregnancy, were they almost same?
No, ma'am. They were not same.
Okay, so
मतलब
what?
2 weeks of lag.
How much lag?
2 weeks of lag was seen, ma'am.
2 weeks lag was seen.
Yes, ma'am. According to the मतलब parameters in the USG.
Okay. So, can you think of anything? Can you interpret anything? Like, I mean, it was heterotropic and it was 2 weeks lag. So, what?
Ma'am, it can be मतलब super fetation या anything मतलब it can be possible, but here it was likely to be the heterotropic pregnancy. It can be मतलब luteal phase defect or something. Later conception can occur.
Okay, thank you from my side.
Thank you, ma'am.
Dr. Gandhi sir, Dr. Neeta madam, any question?
What are the high risk factors for heterotropic pregnancy?
Sir, IVF conceived pregnancies मतलब extremities of age can also any tubal
Why IVF
surgeries.
increases the chance of heterotropic pregnancy? What is the reason?
Sorry, sir.
Why IVF increases the chance of heterotropic pregnancy?
Sir, the मतलब overstimulation that मतलब in the IVF the ovulation triggers that we give or the hormonal मतलब the receptivity of the endometrium we choose an implantation window.
Okay.
But
Yes.
Other high risk factors?
embryo transfer will be in utero, beta.
Ma'am, multiple मतलब the at the
Your
same time.
answer explains intrauterine pregnancy. It will
Hmm.
be in utero, na? So how do you explain heterotropic along with it?
I mean IVF due to the मतलब, the trigger that we give, it can produce multiple ova. So at the same time, embryos can be fertilized. Or if any case of मतलब, infertility is due to any tubal causes of infertility, then there will be adhesions in the tube which can lead to the मतलब, heterotropic pregnancy. If at the same time two embryos have formed.
Judges, done. Can we
What
go
are the
ahead?
indications of medical management of ectopic pregnancy?
Sir, in medical management, if firstly the patient is hemodynamically stable, if the beta HCG should be less than 5,000 and the size of the GSAC should be at least less than 4 centimeter, then we can, and if the patient can come for a regular follow-up visits to us, then we can think of the medical termination of pregnancy.
Okay.
Thank you.
Can we go ahead?
Yes.
Yes. Thank you. It was a nice presentation. Our next presenter is Dr. Devdan Gadvi. Dr. Devdan.
Yes, sir. Good
Yes.
afternoon.
Please join.
Yes, sir.
Please go ahead. Hello.
Yes, sir. I'm sharing.
Yes. Please.
Go ahead with your presentation and if possible, put yourself also on video.
Yes, ma'am.
You can do it.
Ma'am, I'm sharing my file, but it's not showing on the
No, no,
screen.
let her do it. Yeah, it's there. અહીંયા
એ તો આ ચાલુ જ છે પણ આમનો ઓર્ડર
અચ્છા અચ્છા
અરે
okay.
Please start. Dr. Devdan.
Yes, sir. I'm sharing my screen, but it's not
No, but
getting
it is
shared.
seen on the screen.
Your screen is visible. You are not visible. Your screen is visible.
Yes,
We
ma'am.
can change the slides from here if you want to, because
Yes,
it is
ma'am.
there in our this laptop also. So please go ahead.
Yes, ma'am.
Please start.
Please start. Devdan.
Yes, sir. Good evening, judges. My Sir, am I audible?
Yes.
You are visible and audible. Please start.
Okay. Good evening, sir. Good evening, ma'am. My topic was on interstitial ectopic pregnancy. Interstitial ectopic pregnancy is a rare form of ectopic gestation, accounting for 2 to 4% of all the ectopic pregnancies. This was referenced from William 26th edition. Implantation occurs in the intramural portion of the fallopian tube, allowing the pregnancy to progress longer before the rupture. When rupture occurs, it can result in catastrophic hemorrhage due to the rich vascular supply of the uterine conduit, making early diagnosis and prompt intervention crucial in this case. Now, my patient was a 28-year-old lady referred from medicine department after her USG showed ruptured right-sided ectopic pregnancy. Clinical examination revealed abdominal tenderness with signs of peritoneal irritation. Transvaginal ultrasonography demonstrated an empty uterine cavity, a right-sided interstitial gestational sac with surrounding myometrium, and moderate hemoperitoneum. Emergency exploratory laparotomy confirmed a ruptured right interstitial ectopic pregnancy with massive intraperitoneal bleeding. Corneal resection with repair of the uterine wall was performed, achieving successful hemostasis. The patient received appropriate blood transfusion and post-operative supportive care with an uneventful recovery. Sir, can I see the second part? Because I'm not able to do it from here.
Okay.
The management part.
Madam, we need to change from there. What Devdan is
Yes,
telling,
so
he is
what
not
you
able to
can do
change
is
the
you can
slide.
just ask her to change. That's all. Yes.
Yes, ma'am. I want to see the management part that I have written in the second paragraph.
On the second side. So go down.
Yes.
Go down. थोड़ा नीचे जाओ. पहले ऊपर पाछा जाओ. Go back. नहीं go back. On this side it is management.
Yes.
Yes,
Now
ma'am.
it is there.
Yes, ma'am.
Yeah.
Your back
Yes.
camera is on. Devdan.
Yes, sir. So can I start?
Yes, Dr. Devdan.
Yes, ma'am.
Continue and finish
Now
it.
the management was following the evacuation of the approximately 600 ml of hemoperitoneum and blood clots, the ruptured right interstitial ectopic pregnancy measuring 3 by 2 centimeter with active corneal bleeding was clearly visualized. Rather than performing a standard corneal wedge resection, a fertility preserving corneostomy was executed by making a meticulous linear incision directly over the antimesenteric border of the right uterine cornu to access the gestational sac. The products of conception were carefully evacuated from the rupture site with minimal disruption to the surrounding arterial tissue. While ensuring complete hemostasis, the incision and the myometrial defect at the rupture site were then meticulously repaired in two anatomical layers using absorbable suture, thereby securing the structural integrity of the uterine wall and preserving the patient's future reproductive potential. These are the intra-op images which I have attached. And in conclusion, I want to conclude this case by saying that ruptured ectopic pregnancy, interstitial ectopic pregnancy, is a life-threatening emergency requiring a high index of suspicion, early imaging diagnosis, and timely surgical management. Prompt recognition and intervention are essential for improving maternal outcomes and preserving future reproductive potential whenever feasible. Thank you, ma'am.
So
Thank you,
you
sir.
said early
What do you
diagnosis.
mean
Sorry,
by
sorry.
shock
Please continue.
index?
Sorry, sir.
What do you mean by shock index?
The shock index is uh, uh, mean arterial pressure upon heart rate.
What was the shock index of your patient?
Sir, it was I have calculated it. It was around uh, less around one, sir. One.
Around 1.
What do
Actually,
you
I don't.
how do you interpret
What
shock
is the
index around
predict?
1?
How it
Actually, I
is 1?
don't.
Tell me.
Actually, I don't actually remember the. I don't have the like
Okay,
reference
no
here.
problem. But how do you interpret shock index of 1?
Yes, ma'am. But it was mean
Because
arterial
you
pressure
said
was.
around 1. So that is why Mayur Bhai and myself have been, alarmed
Yes,
by
ma'am. Yes,
around 1
yes.
means what?
No, ma'am. It was not one.
Acha, tell me what is normal shock index?
Ma'am,
See, less than 0.7 is normal.
yes, ma'am.
And around 1 में 1 है कि 1.3 है कि 1.4 है makes a lot of difference in shock index. So this
Yes,
type
ma'am.
of answer has made us get alarmed.
Yes, ma'am. It was
So
0.
you said in your conclusion,
Hmm.
I mean, early identification, early diagnosis. Tell me, how do you diagnose interstitial ectopic pregnancy?
Ma'am, first of all, we did an USG, and in USG it was suspicious as it was
How do you
the
raise suspicion? What in sonography will raise a suspicion of interstitial pregnancy?
ma'am the intrauterine sac was empty, and at
Good.
the
One
interstitium,
thing. Then
and ma'am in the interstitium we could see that there is a myometrial section.
no, wait, beta. You said that you had suspicion.
Yes, ma'am.
So what do you mean by that? What is interstitial line sign?
Yes, ma'am. That is uh, around the gestational sac. There is a myometrial lining in the interstitial pregnancy.
How do you confirm? What is the gold standard to confirm interstitial pregnancy? Okay, no problems. So how will you distinguish whether the uterine sac is empty and
Yes, ma'am.
beta HCG would be more or some other risks of? So how will you confirm that it is not a cornual pregnancy but an interstitial pregnancy?
I mean, in my case, as the at first day the beta HCG was done, and the values were not on the decreasing trend; they were on the increasing trend. That is more than
But
33% on the
increasing
fourth
means
day.
what about the doubling sign?
Yes, ma'am. It was not.
Increasing trend, you said. Was it doubling or not? What are the
Sorry, ma'am.
risk
I
factors for
couldn't hear you.
interstitial pregnancy? What are the risk factors for interstitial ectopic pregnancy?
Ma'am, the most important restriction is the case in where the previous ectopic pregnancy, and then if
Acha,
there is a
wait. Previous ectopic you said. So which side previous ectopic?
ma'am, in the ipsilateral side, if we have done the salpingectomy in the previous case, then there are more chances of the stump to receive the implantation. So interstitial is the more
Okay,
common in that cases.
okay. What else?
Ma'am, if there are any tubal deformity, like if salpingitis is there, or if any pelvic
That
inflammatory
is
disease
for
is there.
any ectopic. That is for any ectopic.
Yes, ma'am.
Specifically for interstitial.
Yes, ma'am. Any for interstitial, if salpingectomy is done, then it is specific for the interstitial pregnancy, ma'am.
Okay, what Nizar has asked something about. Okay, you tell me what is the role of medical management in case of interstitial ectopic pregnancy?
Ma'am, we can do the management, medical management, if the patient is stable, the
One, good. Then
and if the patient is stable and
cut off
it is
the
not
HCG.
ruptured.
How much?
It
That is
should not.
fine. What is the cutoff for beta HCG?
Ma'am, it was 4,000 microgram.
It's 5,000. Good attempt. Very near.
Okay.
Okay,
And
just with your common thing, you have said so much about that. I just want to know, what do you think for how will the patient behave with medical management with interstitial ectopic pregnancy?
the presenting signs of the patient.
No, beta.
No. Once you start medical management, what will happen?
Yes.
What is the normal course after medical management?
Okay, sir. After the medical management, we have to see the beta HCG trends. That is,
No,
if the
no,
beta.
no, no. You're not getting our question.
Okay, ma'am.
I mean, we are doing medical management.
Yes, ma'am.
And it is not an ectopic pregnancy. It is an interstitial ectopic pregnancy.
Yes, ma'am.
What do you expect? How will the patient behave with medical management? Your video has gone. Your video has
Am
gone,
I
doctor.
visible, ma'am?
No, you are not visible. Your video has gone. Anyways, no problems. You just have to apply a little common sense. You said something, what happens around the sac?
Around the cornua.
What is there, what is present, which is not present generally in ectopic? Myometrium you said is there, na?
Myometrium is there.
So,
So it's
will
not
it
there
have
in.
any relationship on drug penetration?
Sorry,
Theoretically.
ma'am?
Will it have any effect upon drug penetration?
Ma'am, if it ruptures, then after giving the medical management and
Okay,
it,
no
it.
problem. No problem. No problem. Thank you. Good
Yes, ma'am.
attempt.
Thank you, ma'am.
Yes. Okay. Can we go ahead, madam?
Yes.
Yes, sir. Yes, sir.
Yes. We will get back to Dr. Dhruvi again as her technical problem is solved. Dhruvi,
Okay.
please join. Yeah.
You can start with where you left, Dhruvi, wherever you are comfortable with.
Please go ahead. Fast.
Good afternoon, sir and ma'am. My topic is ovarian cysts presented as ovarian torsion, a critical case study on emerging diagnostic, surgical execution and application technique at 30 Hospital, Bhavnagar, under guidance of Dr. Rajni ma'am and Dr. Kanak Lata ma'am. Introduction. What is the complex ovarian cyst? Complex ovarian cyst is abnormal cell on or within an ovary that contain a mix of solid tissue, fluid or blood, unlike simple cysts which hold only clear fluid. Ovarian torsion is the fifth most common gynecological emergency. Prevalence is 2.7 to 3% among emergency gynecological admissions. Highest incidence occur in women of reproductive age. Of almost 70% of the case of the ovarian torsion occur in reproductive age group. ovarian torsion most commonly right side due to stabilizing effect of the sigmoid colon on the left side and the longer right due to ovarian ligament, which cause ovarian torsion on right side. Physiology of torsion. Mechanical risk cyst measured between 5 centimeter to 10 centimeter pose absolute highest risk for torsion. Once the cystic mass goes to 5 centimeter or larger, its physical weight overrides the natural stabilizing tension of this ligament. This causes pedal uterovarian ligament rotation, causes venous and lymphatic congestion, causes progressive tissue edema, arterial compromise, and causes ovarian necrosis. Our patient, 34-year-old female, presenting with OPD, pediatric light with history of previous to LSCA, presenting with right-sided ovarian pain and significantly increased intensity over the past 2 days. USC finding shows 5 to 6 centimeter size well deep and unequal cystic lesion with septation arising from right ovary. Left ovary status is normal and appendix is also normal. We rule out appendix abnormality before right-sided lower abdominal pain. MRI finding suggests a complex cystic lesion measuring 5.5 to 5.3 centimeter masses in right ovary. Intraoperative finding shows right-sided 5.6 centimeter translucent fluid cyst with three concrete rotation at the uterovarian ligament reflecting ischemic vascular compromise. We do right-sided ovarian cystectomy and ovarian ligament plication. Other management option, if patient is hemodynamically stable, we go to laparoscopy, which is gold standard method. If patient is hemodynamically unstable, we go for laparotomy. If a patient is stable, we also do detorsion, which and cystectomy. On end, do right ovarian ligament, uterovarian ligament plication, which prevent recurrence of the further case of the torsion. Definitive surgery, salpingo-oophorectomy, removal of ovary and fallopian tube, which done in post-menopausal woman, gangrenous or disfiguring tissue or suspected malignancy. Discussion. Ovarian ligament plication stabilize hypermobile ligament and significantly prevent retorsion. Conservative detorsion and cystectomy preserve normal ovarian reserve and endocrine function of the ovary, make it the preferred approach for nullities and reproductive age women. Since between 5 to 10 centimeter range, billions are high mass with sufficient abdominal space between freely which cause ovarian torsion. Conclusion. Early recognition is critical to prevent infection and compromise fertility. Prognosis. Prompt surgical intervention allows full functional recovery of the affected ovary with long-term hormonal preservation. Thank you, ma'am and sir.
What is the role of uporopexy?
Uporopexy.
Ophropexy.
So, uterovarian ligament which cause further torsion in next episode.
Okay, what are the chances of ovarian salvage when we operate on a case of torsion?
I was completely reversible if diagnosed early and
Okay, thank you.
What is the clinical presentation of a patient with ovarian torsion? Dhruvi.
Right-sided abdominal pain, fever. If we do CBC, WBC raise.
What is the differential diagnosis of patients with ovarian torsion?
Degeneration of appendicitis.
What is the role of MRI?
You are not audible.
Sir, this is the confirm. Audible નથી થતું.
What are the
Sir,
ultrasound?
am I audible?
Okay, audible.
Okay.
What is the
Sir,
USG
MRI is the
finding?
definitive
Definitive. What is the USG
USG
finding?
finding.
USG findings of a patient with
USG finding.
torsion.
Translucent anechoic cystic lesion.
What?
Translucent anechoic cyst present in a right ovary.
Okay.
Is there any further questions?
If it happens during pregnancy, what will you do? If a patient
Sir, in
comes to you,
pregnancy, conservative. Okay, sir. If size is less than 5 centimeter, we do conservative management. If cyst size between 5 to 7 centimeter, we do ultrasound monitoring. And if cyst present more than 7 centimeter, we do surgical management. Because of high risk of torsion, malignancy.
can we do laparoscopy if patient is having 5 months of amenorrhea and ovarian torsion?
Yes, sir, we do.
Okay.
Because, sir, if this is an emergency condition which cause ovarian necrosis.
Okay.
Okay.
Should we go ahead?
Yes, sir.
Thank you.
Yes,
Thank you
yes.
so much. Our next presenter is Dr. Parul Gupta. Dr. Parul Gupta, please join.
Em có thể thấy luôn. Nhìn viên não người nào.
Good evening, judges. I am Parul Gupta. My topic for today's poster is Teamwork Saves Two Lives, Managing Primary Gravida with Rheumatic Heart Disease. Background: rheumatic heart disease remains a major cause of maternal cardiac morbidity. In developing countries, mitral stenosis MS is the most common valvular lesion encountered in pregnancy, and severe MS poses substantial hemodynamic risk due to physiological changes of gestation, particularly during labor, delivery, and the immediate postpartum period. Case summary: 29 years old, primary gravida, 30 weeks, 4 days of pregnancy, newly diagnosed rheumatic heart disease in the pregnancy, only when presented with progressive dyspnea at rest, NYHA grade 4, not able to sleep at night, and palpitation, giddiness, numbing sensation in legs and palms, basal cramps, no prior cardiac intervention, balloon mitral valvulotomy, anesthetist advised for BiPAP support, physician advised for furosemide drip, injection ceftriaxone, injection benzathine, penicillin stat, and patient stabilized hemodynamically after 3 days of continuous monitoring. Echocardiography reveals severe MS, severe pulmonary artery hypertension, right atrium, right ventricle, and left atrium IVC dilated. ECG reveals left atrial enlargement pattern, P mitral. Hemoglobin was 10.8. Coagulation profile was normal. Renal and liver function was normal. Cardiologist advised for elective LSCS, which avoids the hemodynamic stress of prolonged labor and Valsalva associated pushing. Patient kept in ICU for 27 days on treatment, tablet furosemide, tablet digoxin, and tablet metoprolol. Patient terminated at 35 weeks, male child, 1.5 kg delivered, kept under observation in NICU, later given mother side and well breastfed. Discussion:
RHD complicates 0.3 to 3.5% of pregnancy in endemic region, accounting for 50 to 90% of maternal cardiac complications. Severe MS in pregnancy requires early multidisciplinary planning and delivery by elective LSCS to avoid labor-associated hemodynamic stress. Anesthetist's goal was to avoid tachycardia, maintain preload and sinus rhythm, avoid sudden fall in SPR, achieved via slow titrated epidural technique. Vigilant postpartum monitoring is essential due to autotransfusion related risk of pulmonary edema in the first 72 hours, counseled regarding future contraception and consideration of balloon mitral valvulotomy and valve intervention prior to future pregnancy. Conclusion: every heartbeat matters. Multidisciplinary care transforms high risk pregnancy into success stories.
So, how long your patient is having RHD?
Ma'am, when it comes to our hospital, it is diagnosed.
No,
It
it
was
was not
newly
diagnosed.
diagnosed
It
RHD.
wasn't diagnosed earlier.
No, ma'am. One echo was done, and uh, in private, and then they referred that the patient to our center.
Okay. What is the effect of pregnancy on the disease?
Ma'am, in pregnancy, the preload increases, the plasma volume increases, and if the preload increases and the MS in severe MS, there is a risk of pulmonary edema and um, left atrium dilation.
What are the common RHD lesions in pregnancy in our country mainly?
Ma'am, most common is mitral stenosis.
How
and
common?
Most common is mitral valve
How
stenosis.
common is mitral stenosis? Most common, but how common? 50%, 60%? How much?
Ma'am, it is some 75%.
It's as high as 90%. You are right. It's the most common. Second commonest is?
Ma'am, atrial valve stenosis. Aortic valve stenosis,
No,
yes.
but when most common is MS, then second common has to be
Tricuspid valve stenosis.
first is stenosis. Then what will happen?
Yes, ma'am. Ma'am, mitral valve
Mitral wall
prolapse.
stenos. Mitral wall gets stenos. Then what will happen if it is if I tell you it's as high as 90% MS? Then the second commonest would be what?
Pulmonary.
MR. MR.
Yes. Regurgitation. Yes, ma'am.
You know, stenosis and then right.
Then there is
next common.
regurgitation.
Then what is the next commonest?
Aortic stenosis.
Yes. Okay, so how do you risk stratify a patient with this? How do you classify the risks?
Ma'am, according to NYHA grading, the patient comes in grade 4, and
Okay.
because the patient having restlessness even at rest also.
Good. Then
Breathlessness. And according to WHO classification, it is also in WHO classification 4.
so how do you monitor her antenatally? In the antenatal
Ma'am,
period, how do you monitor?
Ma'am, patient comes to us at 30 weeks, 4 days. Patient was on BiPAP support for 3 days. After that, we monitor her pulse rate and pulse rate, pulmonary edema, and the Krebs respiratory system. And the patient was on metoprolol and furosemide, and also on antibiotics.
No anticoagulants were started?
No, ma'am. For this patient, we have not started any anticoagulants.
Okay, what about prophylaxis she would require?
Ma'am, first of all, antibiotic prophylaxis she may require, and mostly in cardiac patients, we start anticoagulants like heparin and warfarin. Warfarin
You
from
start
second
both
trimester.
together, heparin and warfarin.
Sorry, ma'am.
You start both together. Warfarin and
No,
heparin?
ma'am. No, ma'am. There is a timeline. In the first trimester, we start heparin, and in the second trimester, we start warfarin till the 36 weeks.
Is
And
it
after that,
why you cannot give heparin in second trimester?
ma'am, it is not that key. We cannot give heparin in second trimester, but the warfarin cannot be given first and the last.
Good.
Mhm.
I'm done.
What are the contraceptive options for your patient?
So we can advise her progesterone only pills. Copper T can also be inserted, but the main thing is we cannot start OC pills because there is a risk of thromboembolism in these patients.
Okay.
Yes, sir.
Can we give trial of labor to this type of patients?
Ma'am, in
Previous, but with
no, ma'am, we cannot give trial of labor in grade 4 patients. We can give a trial of labor in grade 3.
so in which cardiac conditions we
Yes, sir. Yes, ma'am.
Done?
Yes, we can go ahead, I
Can we
think.
go ahead? Yeah.
Thank you, ma'am.
Thank you, Dr. Parul.
Thank you,
Our
sir.
next presenter is Dr. Srija. Dr. Srija? Yeah.
Yes, sir. Good
Good.
afternoon, all the judges on the other side and my fellow mates listening. I am Dr. Srija Aghera from SSGH Hospital, second year resident, and presenting a poster today on OVIRA syndrome. OVIRA stands for obstructed hemivagina and ipsilateral renal agenesis. It is a rare congenital uterogenital malformation. We had a patient, 22-year-old married woman, presented with a complaint of foul-smelling vaginal discharge and a lower abdominal pain since 1 month. Her menstrual cycles were regular and scanty with dysmenorrhea. On examination, her abdomen was soft, cervix was not visualized on post-speculum examination, and there was a bulging of left lateral vaginal wall and a cystic tender 6 cross 7 centimeter collection, which was thin, yellowish, and white, foul smelling discharge. On per vaginal examination, exact size of uterus could not be made out, and the collection in the left paravaginal space could be felt. In the right, and the right fornix was clear. Then further we proceeded with a USG examination. 3D USG pelvis and abdomen examination was done, which was suggestive of didelphys uterus with bicollis, left hemivaginal collection 2.8 cross 3 centimeter, and left kidney was not visualized. Further imaging modality we preferred was MRI pelvis, plain plus contrast, which is gold standard for diagnosis of syndrome. It was suggestive of Mullerian duct anomaly, that is ASRM class 3, which is American Society of Reproductive Medicine class 3, and Escher, that is European Society of Human Reproduction and Embryology, U3B, C2, and V2. Uterus didelphys with double cervix, left hematocolpus, that is which was due to obstructed hemivagina of 4.5 cross 3.9 cross 6.8 centimeter, and left renal agenesis, which gave the final diagnosis of OVIRA syndrome. OVIRA syndrome is also called as Harlan-Werner-Wunderlich syndrome. And further on, we preferred for examining this patient under general anesthesia. And on examination, we found two cervix, bicornuate uterus, partial longitudinal septum in the upper two-thirds of vagina with obstructed hemivagina. And pus drainage and under general anesthesia, pus was drained around 100 cc, followed by diagnostic hysterolaparoscopy. I have shown the picture of the on laparoscopy that was suggestive of bicornuate uterus, and on chromoperturbation was done, and followed by excision of longitudinal partial septum was excised, and all the pus was drained, and patient was relieved with symptoms of cyclical pain and And further, I would like to say that this syndrome is a rare uterine Mullerian anomaly. 0.16 to 10% of only constitutes of Mullerian anomaly. And according to the Asian theory, the primary defect lies in a Wolffian duct, which connects our genital system as well as our renal system. And it is an Overa syndrome is a diagnostic challenge which requires an which can be uh, achieved by comprehensive medical history, physical examination, and MRI. MRI is a gold standard method for diagnosis of this syndrome.
Definitely a very rare case you have presented. I have two things to ask you. You are saying it is HWW syndrome and Overa syndrome. So what is the triad in Overa syndrome?
Overa syndrome triad is obstructed hemivagina with
Yes.
hematocolpos and ipsilateral renal agenesis.
Right. But there is uterus didelphys in HWW syndrome. But whereas you are saying it is bicornuate uterus.
No, actually, on a
You said
diagnostic
bicornuate, then you also said
hysterolaparoscopy,
okay, the two cervixes were seen.
yeah,
You
ma'am,
narrated it as that bicornuate and you said two services were seen. Plus you are saying HWW syndrome, Overa. So it has didelphys, not bicornuate uterus.
yes, ma'am. Actually, the USG and MRI reports were suggestive of didelphys uterus. And on DHL, diagnostic hysterolaparoscopy, the cornua we found was around suggestive of bicornuate uterus.
But then, beta, it will not become HWW syndrome. It would be some other abnormality. Second thing is that you said that there is problem in Wolffian duct development as well. In the end, you said, but you have written and you said in the beginning also, okay, it is a Mullerian duct anomaly. It is actually Overa syndrome is actually a combination of Mullerian as well as Wolffian duct anomaly. It is not only a Mullerian duct anomaly.
Yes, ma'am.
Right?
Yes.
So it is a really a nice case that you have presented, and gold standard also you have said. This actually is a differential diagnosis when you of Overa. Differential diagnosis of Overa is this case, that is bicornuate with hemi colpos. The patient did not have any complaints before she came to you. I mean, she's 27 years and she's married. So she did
Yes,
not have
she is
any
married.
despair complaints starting to dyspnea, no complaints during her menstrual cycle.
No, ma'am. She had a regular cycles, but she had complaint of dysmenorrhea and scanty menses
Okay, no problem.
and
Fine. Good case. Very
vaginal
good case.
discharge. Thank you.
Any questions from Dr. Gandhi sir? Dr. Neeta madam? Can we go ahead?
She's Shrija, right?
Yes, ma'am.
Thank you, Dr. Srija.
Thank you, sir.
Yeah. Our next presenter is Dr. Annie. Dr. Annie, please join.
Seems she is not present.
Annie?
Ma'am present, sir, present.
Yeah, please.
Great.
Emergency hai?
Yes, sir.
Okay.
Such you are a real gynecologist, bacha. Multitasking, emergency as well as case presentation. Kudos to you.
Yes, ma'am.
Go ahead.
Thank you so much, ma'am. Ma'am, may I start?
Please, better go ahead.
Okay. Good evening, ma'am. I, Dr. Andy Chapola, resident at GM Bhavnagar. My topic is a rare combination of morphological anomalies, back door and pregnancy.
Both screens you are visible, and so your voice is also breaking down. You can show the slides on one and you can be there. I mean, like the voice won't equal.
Yes, ma'am.
Annie, you are not audible.
અમે આપણે કોર્સ બનાવી દઈએ ને કોર્સ બનાવી દઈએ ને એટલે જાતે કરી દઈએ તો આપણે કરીએ ના હા એટલે પછી આપણે ટેન્શન
Annie, please start.
Please re-log in if it is not working.
સ્ક્રીન તો શેર થાય છે પણ એમને સ્ક્રીન ખોટી સિલેક્ટ
Phone लगाएगा. Where is he? Where is she?
Hello.
Sir.
They are trying, sir.
Yes. She logged out and I think she's trying to re-log in.
Yeah.
हमने फोन लगाया क्या? ठीक.
कॉल भी नहीं जा रहा है
अब स्क्रीन शेयर करो ना तारी
इसमें
तो एक महीना तक क्या हो गया ये दीदी वालों का
वही मेरे को भी.
ठीक है.
Hello, good evening, ma'am.
Just start.
Possible
May
है
I
तो
start,
PPT
sir?
शेयर कर दो.
Yes, sir.
इसको बोलो जो सर
मेरा खुला है मुझे भेज हाँ मेरे को भेज
PPT शेयर करो.
Yes, sir.
Yeah.
The connectivity problem.
Possible,
Okay,
then
in
start
case you
with
are
your
not able to
physical
do that.
copy. If you have any physical copy, then start with it.
Yes, sir. Good evening, sir. Today I, Dr. Annie, presenting my poster presentation on topic a rare combination of morphological placental anomalies, battledore and succenturiate lobe in a term pregnancy, under guidance of respected Dr. Rajni M. Parikh, ma'am. Introduction. Placental morphological anomalies are variation in placental shape, cord insertion, or lobulation, most often identified incidentally during antenatal ultrasound or post-delivery examination. Battledore placenta, marginal cord insertion, is defined as umbilical cord insertion within 2 cm of the placental edge, resembling the handle of a battledore racket. Succenturiate lobe is a smaller accessory placental lobe separate from the main placental mass, connected to it by fetal blood vessel coursing through the membranes. Each anomaly is well described in isolation. Their simultaneous occurrence in a single placenta is rarely reported and carries an additive obstetric risk profile. My aims and objectives are to report a rare case of coexistent battledore placenta and succenturiate lobe identified in a term pregnancy, to describe the antenatal Doppler and ultrasound profile associated with this dual placental anomaly, and to highlight the intrapartum vigilance and postnatal placental examination required to prevent complications. My background is the placenta normally develops as a single discoid mass with central cord insertion. Deviations in shape, lobulation, or cord insertion site are collectively termed placental morphological anomalies. Battledore cord insertion and succenturiate lobe formation are thought to arise from localized atrophy of trophoblastic issue in area of poor decidual vascularization. Both anomalies are individually associated with increased risk of fetal growth restriction, intrapartum fetal distress, vasa previa, cord compression, and postpartum hemorrhage from retained accessory tissue. Concurrent occurrence of both anomalies in the same placenta is exceedingly uncommon and is documented mainly as isolated case reports, making systematic risk data unavailable. My case report is a 20-year-old woman, gravida 2, para 0, abortion 1, live 0, at 39 week 3 days gestation, admitted with labor pain. Her antenatal profile was last menstrual period 9th October 2025 and estimate delivery date was 16th July 2026. Previous first trimester spontaneous abortion 2.5 months, managed by dilatation and evacuation 5 years ago. Regular ANC injection, tetanus in intramuscularly 2 dose taken. Her antenatal anti-scan was at 13 week 2 days, no abnormality detected, and anomaly scan 22 week 4 days, no abnormality detected. Her USG at 37 to 38 weeks was cephalic, placenta right anterior, grade second. Uh, Amniotic fluid was 15 centimeter. Umbilical artery Doppler raised, SD 3.47. PI index was 1.91. Uterine artery Doppler and ductus venosus normal, no notch. Her intrapartum and postpartum profile was uterus 34 week size, longitudinal lie, cephalic, head floating. Fetal heart sound was 136 beats per minute. Contraction was 1 to 2 contraction per 10 minutes. PV findings were cervix 2 centimeter dilated, 20% effaced, vertex, present part vertex, membrane was intact, pelvic clinically adequate, and station -2. Her HB was 12.2 gram per deciliter, WBC was 13,200 per cubic millimeter, platelet was 3.26 lakh per cubic millimeter. Assisted vacuum vaginal delivery of a live male infant, birth weight with 2.61 kg. Cried soon after birth and baby was mother side and well breastfed. Placental examination after controlled cord traction, placenta delivered complete with membranes intact, marginal battledore cord insertion noted, cord inserted at the very edge of the placental disc. A discrete succenturiate lobe identified connected by fetal vessel running through the membrane. No torn rupture membranous vessel, accessory lobe delivered intact. Placenta sent for histopathological examination to confirm gross finding. Microscopic findings that I found was chorionic villi section shows third trimester villi appropriate for 39 week. Villi displayed advanced vascularity and regular syncytial knot formation. No villus edema or hydropic changes are present. Trophoblast and intervillus space basement membrane show normal thickness. Intervillus space contains small physiologic fibrin deposit. No mass perivillus fibrin deposition or intervillus thrombi are identified. Decidua basalis intact, contains scattered maternal vascular segment. Cord cross-section confirm normal 3-vessel arrangement and Watson jelly surrounded by Watson jelly, fetal membrane and bridging vessel. Cross-section of the intramembrane vessel connecting to subcentuate lobe reveal patent lumen and normal muscular wall. Conclusion and clinical relevance are a genuinely rare finding coexisting battledore placenta and subcentuate lobe in the same term placenta is uncommonly reported, adding to small body of case literature. Antenatal Doppler adds value, reduce MCA resistance with a raised umbilical SD and low CPR can flag early placental compromise even when growth and liquor appear reassuring. Vigilance in the third stage include marginal cord insertion and accessory lobe raise the risk of cord complication, membrane vessel injury, and retained placental tissue with postpartum hemorrhage. Examine every placenta. Routine systematic gross placental examination at delivery, followed by histopathology, remain essential to detect these anomalies and inform counseling for future pregnancy. My key take home message is reassuring antenatal growth and Doppler parameter do not exclude placental morphological anomaly. Cord insertion site and lobulation deserve routine documentation on anomaly growth scan. Concurrent battledore cord insertion and subcentuate lobe, though rare, carries an additive risk of cord compression, vasa previa, and retain accessory tissue, warranting vigilant intrapartum fetal monitoring. Meticulous post-delivery placental and membranous examination tracing vessel to the membrane edge is essential to detect a missed accessory lobe and prevent return product of conception. Histopathological examination remain valuable to confirm
Excuse me, I
gross
think,
morphological diagnosis.
excuse
Yes,
me, I
ma'am.
think that's enough. Anyways, time is lot more and we need
Yes,
to
ma'am.
ask. You have said the
Yes, ma'am.
outcome. Can you tell me male something? You said it was a male child. What did you read? Please read. You have read some, what you have
Yes,
written.
ma'am. Ma'am, assisted vacuum vaginal delivery of a live male infant, birth
Yes,
weight
male infant.
2.61 kg.
Male infant. So back to MBBS. What is an infant? What is a newborn? Is this a male infant is born?
No, ma'am, newborn.
So yeah, male infant. I just want to ask you, you also said something ke vasa previa. Is it same? You said together. What did you say there? Ke scan to rule out. In fact, if I am not wrong, it's a differential diagnosis.
Yes, ma'am.
So why did you say together? It's a differential
Ma'am,
diagnosis to subcentuate as well as battledore. We have to rule out it is not vasa previa.
yes, ma'am.
They are not together.
Yes, ma'am.
What will
Different thing.
happen with this vasa previa? When can you diagnose this anomaly? Which scan?
Ma'am, anomalies can at fifth trimester, 5th week.
5th week of pregnancy. Seriously?
In ma'am 5 month of pregnancy. Anomaly scan, ma'am.
So TIFA scan, second anomaly scan, level 2 scan, they can diagnose it, right?
Yes,
What
ma'am.
are the risks involved with this type of anomaly?
Ma'am, it can lead to antepartum hemorrhage and postpartum hemorrhage, preterm labor, intrauterine death, abruption.
सारी चीजें नहीं बोलना, आपको जस्टिफाई करना पड़ेगा कौन सी चीज क्यों होगी, है ना बेटा? With reasons.
Yes, ma'am.
Answer is okay. Tell me why. Why will it cause preterm?
Ma'am, early detachment of cord, which releases prostaglandin and causes preterm labor pain.
Detachment of cord will release prostaglandins. Early detachment of cord, it will cause release of prostaglandins. Okay, no more questions from my.
Dr. Mayur, sir?
Can there be any other abnormality? What are the common abnormalities of placenta?
Sir, common abnormalities include placenta succintoriata, batidor placenta, velamentous placenta, and placenta spuria, and circumvallate placenta, circummarginate placenta,
How will you
placentomegaly.
examine the placenta after delivery? Show me the method of examination of placenta after delivery.
Sir, after controlled contraction of placenta by
Once it is
Brand
out,
and Rheumatic.
once the placenta is out, how will you examine? You have told that role of examination of placenta after delivery. How will
Sir,
you hold the placenta?
Sir, in palms, and I will check fetal side and maternal side, fetal chorionic side and maternal basal plate, and whether the whether the membrane and vessels and cotyledons are intact or not.
Okay. Okay.
Thank you, Annie.
Thank you so much,
respected judges, Dr. Mayur Gandhi sir, Dr. Nalini Anand madam, and Dr. Neeta Rada madam, for this wonderful session and your wonderful inputs. It helps the upcoming gynecologist in their practice and in academic session also. Thank you so much. We are concluding this session.
Excuse me, sir. Sir, sorry to interrupt, but my one co-batchmate is remaining for her poster presentation, Dr. Rajvi Nagaria.
She
She's
might
not
be
with us.
another hall.
She must be in another hall. She's not with us.
She is not here in our list. She might be in another hall.
Okay, sir. Thank you, sir.
Thank you so much, respected judges, again. And valedictory
Thank you,
is
Sonal ma'am. Thank you, sir.
yes. Our valedictory function is in hall A. So please join link from for hall A. Thank you.
Sir, do we need to submit the mark sheet or online Google form for the mark sheet?
Just a minute, sir. Yeah, you have to submit that Google form, sir.
Okay.
That you might have received on your number.
Yeah. Okay.
Yeah.
Sir. Thank you.
Thank you, sir. Good day.
Good day.